Mm.
How's it going, John?
Good morning, is that Greg? Good morning,
Oh gosh. I'm gonna
how you
mess.
doing?
No, it's all-
You're not Greg. Focus on my pictures now. I'll be in a few minutes, okay? Hello, Greg, can you hear me? Greg, are you there? Can you hear me?
Good morning, John. Are you able to hear
Oh,
me?
okay. Yeah, I was getting nervous there. I didn't, is this Greg? Can you hear me? Hi, Greg,
Good morning.
can you hear me or no? You can't hear? Yeah. It doesn't matter.
All right, I believe I can hear you now, John, if you want to try.
Can you hear me now?
Yes, I can. Thank you.
Oh, great, great. I was getting nervous there. Because if you can't hear me, you might not be able to hear the people, the virtual speakers.
Exactly. Yep, we can hear you now.
Good. Yeah, I was gonna just suggest that. How you doing? You ready for a big day?
We're ready. How are you?
Good, good. Yeah, I'm ready. Ready. I don't know. We did a lot of social media, but you guys are more concerned with the event.
Right. Yep.
Yeah, well, good morning. What's your associate's name?
Oh,
John.
nice to meet you. I'm Dylan.
Bill. Okay, nice to meet you, Bill. And John Bennett.
Nice
to meet you, So-
John. Oh, sorry.
Okay, Greg, I'll be back. You know how
All
it is. I
right.
gotta do all the little things.
Definitely. No problem. Thank you.
Okay, okay. Okay, can you hear me okay, Greg? Hello, testing, okay. Oh. Hello, Greg, can the speaker come on to test that everything's okay?
I think this is a great, tremendous opportunity for the seventh time with COVID in the middle for us to get together, to exchange information and learn from each other. But I think it's also a celebration of the work that everybody, and everybody in this room knows this as well or better than I do, that it's a tremendous team effort to take care of these patients that goes from the patient himself, herself, through our EMS, to our first responders, to everybody in the hospital and beyond the hospital. So I think that's for you guys. Enjoy these next 3 days. We have a lot of exciting talks with great speakers. But the goal for this meeting, what we try to do different this meeting is time for discussion. So don't be shy, raise your hand, ask questions. This is the goal. I'm not gonna say names because I'm gonna be unfair and I will forget somebody. You know who you are, but there's a tremendous team behind the scenes that made this all possible, from Wendy, Abby, team, and I'll stop there because I'm forgetting somebody. But the Baptist team that put this together with the hospital administration support and all our vendors that made happen financially to sponsor us to be in such a great place for our meeting. With that, I'll stop. I invite Dr. Nima. Thank you, guys. I hope you enjoy the next 3 days. Thank you.
All right, welcome everyone. I like what Dr. Hanel said, get the party started. I did also want to thank everyone for being here. Last week was Nurses Week. Week is Neuroscience Nurses Week. Very glad that we were able to do this during the week of celebration for really the hard work that you guys do, especially all the nurses. The work that you provide to our patient is greatly appreciated. As I've always said, we cannot do what we do without your work and your help. The team, that really what makes what we do unique. With that, thank you. Enjoy the day, and hope to see you guys today, tomorrow, and Friday. Wendy?
Dr. Nima, Dr. Hanel, welcome. Sorry, I don't have much of a voice today. I'll keep this pretty brief, but thank you guys for being here this morning. We really appreciate you coming out to spend the day with us. I think we've got a really good lineup on tap. It's a little different this year. We've kind of got a little bit of everything. So we've got some talks for those of you who work in the post-acute space, in the ICU, and just in the hospital. And then we've even got some program development talks today. So it's a little bit different. So we hope you enjoy the talks. There are a few announcements. So our first speaker couldn't be with us this morning. It was our subarachnoid hemorrhage survivor and her husband, but they're both ill and under the weather, so they weren't able to join us. So we've got a few changes to the lineup today, but we'll go ahead and get started. So our first speaker is coming to us this morning. It's Dr. Cassandra List. She's a physical medicine and rehab physician at Brooks Rehab Hospital here in Jacksonville. And she's going to talk to us this morning about managing spasticity after stroke.
Thank you so much for having me here today. So as Wendy mentioned, I'm Cassandra List. I'm a physical medicine and rehabilitation doctor out of Brooks Rehab here in Jacksonville. I subspecialize in neuro rehab and spasticity management. I serve as the spasticity management lead over at Brooks, as well as the stroke medical director for the stroke rehabilitation program. So with that, I do have some disclosures. I am a speaker for AbbVie, for their Speakers Bureau and their advisory board. So they are the makers of Botox. So I have received an honoraria for that. I will be discussing botulinum toxins in general. Sorry, the screen. Can you still hear me okay? Yeah, okay. I'll be discussing botulinum toxins in general for the use of spasticity, not specific to any one toxin. So I have no actual conflict of interest in relation to this presentation. But some of my comments may be off-label use for any one specific toxin. Each of the toxins has their own FDA label, so we're just going to be talking about them generally. All right, today's objectives, we're going to review current spasticity management options in relation to stroke rehabilitation, as well as reviewing the updated literature in spasticity management, specifically in relation to stroke. So what is spasticity? So we all have seen spasticity. It's a condition that may develop after a patient has had any damage to either their brain or their spinal cord. So any sort of upper motor neuron damage can lead to spasticity, which we technically define as a velocity-dependent increase in tone. This falls more into when we define rigidity versus spasticity, but it's a muscle tightness, or patients may notice it as muscle stiffness that can occur after stroke, brain injury, spinal cord injury, cerebral palsy, multiple sclerosis, hereditary spastic paraparesis, and other conditions. So these are the common patterns of spasticity, which we mainly see in stroke. Nobody's a textbook, but generally speaking, this is what we see. We see the shoulder adducted and tight to the chest, the elbow is flexed, the forearm is pronated, the wrist and the fingers are flexed, and the thumb is usually in the palm. So we get that flexor synergy pattern in the upper extremity. And then in the lower extremity, again, generally speaking, we see the thigh to be adducted. The knee can either be flexed or extended. The foot, we tend to get plantar flexion and foot inversion, as well as we'll usually get toe curling, or we may get that hitchhiker toe, as I call it, or the straight-o toe. So again, it's on a spectrum, but this is what gives us this hemiplegic gait pattern that we see, is that flexor synergy pattern in the upper extremity and the extensor synergy pattern in the lower extremity that's due to the spasticity. So what do patients actually say when they come to you and they're like, my muscles are tight? They don't say, oh, I have spasticity. They'll say, my toe curling is really bothering me, or I can't get my thumb out of my hand, or I can't stretch my fingers enough to cut my nails, or my legs keep crossing over when they're describing scissoring, or they hear me coming when I walk, and that's that toe catching. They'll hear the top of the foot catch first as they're walking. Or my brace is rubbing because my foot turns in so much. And then one patient said, I was trying to be intimate with my partner and my clonus kicked in. So spasticity can be very debilitating in all facets of life. So what can we do about it? Therapy, stretching, bracing and casting, medications, oral medications. These are usually things like baclofen, tizanidine, cyclobenzaprine, dantrolene, diagnostic nerve blocks, phenol injections, botulinum toxins, intrathecal baclofen pumps, and then surgical procedures such as tendon lengthenings. So we're not going to go through all of this today. We're going to mainly focus on botulinum toxin and intrathecal baclofen pumps. So botulinum toxins, 4 commercially available botulinum toxins currently. There are some more that are potentially coming down the line. Botox, Xeomin, Dysport, and Myablock. So Botox, Xeomin, and Dysport are botulinum toxin A. Myablock is botulinum toxin B. We tend to say Botox a lot because it's easy to say. They got a good name, but there is Xeomin, Dysport, and Myablock, and it's just important for us to know that there are multiple companies that are making a very similar product. And a patient may say, "Oh, yeah, I'm getting Botox for, for another indication for migraine or cosmetic or whatever it might be," but they may not actually be getting Botox. They may be getting another toxin. So it's important for me to know which medication they're actually getting. But when it comes to botulinum toxins, they're muscle relaxants that we inject into the muscle. So when I'm seeing a patient for spasticity, what I'm doing is I'm getting a history from them, seeing where their muscles are tight, how is it getting in the way of their day-to-day function. And as I'm talking to them and examining them, I'm coming up with a plan as to how to make their life a little bit easier. So we come up with a muscle dosing plan. We go in with about an acupuncture sized needle. I'll talk to you a little bit about the guidance. In my clinic, we use EMG guidance. So there's a little microphone at the end of the needle, and I'm listening to the muscles as I'm injecting. So I'm kind of confirming what I have come up with as the most spastic muscles, or the ones that are interfering with their function. We inject a little bit of the medication. It doesn't kick in right away. It takes a few days to a week to slowly start to kick in. Peak effect is 4 to 6 weeks, and then it slowly starts to wear off. So what I say is the good thing is it wears off, and the bad thing is it wears off. So if it works really, really well, it's going to eventually wear off. If it works too well, if it over relaxes the muscles and causes weakness, that will wear off as well. So these are things that we counsel our patients that, look, for better or for worse, it's not going to be permanent. So let's see what we can do to make your life a little bit better. And then I talked to you a little bit about guidance. So we always use anatomical guidance, right? So we've studied the muscles. We know where these muscles are, but very different practicing on a model or, when you did your cadaver labs and anatomy lab, an arm that's like this versus the anatomy of an arm that's like this. The muscles change position, they shorten, they atrophy, et cetera. So we always recommend that we use additional guidance, either EMG guidance, which is what I use in my clinic, or ultrasound guidance, so we can actually visually localize the muscles. Because we know even the most expert injectors, they're not that as accurate as we think we are without that additional layer of guidance. We talked about the gradual onset and we talked that it's not a permanent fix. It will eventually wear off, lasting about 2.5 to 3 months, but we do have to wait about 3 months between injections. So the reason for this is that if we inject a patient too often, it can work like a vaccine and then we can be immune to it. So we don't know if it's 2.5 months, if it's 3 months, but we know that the 3-month window is a safe window where the toxin is out of our body and our body is seeing it as a new exposure. So we tend to stick to that 3-month window. With that being said, we talk a little bit about that it wears off and some of the risks that higher doses can cause weakness. And I'll have from time to time a patient that comes to me and they're like, well, my therapist didn't want me to get this because it's going to make me weak and I'm trying to get stronger. I don't want to get weaker. And I'm like, wait. So it really depends what we do with the toxin, which muscles we target and what dosage we use. So I'll give you an example. I had a patient that came in with a really, really, really tight hand. And she comes in and she's like, doc, I just want you to relax my fingers. I want to be able to open my hand. I'm just constantly, trying to stretch it out and fidgeting with it. I can't clean my hand. I can't cut my nails. And I said, okay, well, this is what I ask everybody, what do you do with that hand? And they said, nothing. It's a paperweight. I don't use it for anything. I said, okay, so that tells me I can be more aggressive with the dosing, right? Because she's not using it for anything. So my goal is just to relax the hand. She comes back a few months later and she's like, well, I was able to relax the hand. It worked great. I can get in there. I'm not fidgeting with it as much. But what I realized is that when I went to grab the refrigerator door, I was actually working on my grip strength to pull the refrigerator door open. I couldn't do that anymore. So that's something that she realized she was trying to use that hand functionally without even realizing that she was even doing it. So that's where we just pulled back on the dose. The toxin wore off. We pulled back on the dose and we found a dose that worked for her. So when we talk about weakness, we're talking about weakness to those specific muscles if the dose is high for those muscles. All right. And then this is medically indicated and FDA approved. So as opposed to cosmetic botulinum toxins, these are usually covered by insurance, not an out-of-pocket cost. All right, so we'll go through a few patient cases. So this is a 43-year-old male with right spastic hemiparesis. He unfortunately had a hypertensive hemorrhagic stroke. Still really weak. He's a 0 to 5 in the right upper extremity. He has some trace hip flexor and knee extensor strength, but otherwise he's 0 to 5 in the lower extremity. So he's what we would classify as severe. Okay, he has that stereotypical flexor synergy pattern in the upper extremity and a lot of extension in the lower extremity. It's really hard to move the muscles. Family helps him to get dressed because he can't do anything on his own because he's so tight. So he has a lot of difficulties with activities of daily living and getting dressed in general, grooming and hygiene. And then he's working on taking steps, but his plantar flexor tone is so severe that he actually will step on the balls of his foot and then his leg will start to clonus. So he starts to lose balance as soon as he starts to take a few steps. So this is just to give you an example of the muscle plan that we did for him from a botulinum toxin perspective. So we used 600 units of botulinum toxin A. And we kind of tried to target the areas, in him. And I tell patients, we can't dip you in this stuff either, right? We have to kind of pick and choose which muscles we do. And so for him, really getting the arm to relax enough so that they could pull the shirt under and get under the underarm and clean. And then that elbow flexion, so the biceps and the brachialis, where they were so tight in this kind of 90-degree pattern and stuck to his body, to his chest. And then the fingers and the wrist flexors were really tight, the FDS and the FTP. And then in the lower extremity, like I said, he was standing on his toe and he was getting a lot of clonus. So we did the medial gastroc, and then his foot was also turning in and his toes were curling. So we did the toe curlers as well. So this is a bigger dose for this particular toxin, but a lot of muscles that we had to address. This is a different case. So this is so it's still a very young stroke, 28-year-old female, right hemiparesis due to ischemic stroke that was attributed to oral contraceptives. She was much stronger. So she had 4 to 5 strain throughout her right upper and lower extremity, except the dorsiflexion, she had a bit of foot drop at a 3 out of 5. When you would look at her, move her muscles around, you would classify her as a mild spasticity, right? She's somebody that would come and go out of offices and nobody would really pick it up. But what she was noticing is she had tightness in her wrists and her fingers, her thumb would come in and she was catching that foot. She was back to work. So she did really well in her recovery considering, but she was back to work. She worked at a bank. So a lot of typing, a lot of writing. And so those spastic muscles would really interfere with her day-to-day function. So again, this is somebody that even though we would classify as mild, it's severe to her because her being so spastic in those finger flexors and preventing her from writing and typing was affecting her day-to-day life. So somebody that we did a much lower dose on, but it was enough for her. And, you know, some may argue that this is even subtherapeutic, but it's the dose that worked for her in her condition because she just had that little bit of tightness in her fingers left over. All right, so botulinum toxins, I get this question a lot. When is it too early and when is it too late? Or is it too early or is it too late? So when we talk about stroke recovery, we know that people are going to go through these general stages of stroke recovery where they're going to be, there we go. There we go. And so more on the flaccid part initially, right? Not everybody goes through every stage, but generally somebody who's very flaccid is going to get some increased synergy, more in that spastic flexor synergy for the most part. And then their spasticity is going to get worse before they start to get more control of it. And again, not everybody goes through every stage. So some people get stuck more in this stage. And those are the people that you see in the community that have, their arm flexed, their leg extended. But really what we're seeing is that if somebody has a stroke, right, and they're flaccid and they just start to develop a little bit of tone, they start to break out of that flaccid period, we know that it's going to get worse. So we kind of let the spasticity declare itself because it's going to be changing quite a bit. So we're, like I talked to you before, once we do the Botox or the botulinum toxin, we commit them for 3 months. They can't get another injection for 3 months. So if they start to get tight just in the elbows, and then I do the botulinum toxin, I can't inject them for another 3 months. So then next week, their fingers start to get tight. I can't address that for another 3 months. So we kind of give it some time for it to really declare itself, but not too much time so that we can take advantage of kind of that acute period of rehabilitation. And then the question as to when is it too late? So I'm not really a believer in when is it too late. I had a patient who had a stroke about 8 years ago, pretty much has been living in a nursing home ever since, family support, but they can't take care of him at home. So he had been offered botulinum toxin 8 years ago and he's like, I don't want anything to do with it. Leave me alone. Now he comes back. He's like, I probably should have done it back then because now it's so tight and painful. And what I tell patients is we don't really know when an actual contracture develops. When does the bone actually start to fuse? We don't have good information as to, we know the longer we go in one position, the more at risk we are, but we don't really know when it actually develops. So there's always an opportunity that you may be able to help this patient. So you counsel the patient, let them know, look, you may be stuck in this position. I'm not sure, but we can listen to the muscles, see if there's muscle activity still, if there's some sort of pulling contribution where the muscle is still activating and pulling the joint in that position. So for this particular patient, his muscles are still very active, even though he's just stuck in this position. But you can hear that the muscles are still pulling. So we do the botulinum toxin. He doesn't get great range of motion. He doesn't get great functional movement, but he gets a lot of relief in that muscle tightness that drives him insane. So it's always worth trying. And what I tell patients, the worst we can do is that we go through this procedure and we don't get the benefits that we want. And then I'm not going to keep poking you. So it's good to at least have the option. But I think a lot of patients don't even get referred for spasticity management because it's been, so long since your stroke. So it's always worthwhile to look into it. All right, so just a little bit of a study that came out in 2021. So this was real world analysis of botulinum toxin injections in post-stroke spasticity, higher doses of botulinum toxin and longer intervals in the early start group. And so some facts that they put out, which I thought were important and pertinent is the prevalence of spasticity in stroke. So in the by 3 months after stroke, in those that have moderate to severe motor impairments, so strength impairments, 19% of stroke survivors have spasticity. That increases to 43.2 at 12 months and 97% for those that are after the 12-month period. So it is quite prevalent in our stroke population, especially those that have more moderate to severe motor impairments. So what they did was a retrospective chart review for comparison of early start botulinum toxin patients. So within 12 weeks after the stroke versus late start, meaning after, later after 12 weeks after their stroke. So they looked at 2,000 something charts, but ultimately they were only able to look at 47 patients that were categorized into these early and late start groups to compare the effectiveness of botulinum toxin between the groups. So just to note here, when we talk what they found in these patients or in this population, that the early start group, even though it was less than 12 weeks, we're getting botulinum toxin at about 7.17 weeks, whereas the late start, they were getting started much, much later. And something else that's important, let me just make sure. Time from stroke to admission. So this is inpatient rehab admission. So these patients were only about 3 weeks before they made it to inpatient rehab, whereas these were closer to 6 weeks. So you can assume from that probably the late start group were sicker patients. But ultimately what they found were the characteristics of these patients were very similar. So they were able to compare pretty much apples to apples as to early start versus late start. And what they found were that the higher doses of botulinum toxin were used in the early start group. So we used earlier doses if we injected them earlier, and this often resulted in a longer interval to subsequent injections. So even though we can't inject any earlier than every 3 months, the less I have to poke you, the better. If we can get results, benefits for 4 months, 5 months, 6 months, even better. I don't need the praxis, neither do my colleagues. So the less we have to poke you, the better. And so that's what we found is that if we address it, or that's what they found in the study, is that if the spasticity is addressed earlier on, you end up using higher doses, but they also last longer. Now, this isn't exactly a landmark study, but when it comes to spasticity management, there isn't a lot of data out there. It's, a lot of more anecdotal practice of experts. So it's really just one more piece of evidence that we have to support what we've been doing along the way. So that's the important part more of this study. And also that we should address the spasticity earlier rather than later. All right, we'll have some time for questions at the end, but we'll go over intrathecal baclofen pumps and then we'll kind of put it all together. So intrathecal baclofen pumps, another way that we manage spasticity. So these are hockey puck sized metal pumps that get implanted into the subcutaneous tissue, usually in the abdomen, but sometimes they'll implant them in the back or in the gluteal region. And they're placed in the subcu just right under the skin. Oops. And then there's a catheter that runs under the skin into the near the intrathecal area. So the benefit of this is that you get targeted continuous delivery of the muscle relaxant baclofen in microgram doses as opposed to milligram doses that people are taking by mouth. Okay, so you're getting a significantly you're getting the drug delivered straight to the spinal cord region where the spasticity is originating from. It's more effective because it's getting delivered right there, and you're not taking these oral doses that can make you foggy, confused, lethargic, et cetera. So we just have a lot more room to titrate and have more effect on the spasticity than we do with oral baclofen. And then so you're getting this also delivered 24 hours a day. So you're getting a continuous push, and then we can also program the pump to do different pushes throughout the day. So say, for example, somebody wakes up really, really tight first thing in the morning because they've been in bed and sleeping, and then they wake up and they're really tight, have a hard time getting into their wheelchair. We can program a push so that they get a bolus early in the morning and they're looser when they start to actually get moving. So different things that you can do to titrate the medication that you don't have the flexibility with oral baclofen. And the goal really is to improve spasticity and wean off the oral muscle relaxants, which can make us foggy. I have patients that are on very high doses of oral muscle relaxants and they're fine. I have patients that are in very low doses and they are out for the count. But what we find is even those that are fine, when we start to take them off them, they're like, I feel so much better now. I didn't realize how tired I was until we came off of these medications. All right. So, but with that being said, I say in the world of surgeries, it's not a huge surgery, but it's a surgery nonetheless. So it is a long-term commitment. And you will need, the medication does run out and that can lead to baclofen withdrawal, which we don't want. So they have to commit to coming in for refills every few months. The drug itself expires at 6 months once it's put in the pump. So we, at the very least, have to see these patients every 6 months for refills, but really it depends on what dose they're on. And then the end of the battery life, it runs in a battery. So it ends at approximately every 5 to 7 years, depending on how high the dose is, how hard the motor is working. So they are committing to future surgeries. So not just this surgery, but future surgeries. I tell patients there's a try before you buy. I'll go over the trial here in a minute, but we don't commit them necessarily to the surgery. We do go through a trial to see how they respond. And the goal is to improve spasticity management and wean off of oral antispasmodics like we talked about. And I tell patients it's not just because we use pumps and we stop using the botulinum toxin. Maybe we can relax most of your spasticity, but your fingers are still really problematic or your toes are really bothering you. Then we can just focus little bits of the botulinum toxin in those specific areas as opposed to kind of, again, trying to dip you in it. So this is the trial, the try before you buy. So the patient comes in for the day. They're taken off of their oral antispasmodics. They're given a push of the intrathecal baclofen through lumbar puncture, and then they're monitored throughout the day by physicians, providers, and the therapy team to see how they respond. So really what we're looking for, if there's any sort of weird reaction. So this is going to be one push of the medication as opposed to that continuous low dose of the medication that they're going to be getting throughout the day. So I tell patients it's not a one-to-one, and some patients may even get weak from it. It may have been that push was too much, and then they're like, oh, I don't want this. And it says, no, this is a bolus. This is a push of what we're going to do. We're just making sure that you don't have any sort of weird allergic reaction or something that we don't want to happen. And then there is an argument to be made about, do we even need in an appropriately identified patient, do we even need a trial? Again, it's really for us to understand, make sure that nothing really bad happens to these patients before we actually go to commit them to a surgery. So I will say that for intrathecal baclofen, so again, there's this kind of myth that it's only for lower extremity spasticity. It's only for paraplegics. It doesn't affect the upper extremity, and that's not true. And we have evidence to back that up. And it is perfectly appropriate for stroke patients, and appropriately identified hemiparetic patients would still benefit from intrathecal baclofen pump therapy. And so there was the Sisters trial that was done in 2018, and it was a randomized control, open label, multi-center phase 4 study. And what it was initially to evaluate the efficacy and safety of pump baclofen versus conventional medical management with oral antispasmodics in the treatment of severe post-stroke spasticity. So their inclusion criteria was chronic stroke. They had to have spasticity in at least 2 extremities, and their Ashworth had to be greater than 3. So a significant amount of spasticity in at least 2 different muscle groups in the lower extremities. And so they were randomized 1-to-1 for conventional management versus ITB. And both treatment arms received therapy throughout. And so their primary outcome was the effective ITB over conventional medical management in the lower extremity as measured by the Ashworth scale, so how we measure spasticity. The secondary outcome was any adverse effects assessed for safety, muscle tone in the upper extremity of the affected side, and then functional assessment of the functional impairment measure, the total score, which is something we use in rehab to understand their function, a patient's function. So what they found is that spasticity was reduced in the lower extremity with ITB therapy, which confirms what we already knew. We knew that it was going to help with the leg, but this is just one more piece of evidence. What they also found was that there was a significant treatment effect with ITB over conventional management and spasticity with the upper extremity, despite the fact that the study wasn't initially powered for this. So again, this was consistent with 2 previous studies that show a decrease from baseline in the muscle tone in the upper extremity with ITB therapy. So perfectly appropriate for stroke patients, even if they're just affected on a hemiparetic aspect. There were more adverse effects in the pump group, but this is to be expected. It's a surgery, so you're going to have more potential risk of adverse effects with the surgery versus a non-surgical intervention or an oral medication. All right, so that's what I got. Any questions? Yes. Mhm. Yeah, and that depends on how far out they are from their stroke. So for example, if they've, I'm seeing them and they're 6 months out of their stroke, I know that their body is still very much changing. So my practice, I see them for the initial botulinum toxin, and then I check in the first time at 6 weeks when they're having peak effect to see what worked, what didn't work, and what could be better. And then I'll see them at that 3-month mark. So 6 weeks later. After that, they know more or less what to expect. Now, some practices will see them every 6 weeks anyway. But I tend to, if it's somebody that I'm not really sure I'm going to get an accurate report, I may have them come in on an exception basis, but usually it's just that first time. So we're all on the same page as to what worked and what didn't work. I will tell you, a lot of times patient will come in at that 6-week mark and they're like, doc, I don't know, this didn't do anything. I'm not really sure that it's doing. I said, well, let's see when it wears off, because it's so gradual that sometimes patients don't even notice it kicking in. And then they notice it when it starts to wear off and they're like, oh, it was working. So it's good for me to know and plan at that 6 week and then plan for the next time. Now, I'm more expecting that my plan is going to change earlier in their stroke recovery, as opposed to somebody who's 3 years out, 6 years out, right? Because now their spasticity is what it is, right? So it may be, I have some patients that they're flex, and we're doing the elbow flexors, and then the elbow flexors get it, and now they're extended, and we change the plan. But for the most part, it's pretty steady. So those patients are more on a routine, or it's quicker to get to that routine regimen. So yeah, does that answer your question? Okay.
Guys, we have to use the microphone because we're live streaming this. So if you don't use the microphone, whoever is watching, if somebody's watching, they cannot hear. So if you raise your hand, Gustavo and the team will bring you the microphone. Thank you, Dr. List. Beautiful presentation. Any experience with vagal nerve stimulation for these stroke patients?
With botulinum, with spasticity management, or with just in general?
All the above.
Yes. So we actually just implanted our first completed protocol for a vagal nerve stimulator patient and completed her therapy. So for those of you that don't know, the vagal nerve stimulator, which we've used for other reasons for a long time, they've now found to be beneficial in post-stroke motor recovery in the upper extremity. So it's now FDA approved. It's not in a trial period. And so the patients get implanted, and then they go through a protocol of occupational therapy to try to regain some of that upper extremity strength, and the device is activated with a magnet. So with, the studies are promising as to functional recovery after stroke in the chronic period. My N of one and that I've had in clinic complete the protocol. She's really happy with her results. She's now able to cut vegetables, which she wasn't able to before, and do more for herself at home. So it's a great thing. We have been trying to push for the Vivastim people to look at it from a botulinum toxin and spasticity management and Vivastim, because we know that tightness does interfere. And that's actually another point, is that I tell patients that the botulinum toxin can't bring strength back. It's a muscle relaxant, right? So they're like, well, I want this hand to work again. I'm like, okay, well, I can't promise you that. I don't have my magic wand. But what I can tell you is that sometimes we notice that the fingers are so tight, and then it hides any active movement that we have. So then once we start to relax the fingers, whatever little bit of strength is there, we may start to see it, but I can never make that guarantee. So that's just something I counsel them on. But yes, hopefully more to come with Vivastim.
Good morning.
Good morning.
Thank you for the presentation. Just wanted to know, prior to the permanent decision for the surgery, have you guys thought of like an external device for the trial before, to really see the continuous therapy plan?
Yeah, not as of yet. That there isn't anything out there for an external device, just the one-time trial. Now, I will say, if for whatever reason the dose isn't high enough at the trial and we don't see any benefit at all, we will try a higher dose with that lumbar puncture to see if they respond. So no external device as of yet. What's that?
Maybe you can create
Yeah.
one. Thank you.
You're welcome. Any other questions? All right. Thank you very much.
Okay. Wow. Next speaker is running late. Be here, and so if you guys want to take a quick break and then come back maybe in 5 minutes, then we'll get started.
Just one more quick announcement. We have a cell phone that was lost. If you are missing your cell phone, we have it back at the tech table.
Good morning. I know there's still some people out there, but we're going to go ahead and get started with our next speaker. I would like to introduce Jessica McManus. She's a pharmacist in our neuro ICU at Baptist Medical Center. She'll be discussing management of post-thrombolytic intracerebral hemorrhages. Jessica?
All right. They said I have a little bit of extra time. I like to know what I'm doing of time. All right. So first I want to thank y'all for the invitation for me to speak. It's always nice for me to be able to come. And because not only am I just speaking on something that I know at baseline, like I like to say that even though I am a a pharmacist, I'm not an expert. So everything that I do should still make me feel a little bit uncomfortable. And so I do appreciate when I get the chance and opportunity to really dive into a topic that I know, but maybe not know at this level. So I appreciate the opportunity for y'all to invite me to speak on this. All right, for disclosures, I have nothing to disclose, but I do want to preface a few things. So this is purely applicable to patients that you deem that treatment is necessary. And this does not encompass all the antifibrinolytic data that there has for intracranial hemorrhages. So there's a lot for TBI. I will be extrapolating some of the data, but just keep in mind that this is purely going to be focused on those that received thrombolytic therapy. During this presentation, we'll talk about the fibrinolytic system and the implications that our thrombolytic medications has on the fibrinolytic system. We'll talk about the clinical guidelines and what's changed or what evidence is available since the guidelines have been published. And then we'll talk about the potential treatment options, specifically kind of focusing on the antifibrinolytic data. Lastly, I'll recommend some treatment strategies. So have you ever thought about how we call our patients stroke survivors? And 100% they are stroke survivors, right? But the term almost implies that they've won the battle. But we know that stroke is the leading cause of disability. And so a lot of them are left with disabilities that are influencing them for the rest of their life. And subsequently, they do have depression, or they can. And one of the therapies that has been utilized is art therapy. Art therapy has been found to be beneficial in these patients as it can help them express themselves. So as I was looking for inspiration for this presentation, I found a really great art therapy program in New Zealand, and it features a bunch of different stroke survivors that participate in their program. So during this presentation, you'll see art that's actually featured by stroke survivors, and I'll have some additional information about this at the end. So this painting right here, just for example, it was done by Eddie McMinney, and he is a stroke survivor. So as healthcare providers, we try to give our patients the best outcomes, and we do this through evidence-based medicine, guidelines, protocols, what have you. But what if we don't have the aforementioned? We're basically sorting through a mess of data and evidence and looking at risk benefit. But what if we don't have the aforementioned? It's like sorting through everything, right? So does that remind you of COVID? That's everybody's been through that. So I think we can all relate. This is absolutely not COVID. Not even going to try to say that that is. But when you actually look at the data when it comes to managing these patients, you're going to see that we actually have a really, really, really far way to go. The incidence for symptomatic ICH in these patients is around 7%. And when you look at the mortality or the fatal symptomatic ICHs, it's around 3%. It's not high, but still one is one too many, right? And the patients that actually have the symptomatic ICH, mortality is up to 80%. So we are looking for ways to be able to minimize that risk. It all goes back to risk benefit, right? So we have looked at different individual risk factors, and we've also come up, or I say we, but there's also been prediction models that have been made to assess whether or not we can accurately predict somebody's risk for symptomatic ICH. Unfortunately, those risk scores haven't been great. They don't really have a high sensitivity and specificity for these patients. But I do want to note that one tried and true risk factor is going to be a high stroke score per the NIHSS. But that being said, when you look at functional outcomes, there's actually data that shows that those at highest risk, so to speak, are actually the ones that are going to be most to benefit from this therapy. So there was actually a really great study that I urge you to look at if you ever are in that scenario where you're like, I'm scared to give this patient TPA, but they actually meet the criteria. When they applied a bunch of different scores that have been compiled, they found that the high-risk patients, those were actually ones that benefit. So if you don't know, this is a force plot, and the line in the middle kind of, I guess, draws the line between benefit versus harm. And you'll see with the arrow that at the very bottom, majority of them are are not crossing midline. And so that shows statistical significance in terms of being beneficial for the patients that are high risk, so to speak, for ICH to receive that thrombolytic therapy. In terms of the mechanism for ischemic stroke to hemorrhagic stroke, or just ICH, it can occur, of course, without coagulopathy. And it can also occur in remote areas. The timing of ICH is going to usually be within 12 hours, which is consistent with other thrombolytic data. And that includes for like PEs as well as MIs. However, it can go all the way out to like 36 hours. In terms of the categorization of, or I guess you could, so to speak, you can categorize these. So you can have it as a hemorrhagic infarction or a PI or parenchymal hematoma. And the hemorrhagic infarction is actually going to be within the infarct itself, whereas the parenchymal hematoma is going to be associated with ischemia and then also some reperfusion. So looking additionally at the mechanisms that are proposed, it's going to be associated again with some ischemic injury, obviously, and then reperfusion. Now, the reperfusion is really important, especially when it comes to blood pressure management. We know that patients that have elevated blood pressure and past our goal after thrombolytics are going to be at risk for ICH. So it's extremely, extremely important that we are keeping this in mind. The blood-brain barrier definitely has some involvement, and we're still getting a lot of information in terms of like almost at the biomolecular layer, right? So we know that there's an inflammatory response and possibly a genetic predisposition for these patients. But when we are evaluating them at, from door to needle, we're not thinking about, or we don't have the ability to assess those risk factors. We also, of course, have coagulopathy, and all these together can, again, be part of the mechanism of how the patients do end up having an ICH, but we're going to be focused on the coagulopathy that occurs. So I know that today's for our nurses and our nurse practitioners, and so I really wanted to focus on some of the pathophys because I think whenever I was originally in pharmacy school, I was like, oh, pathophys, let me just figure out the answers to the test questions. Pathophys is so important when it comes to treating your patients. If you don't understand it, you're not going to be able to treat your patient to the optimal extent. So I just want to review this very quickly. So hemostasis, you have two parts when it starts off with secondary hemostasis. You have the intrinsic pathway, which is the check and balance system. It's always going on. And then you have the extrinsic pathway, which is going to be in response to your trauma or like a cut or something like that. Those are going to meet in the common pathway. And that's where thrombin is going to activate fibrinogen to fibrin, thus forming the stable fibrin clot. Then fibrinolysis is the complete opposite. It's the clot breakdown. And this is where plasminogen is converted to plasma via TPA or tissue plasminogen activator. Now, I want to highlight for you all and emphasize that we do have this endogenously in our body, but we also have, that's also the mechanism of course, how alteplase and tenecteplase work. So plasminogen is going to be converted to plasma via TPA, and then fibrin is going to be broken down. It's going to go to fibrin degradation, and then fibrin degradation products, also known as FDPs. So coagulopathies that can occur, there's a few, and I want to highlight these two. So we have a reduction in circulating fibrinogen and then an increase in FDP production. And this is, again, going to be specific to our recombinant TPA products. So our alteplase and our TPA, or alteplase and our tenecteplase. Looking a little bit closer at how these occur. So we have the circulating fibrinogen, or the circulating alteplases, which is not that specific, is not as specific as tenecteplase, and it can actually cause a reduction or act on, plasminogen that's circulating, not necessarily within the fibrin clot. So that can cause a reduction in fibrinogen. Subsequently, we have the increased production of FDPs, and that in and of itself, that can actually cause inhibition of fibrin polymerization. So it can make the clot not as strong, or harder to form a new clot, as well as cause anticoagulants to occur. And this is from the fragments. There's a lot of different fragments. I think there's X, Y, D, E, and each one we're still finding out more information as to what these fragments actually do. But we know that some of them do cause or have an antithrombin effect. Looking at the coagulopathies that we have with our exogenous TPA or alteplase and tenecteplase, you'll see if you get like a coag panel that has PTT, PT, you might see an increase, but these are going to be not just like your normal like heparin type activity. No, this is actually going to be associated with your reduced fibrinogen and FDPs. So if you have an elevated INR and patient just got alteplase, you wouldn't give them vitamin K unless they had warfarin on board. So just keep that in mind. Few points that I want to stress. One is that in terms of the post-thrombolytic ICH, I want to just reemphasize that it's a low incidence, and that's going to have influence in terms of our level of evidence. The coagulopathies associated with fibrin degradation are going to be the premise to some extent of how we treat and manage these patients. So in terms of the post-thrombolytic guidelines, so they're outdated. They're from 2017 and 2015. And I'm going to focus primarily on the neurocritical care ones, but just know that they do mimic each other. And if you haven't read the stroke 2017 guidelines, I highly recommend that you do. It is a very good read and it's specific to this particular patient population. It's not like a big review like the neurocritical care guidelines are. Additionally, so what has changed since 2017, 2015? Anything? COVID, yes. But tenecteplase. So we've gone from alteplase to tenecteplase. So how does this influence how we actually manage these patients? So looking at the guideline recommendations, they say discontinue thrombolytics if a patient has a bleed. Common sense, right? Give cryoprecipitate if they have a bleed, symptomatic. And then you can consider an antifibrinolytic if you cannot get cryoprecipitate in a timely manner, or if there's some sort of, say if they're Jehovah's Witness or they're refusing blood products. Additionally, they say that you should give cryoprecipitate if it's less than if their fibrinogen level is less than 150. And they say that it's unclear platelet transfusion is useful. Now, on the flip side, I will say that the stroke 2017 guidelines, they actually do suggest consideration of it. However, I will say that this is somewhat controversial as there's at least one study that shows that platelet transfusion can increase mortality, but the data is crazy. So we'll get there. Looking at the level of evidence. So of course you don't need evidence to say stopping something that makes you bleed when you're bleeding needs to be done. So that's a good practice statement. In terms of the rest evidence, you'll see that it's very, very low quality evidence. So first we're going to focus on cryoprecipitate. So the production of cryoprecipitate is actually from FFP, if you didn't know, and it is basically precipitated out and then they gain all the factors of interest, and it's going to be basically your highest concentrated fibrinogen product. So if you look back at our pathway of our thrombolysis and coagulopathies, you'll see that cryoprecipitate works by repleting fibrinogen. Looking at the previous data that kind of brought cryoprecipitate into the picture, they found that when patients were given thrombolytics, that those that had a reduction of fibrinogen greater than 200 after thrombolytic therapy, they would be at increased risk of bleeding. However, I don't know who all has baseline fibrinogens. If you have one, that's cool. But that was something that they identified. Subsequently, there's been additional data that looked, and this is, I actually really like this study. It was in Journal of Neurologic Science. I wish they would redo this study with now using tenecteplase. But what they found is that the HIs were not associated with any sort of coagulopathies, whereas the parenchymal, parenchymal hematomas, those were associated with a reduction in fibrinogen and an increase in fibrinogen degradation products. Furthermore, when they assessed like a risk benefit or the increased odds, they found that those that had fibrinogen levels less than 250 and subsequently 200, they were at high risk. So 10 to 12 times risk of having symptomatic ICH. So when we go back to our mechanisms of hemorrhage in our post-thrombolytic patients, we'll find that coagulopathies should also be a consideration. Now, I do want to emphasize that the prediction models that have been done did not include any sort of coagulopathies that could occur. And that makes sense because, I mean, it is a pre-risk factors. You don't have this information until afterwards. The guidelines also recommend repeat dosing, and this study was also probably the largest one. It's a multi-center, so that's good, but it's retrospective, so limited. But it did have a very large patient population. And so the guidelines actually reference this study for basically 3 statements. And they found that when patients were giving alteplase and they had a symptomatic ICH, that of those that had the expansion, a little bit more, so about 10%, which was statistically significant, they had fibrinogen levels of less than 150. However, when they went and did a multivariate analysis, they didn't find that. And I think that's because there's a lot of variability when you look at the data. So this brings us to the use of tenactoclase for ischemic strokes. Should this change how we manage our patients? So again, I don't know why I would never say this. I think like rehashing studies is like not the best thing. Like in the pharmacy world, you'll sometimes see that at like conferences, like one I'm about to go to, I'm like, oh, this has already been done. What are you adding to the evidence? But in this scenario, when we've looked at alteplase, I would love to look and see repeated studies with tenactoclase. This is a great study. It was a smaller one, but it still gives us a lot of information. I really wish they would redo it. So this was actually a study that looked at the patient population from the ATTEST study. And so this was alteplase and tenactoclase, and they looked at different coagulation and fibrinolytic activity after the administration of these thrombolytics. So shown in the purple, you'll see that tenactoclase, it did not have a significant drop in fibrinogen compared to alteplase. So you can see that dotted line, that's where it's about 200 for the fibrinogen levels. So you can definitely see that there's a reduction with their alteplase. Subsequently, they did look at fibrin degradation products or FDPs, and you'll see that tenactoclase had an increase, significantly increase of these production of these. So alteplase potentially has more effect on the fibrinogen and tenactoclase potentially more effect on the FDPs. And why is that? I would hypothesize that this is going to be due to the fibrin selectivity of these products. So alteplase has a little bit less fibrin selectivity, and because of that, it would increase subsequently have an increased effect of circulating plasminogen on fibrinogen and subsequently reduce fibrinogen. Whereas tenactoclase, if it's more fibrin specific or clot bound specific, then it's going to increase or have increased binding and then subsequently have more effect and increased production of FDPs. So the question is should we be treating these the same? I want to emphasize in terms of the utility of cryoprecipitate that I could not find, and please, if y'all find this, let me know, send me an email. I cannot find anything that suggests that there is established benefit for giving cryoprecipitate to these patients. All it's based off of is purely a supplementation of fibrinogen because the patients that have had ICHs after thrombolytic therapy have been found to have lower or have a risk factor of lower fibrinogen levels. So this is extremely important. And it's a question as whether or not this is our tenactoclase use is going to have influence on the utility of cryoprecipitate, and that is yet to be known. In terms of antifibrinolytics, the guidelines just suggest, okay, if you don't have cryo, next best thing could be potentially antifibrinolytics. So antifibrinolytics, they competitively bind to plasminogen, thus inhibiting fibrin degradation. So if we go back to our scheme here, you'll see that fibrinolytics work here to inhibit plasminogen to plasmin and subsequently prevent the FDP productions. We don't necessarily know if there's a direct effect on the fragments that are actually produced. So that is to be determined. For our products, we have tranexamic acid or TXA, and then we have epsilon aminocapuric acid, also known as Amicar or EACA. In terms of the difference between the two, TXA is about 10 times more potent. Now, they use this a lot in CT surgery, so I'm going to reference that data. They also use it a lot in orthosurgery. And they found, based off of various analyses, that basically there's no difference between the two. And so this is in terms of additional bleeding, blood transfusion, chest tube output, meaningful outcomes that are assessed from a CT surgery perspective. So although it is 10 times more potent, it hasn't shown to be superior. One thing that is nice about TXA though, is that you can give it as an IV push. However, in terms of EACA or the Amicar, you have to give it as an infusion. Now, ordinarily that would be, I guess, a barrier because, pharmacy has to make it, pharmacy delays it, it's to go in the tube system that is just like archaic. And so you're just sitting there like, where's my drug? But nicely, somebody was very smart and hopefully made a lot of money off of it. But we have new devices that allow for nurses to easily pop together or call it's the advantage bowel mate adapters to put a bowel to a bag and be able to administer, just prepare it up on the floor. So it's really nice that both of these products should be available in your Omni cells. And we don't, I believe, have it right now, but it's something that we could if there's interest in using it. I know that RED does have TXA available in their Omni cells. One thing to consider is depending on your facility, you might have a really long time to get your cryoprecipitate. So if it takes a while to thaw and get to your patient, then that's delaying care. And, with anything, we want to obviously intervene as quickly as possible for these patients in a safe manner. Looking at the antifibrinolytics, the old data. So I was, again, just really disappointed in this data when I was reading it that was based off the guideline recommendation. So first was a Jehovah's Witness case report where a patient did get alteplase. And after they got alteplase, they noticed that the patient had a PICC line. And they're like, why do you have a PICC line? And apparently he had endocarditis. And subsequently, when he was being transferred to the higher level of care facility, he had a neuro change and subsequently was found to have a huge bleed. And so they gave him TXA. And he had no expansion, but he was ultimately withdrawn of care. The case report did note that the patient did have a huge stroke and they provided all the images. And, but they did say that this was not due to TXA itself. It was a culmination of the patient's original stroke. Secondly, I don't even know what you can take from this study. It's a retrospective evaluation. That was one patient that received Amicar, but they also received like FFP, cryoprecipitate, and platelets. So little can be taken away from this. Lastly, if you recall, I did mention that retrospective evaluation. That was probably one of the better that, I talked about the cryoprecipitate. They looked at of the patients that did have an ICH. They found that 2 patients did receive Amicar and they didn't have any expansion and they survived to discharge. So that's the old evidence. Can't say that the new evidence is any better. So when you look at antifibrinolytics, there's a new one that was actually done by a colleague, I would say a colleague of mine. I've done some work with her in the past. Her name's Corinne. And she looked at EACA or Amicar for the reversal of alteplase. And this wasn't just for ICHs, although there were probably more than 70% of patients were ICH patients, ischemic stroke patients. But she found that they were looking at all patients, and what they found is that their administration of Amicar was quicker than cryoprecipitate. And of the patients that actually received alteplase for ischemic stroke, 7 of them out of 10 patients were actually had an ICH or hemorrhagic stroke. So other 3 got EACA for some other reason, GI bleed or something like that. So they received it for hemorrhagic conversion and the outcomes were not great for the 7 that had the ICHs. So 5 out of 7 of them died. And of the 2 that did live, they did get EACA or Amicar within 3 hours of identification. And then both of them received platelets. One had hemostasis, one didn't have hemostasis. So it's not a lot that we can kind of connect the dots. I mean, maybe they both received it very quickly. That's about all I can take away from that. So looking at this study, and I would say probably with majority of these studies, there's a lot of heterogeneity, meaning that there's a lot of variability and moving parts when it comes to managing these patients in a retrospective term, or so to speak. So there's a lot of moving parts and we can't control for a lot of them. So it's really hard to identify what's actually working for these patients. Their definition was of hemostasis was anything or any expansion. And again, that's because they didn't just look at ICH, they looked at all bleeds. The administration, again, of EACA was quicker than Amicar, something to consider. And of the patients that survived, they did receive it pretty quickly, but that's just hypothesis generating. There's nothing that I can say that's like why they lived. Additionally, I want to mention that they also did come out with a more recent study in 2022. I didn't highlight this because I felt like it was probably going to be the same patient population plus maybe 10 additional patients. It's just kind of like rehashing old data, another publication. But if you're interested in looking at it, please do. Again, there's so much variability in this study. There's nothing that you can really take away from it. I can tell you 1 out of like 18 patients had hemostasis with cryoprecipitate. So after that, what I could find was some abstracts. And so that was kind of disappointing because abstracts leave you wanting to know more about their methods. If you have ever, had any discussions with anybody in terms of evaluating stats or just evaluating research in general, the methods section is the most important section in terms of trying to evaluate whether or not it's applicable to your patient population or not. So the methods section, and also how legit their research, methods were. So in terms of this abstract, it was looking at antifibrinolytics versus no fibrinolytics. And they found that there's actually an increase of size in the antifibrinolytic category. But if you look, so the data that's presented, it's in a mean plus minus standard deviation. So the standard deviation is a lot larger than mean. So that means that there's just a lot of variability here within our numbers. So it'd be nice to get a little bit more information here. Additionally, I'd like to know when the onset was and how quickly the administration of the drugs were, the timing, the doses. There's a lot of different questions. I'd also like to know about mortality because we can assess hematoma expansion all day long, but what about functional outcomes? What about mortality? That's what really matters. But if you're in a retrospective manner, it's hard to really assess those. So we'll use it as a surrogate marker. Additionally, this was another poster abstract, which I was really excited about, but I couldn't get the full manuscript because it was just an abstract. That was at both of these were at Stroke. I'm assuming Stroke Conference. And this was TXA versus plus cryo versus cryo alone. And this is one done by 3 large academic medical centers. And they were able to evaluate this in 30 patients over the course of 5 years. And they excluded patients that died within 24 hours. So what they found is that there's no difference comparing the combination versus cryo alone in terms of hematoma expansion, poor functional outcomes, and thrombolytic events, which I really appreciate the outcomes that they did assess. However, I still would like to know what their definition for hematoma expansion was, timing doses. I feel like that's important. And their exclusion criteria, and I also like to know, they excluded patients that died within 24 hours. That's very important for us to know about these patients in terms of what they got, what they didn't got. And then to have only 30 patients over 5 years from 3 very large academic medical centers kind of makes me think that perhaps they were trying to reduce confounding factors. So that's good, but I still don't know if that's why they had such a low attrition rate. So this is the data or some of the data that's out there, and it's not great. So what do we do with this? And from here, I think it comes into a balance of risk benefit, right? So our potential risks include thrombotic events and uniquely seizures. So seizures are pretty unique. I was pretty surprised by that. They found that, and there's a really great paper if you're interested in it, but it looked at or just basically summarized everything about TXA and seizures, but they said that how it occurs is that it's a myoclonic jerk that's followed by facial twitching and then subsequently generalized tonic-clonic seizures, but that it typically occurs about 5 to 8 hours after surgery. And they say that it's probably because by then that's where the GABA and the benzos have worn off. They say that it doesn't progress to status epilepticus, but it can reoccur. So take with what you will. The mechanism is interesting. So it comes from the rat or animal data, but then they also said that they have previously, or somebody has previously injected TXA intrathecally. And basically what they found is that it inhibits the glycine receptors and subsequently causes an increase in neuronal excitability, which leads to the seizures. We then have thrombotic risk, which makes sense. It's an antifibrinolytic. And then lastly, we have renal dysfunction. And this was in an old CT surgery study that found it with Amicar, but based off the more recent study in the ICH patients that aren't getting as much drug, it doesn't look like renal dysfunction is actually a concern. So now I'm going to go through a meta-analysis being, typically the best level of evidence, and it assessed thrombotic events as well as seizure events. So first, looking at the thrombotic events, it looked at the underlying disease states, doses, and risk of biases and things like that. And if you look at the underlying disease states for the thrombotic events, you'll see that intracranial hemorrhage crosses the line. And on this incidence, it is favoring control, meaning that TXA was actually causing harm, causing more thrombotic events. And it was so this was actually causing harm. If you look at the different types of thrombotic events, so it's breaking it up in venous, or so like DVT, ACS, and stroke. For stroke incidents, you'll see that the intracranial hemorrhage was higher for TXA, again, favoring not to give TXA. But this was out of 9 to 8 studies. And so I was interested in wanting to know a little bit more about these studies. And when you look at the studies, you'll see that the majority of the patients were subarachnoid patients, which are pretty different, right? And then also the studies are fairly old. You also note that some of the doses are extremely long. And so you have up to 2 weeks of giving Amicar or TXA. That's pretty ballsy, if you ask me. But I guess it was appropriate in 1984. But so what they found is that these 2 studies, the ones that I could find the actual results and then assess whether or not what their ischemic events were for strokes, found that they were 100% more likely to get or was suggesting that TXA was associated with stroke. Again, the subarachnoid patients in and of themselves are going to be at increased risk for delayed cerebral ischemia. So different population, especially. So it's really just hard to extrapolate this data to our post-thrombolytic ICH patients. When you look at the seizures, so this is from one study. And, So first I want to point out that the cardiac CT surgery, they were more likely to have seizures, and they are the ones that get huge doses. So you'll see here based off this graph that those that got greater than 2 grams per day and the CT surgeries, those were more likely to see seizure events. But when you look at our ICH patients, which should be at just inherent risk of seizures, they actually had no risk of, or not no risk, but they were not at risk or statistically significant risk for having seizures with TXA. And this was based off one study. So looking at that study, this was a larger, more recent study, and it was in ICH patients. This is a TICH2 study. And what they found is that there was no significant difference in seizing among the patients that did get thrombolytic therapy just for ICH, not for, antifibrinolytic therapy for ICH. And that is not including your thrombolytic ICH. This is all just extrapolating data. So just as your basic spontaneous ICH patients. And they also found that those patients, there wasn't an increased risk of stroke or TIA. So I felt like this is a little bit more representative of our practice today and perhaps our patient population, albeit they did not receive thrombolytic therapy. Got to keep in mind, they're obviously getting thrombolytic therapy for a reason, but this did not show necessarily an increased risk of stroke or TIA. So for some of my people, I know I showed a lot of forest graphs, and you may have never seen a forest graph. So you're like, what is going on? So let me summarize this. We are very limited in our data, so limited in our data for post-thrombolytic symptomatic ICHs. And so what we have to do is extrapolate some of the data to evaluate risk benefits. And in terms of our risk, the meta-analysis that I showed you, I was really excited about, and some might read it and be like, oh, we shouldn't give this to our patients, but it's really not the best representation of our practice today and our patient populations and even our dosings that we would potentially use. Whereas some of the newer evidence, such as the TICH2 study, it's a little bit more representative and better to extrapolate. So I would feel comfortable based off this suggesting an antifibrinolytic in our patients. So to summarize for the utility of antifibrinolytics in our patients post-thrombolytic ICH, low quality of evidence, It's abstracts and retrospective studies with a lot of variability. And then when looking at the risk benefit, you have to think about your actual benefit versus hypothesize, which hypothesize is just, it's there, but I don't know that there's anything overtly compelling, but perhaps we can stop the FTP production if the conversion is really close to when the patients did get the thrombolytic therapy. For death versus thrombolytic events or seizures, if I had to choose, and so like, I like when I go to the vet, I don't know if y'all, well, actually, I don't like going to the vet. Let me say that, hate the vet. But I like when I go and I don't know something about whatever they're talking about. I try to educate myself, but I like that the vet to just offer what they would do for their dog. If this is my dog, this is what I would do. It means so much to me. If it was my family member, I would be very comfortable and I would want them to get the antifibrinolytic. So questions left. So I think what the biggest question is when it comes to antifibrinolytic is whether or not this is going to be the big drug to go to if our fibrinogen levels are normal. And how does it go in terms of alteplase versus tenactplase? Additionally, if you were to do additional evidence or research in this area, influence of timing to administration, and whether or not it's when the bleed actually occurred, so early versus late, as well as your dosing. And then later down the line, we can look at maybe TXA and EACA. It's not something I'm worried about up front. We need to get more data before we start worrying about which product is better than the other. So now we're going to summarize propose a protocol, or basically a protocol for managing of the post-thrombolytic ICH patients. So obviously, I think it's still good to recognize the patients that are at risk. So that could be patients that are you're having a hard time controlling their blood pressure, or they have a really high NIH, or it's just the doctors or mid-levels perception. They just have that feeling they've seen these patients before and they're concerned. It doesn't have to even be before, it could be after they receive the thrombolytic therapy. In this particular patients, I would suggest increasing or prolonging your frequent neuro exams. I would also suggest checking fibrinogen levels, and it says 2 hours. I would say anywhere from 2 to 6 hours post thrombolytic therapy. And honestly, I think that we should probably just start getting it for everybody. And then obviously, if there is an ICH or a change in neuro exam, you should discontinue the alteplase infusion if you are using alteplase. And then remember your ABCs, C being circulation and getting the blood pressure down to less than 140. Cryoprecipitate, obviously, if your fibrinogen is anywhere from 200 to 250 or less than. And then the antifibrinolytic, I would say, obviously, if there's a delay in cryoprecipitate and you have it on hand, I would give it. And then if your fibrinogen is greater than 200 to 250, then I would give it. And then obviously refusal of blood products. And then it doesn't matter which product at this time, it would be product based off your institution. Not all places have both products. And just as a reminder of how these work, again, cryoprecipitate is providing fibrinogen, whereas the antifibrinolytic is potentially reducing the FDPs, which can have inhibition or some anticoagulant or inhibitory effects on your platelet forming. Lastly, you should also give blood products as applicable. So if their platelets end up being low, then give them platelets, red blood cells, etc. Follow-up labs, obviously fibrinogen, and then repeat cryoprecipitate. I would follow that as well, even though the multivariate analysis said that it didn't remain like an independent factor or what have you, I would still give it. CBC and then TEG. I haven't talked about TEG. I wanted to talk about TEG, but I didn't have time to. So I know that there's a talk later this week, and hopefully they may talk about, post-thrombolytic therapy and the use of TEG. I think that's something that we should also be looking at, so we can maybe gain some additional information when it comes to the coagulopathies post-thrombolytic care or post-thrombolytic. So my kind of call to you all is that we are in such dire need of research for this so bad. And so if you are interested in researching, you can literally just look at fibrinogen levels post tenactplase and publish that. There's a need for that. So there's some things that I wanted to bring up additionally in terms of evidence that would be easy for you to do retrospectively, although you have to think about a lot of the confounding variables. So if you have a protocol in place that can kind of help mitigate some of those variables that might come up for retrospective evaluation. So tenactase versus alteplase, obviously want to know about the coagulopathies. I'd love for them to redo that study, but at a larger scale. Fibrinogen post-tenactase I mentioned, and then also looking at fibrinogen alterations in FDPs. I'd love for that study to be done again, but have more patients. Additionally, as I mentioned, utility of TEG, very interested. When you are looking at your outcomes, definitely think about what's meaningful and how we can potentially evaluate what's the best for our patients. So does timing matter? And also keep in mind functional outcomes and mortality. And please, if you get your research done and you present it at a poster or like at a conference, please still try to publish it. This is very important information. And if we just leave it to an abstract, it just doesn't give us all the information that we need to know, and anything's better than nothing. Also, I would suggest we have, a lot of stroke centers within, Jacksonville area. It'd be great to get together and be able to compile data because it is a lower incidence. Being able to compile data would give us maybe a better picture of what's actually going on with these patients. As promised, so this is the Mapura, and I'm so sorry if I'm mispronouncing that, but this is the New Zealand-based art therapy program. It's really great. They do art therapy for not just those that are stroke survivors, but also those that have intellectual and physical disabilities. So if you're interested in purchasing any art, they also have normal artists, not normal, sorry, just like those that are artist enthusiasts, I should say. They are also on this program as well. And for, again, that's the website if you're interested in that. And that concludes my presentation. Love any questions if y'all have any.
Thank you, Jessica.
Absolutely, thank you.
I know we have a session, I think tomorrow about specifically the topic, but we met Monday, one of VP of Affairs of one of the clinical trials that we're running, and he's telling us about reverse pathway. We just went from TPA to TNK. He was discussing 2 or 3 large institutions that are going back to TPA because of increased hemorrhagic rates. Have you seen anything on your short observation of our TNK patients? I don't know if we're going to present any of this data, but I would love to hear your thoughts about it. What's your sense watching this closely?
No, so I just actually talking to Dr. C about this the other day, that he felt like he was perhaps seeing more bleeds. And my only thoughts is that perhaps, when it binds to the fibrin clots more specific and you're causing that reperfusion potentially, are you causing that like such a profound reperfusion that the vessels are not prepared and potentially causing a bleed? I can't say that I've seen anything statistically saying that there's an increased risk of bleed at this point, but I think it could be consideration that, we jump on a train potentially too soon, not knowing the effects. I would say it's not as bad as like your vitamin C data in sepsis, but I mean, sorry, Eddie. I felt so good about vitamin C and sepsis. I was like, I loved it. But then it just let me down.
To just continue that question, by the way, thank you, great talk. So we do have data, right? So there's been randomized trial looking at TPA versus TNK. So those are randomized. And the most recent one, I believe, was in Canada. And they did not find any increased risk of bleeding. However, we are finding that TNK can lead to more recanalization and distal fragmentation. But whether or not it's leading to more bleed, that's something that we have to figure out. The question with that is, should we change our protocol, for example, when it comes to blood pressure parameters and whatnot, when we give TNK? But great talk. Now, quick question. Practically speaking, how fast can you get a cryo to the patient?
So that was my question. I thought it took a little bit longer, but when I was talking to one of the nurse practitioners the other day, I was told it took maybe 20 minutes at Baptist to get it up there. And I thought it was honestly longer. So I don't know if any of y'all can speak to that. So it's not as long, but I mean, if we have it in the Omnicell, it's a quick reconstitution for the antifibrinolytic and administration.
For knowledge. What do you have to do to get the cryo? Do you have to perforate it, or what do you have to do?
I think do we have it already thawed? I think because maybe the pediatrics are thawed, or they have to. Okay.
Emergency situation.
And
So
I
they
will say, and I didn't have enough time to mention this, but there is recombinant cryoprecipitate that's used for a congenital deficiency. So that's also another quick reconstitution administration. My pharmacy manager would probably be really mad if I was mentioning that because it's probably really expensive. But that is another thing. So if we are finding that, yes, administration was, quicker, but there was a study that looked at it and it actually didn't show any benefit. Unfortunately, I will say that based off the studies, I'm really concerned that perhaps they were just so low and the incidence is so low that the studies just aren't large enough to find the difference between. So maybe if we can look at it retrospectively and get a good enough power, we'll be able to see whether or not there's actually a difference between the ICHs that occur. I just think it's just not powered enough. Awesome. Thank y'all.
Thank you, Jessica. We are a little ahead of schedule as the changes on the schedule today. So we're gonna take a 15-minute break. Please help yourself to refreshment. Vendors are outside. Please go visit them and we rejoin in about 15 minutes. Okay, thank you. Okay, I'd like to welcome everybody back. Hope you're enjoying yourselves. We're going to get started with our next speaker, Dr. Gutierrez with the critical care team at Baptist Medical Center. He's going to be talking about fluid responsiveness and hemodynamics.
You guys haven't even heard the presentation yet. So my name is Eddie Gutierrez. I'm an intensivist. I'm surprised to have been invited again because there's not much I know about neuro, but I think we all as ICU people like to know a little bit about hemodynamics and why we do the things we do. So hopefully I could teach you a thing or two to help you better manage your patients. Again, thanks for everybody for being here and to those who invited me, because it's always a treat to come and speak in front of a great audience like this. So today we're going to be discussing the management of fluids in critically ill patients and fluid responsiveness, because there are a lot of protocols out there that just say to give patients IV fluids willy-nilly. And I kind of want to push back against that a little bit. I'm a bit of a contrarian, and we're going to use data to go ahead and support our decisions to take care of these patients. I do have some disclosures, but none of them are very integral to this particular talk. And as some objectives, we're going to look at some parameters for fluid resuscitation and then see what works and what doesn't for fluid responsiveness. For example, giving people a bolus of fluids and just seeing if the mean arterial pressure increases. Well, that's not the best way to do this. We could be a little bit more nuanced, as at the end of the day, we're all ICU folks and we're perfectionists, and we're, part of my language, we're the badasses of critical care. So we got to actually show it. To be honest with you, when I was trying to look up the data for neuro ICU, there's not much data. So we're just going to try to piggyback on some data from other patient populations and find a way to integrate that into our management of neurocritical care patients. So let's start this party off. I know it's early, 9:55 in the morning, but it's still a party. We're all here. This is not vodka, I promise. And let's start it off with a case so we can kind of get our heads wrapped around what we're going to be discussing. So we have a patient who's 186 years old in the emergency department, okay? They kind of look like that. Their BP is 60/40. They have a heart rate of a $120, and they have a lactate of 126, a whole bunch of lactate. Then you check their UA, and they have positive nitrites and leukocyte esterase, and all the WBCs, it's all in that UA. Oh yeah, we're in a neuro conference, so they're also aphasic and have a facial droop, okay? We have to make it relevant to our population here watching the presentation. So what's the first thing we do? Show of hands, call hospice? Yeah, I know that's what we want to do, but we can't. Give fluids, start the patient on vasopressors, or in this case, call a code stroke, right? I'm telling you, this presentation didn't look like this until it was a neuro presentation, because I would never call a code stroke. But nonetheless, we're going to go ahead and give these patients fluids. That's the first thing we're going to do when we have a patient who's hypotensive. And again, it's supported by a whole bunch of data and what we do in our clinical practice. Give fluids. Blood pressure is not pretty, give fluids. But is that necessarily the right thing to do? And that's what we're going to evaluate here. Because when we look at septic patients, what percentage of septic patients are actually fluid responsive? This is something we need to ask ourselves. Is it 10%? Is it 50%? Or is it 100%? Our guidelines say to give everybody 30 cc's per kilogram, right? That's what they say. But only 50% of patients are fluid responsive. We make ourselves feel like we're doing something by giving patients fluids, but, you know, and we should give fluids, right? It doesn't really cause much harm, but at the same time, we have to know that it's not necessarily benefiting our patients based on data. And again, just to reemphasize, only 50% of patients who are septic are actually fluid responsive. Another thing I like to teach is the fact that fluids that we infuse to patients are not the amount of fluids that are retained, okay? And for some perspective, if I were to give those of us in the room, hopefully healthy individuals, a liter of saline, let's not talk about saline, we'll give LR or Plasmolite, give a bolus of fluids 1 liter, and after 1 hour, how much is still going to be in the intravascular space? 320, half, 680, or the whole liter? Well, we end up extravasating the vast majority of the fluids that we give patients. So we only keep 320 cc's out of that 1 liter. The rest of it goes into the lungs, goes into the tissues, doesn't really benefit our patients. So this is the data to support that, because again, everything I say has a reference, because, you know, this is evidence-based practice. So only 68% is extravasated, only 32% is retained. Now, if we have a critically ill patient, those patients that we take care of, and we give them that same liter of fluids, after an hour, how much is going to be retained? Obviously less than the 320. The answer here is only 200 cc's. So most of the fluid that we end up giving our patients just goes away. It causes them no benefit whatsoever, even though it makes us feel warm and fuzzy inside because we're actually doing something, right? And this is the data to go ahead and support that out of some nephrology journals. Now, the other thing to consider is that within 20 to 30 minutes, 50% of what they receive is already gone. So if you're going to give a patient fluids, you need to give it fast, okay? Because that's the way that you're going to change your stroke volume. And I'll get to that more in a second. Now, looking at septic rats, I know we're not rats, but we have a similar physiology. After 3 hours, less than 5% of all the fluids that these rats got was already extravasated. So most of the fluids we end up giving patients is kind of pointless at the end of the day. So something to keep in mind. So I know we're feeling like this kid because we know that giving fluids is less useful than what we really think, but we need to take a step back, kind of figure out why we do these things and be like mama right here, help the kids stand up, and then everything's going to be A-okay. We can just move on with our lives. And again, we have to remember why we go ahead and give patients fluids in the first place. And the whole thing is that we want to increase cardiac preload on our patients. And in turn, what's that going to do? Increase the cardiac output on our patients. If we're not trying to do the cardiac preload increase, then what are we doing? So one thing I want you to all learn and leave this room, I'm sure you learned it at some point, but you may have forgotten it, is this equation, which if you don't have any tattoos, this might be your first one, which is that the MAP is equal to cardiac output times systemic vascular resistance plus CVP. Hopefully everybody's well aware of this equation because we could do all of critical care hemodynamics just with this particular equation. You'll knock out 99% of what you need to do just with this equation. And CVP right now for all of us is basically 0-ish. So therefore it's negligible. That's why we even simplify it even further. If you don't want a big long tattoo, you can have a shorter one where MAP is equal to cardiac output times systemic vascular resistance. And bringing it down even further, cardiac output is heart rate times stroke volume. So far, so good. We're on the same page. Cool. So who's guilty of doing this at one point or another on the pump? Okay, I'm seeing some hands raised. And you know what? I used to think that this was good enough, but don't do this. Here's why. I already taught you the concept of how we extravasate fluid faster than it goes in, right? But then in addition to that, if you want to give a liter of fluids, you run at 999, it's going to take an hour. You're not going to give the fluids fast enough to actually change the stroke volume on the patient. So then what are you doing? You're just doing nothing, basically. You make yourself feel like you're doing something for the patient, but in reality, you're not. So we're actually changing protocols in the hospital so that, and this falls on the physicians and APPs, of course, because we have to give the nurses the orders to be able to use either anesthesia tubing or to use some sort of pressure bag in order to deliver these fluids. So we have some responsibility in this as well. And as a matter of fact, on the sepsis committee, we're actually changing the protocols to say the 30 cc's per kilogram, we should give it via pressure bag or anesthesia tubing or, a little gun that's hanging out around there that many of you have played with before. So another thing I always like to say, if we're going to be taking care of critically ill patients, we have to understand some of the basic technology that we have in our ICUs every single day. And this comes down to the oscillometric blood pressure cuffs, okay? When we look at a monitor, for example, these are the monitors, there's my reflection on it because I'm taking a picture of the screen. Yeah, I had the same haircut. Anyway, so you see this monitor, you see a patient's hemodynamics, they look fine. But when you look at the blood pressure down at the bottom, which one is the most accurate number? Is it the cheater? You've hung out with me before, haven't you? I'm just kidding. So we have the systolic blood pressure, we have the diastolic blood pressure, and we have the MAP, okay? The key thing here is that when we were all in nursing school and in medical school and in nurse practitioner, PA school, et cetera, we all took care of patients using the basics, basically a stethoscope on the brachial artery and the blood pressure cuff, and we inflated it, and we had the Korotkoff signs. The first time we heard, Korotkoff sounds. The first time we heard was the systolic blood pressure. The last one we heard was the actual diastolic blood pressure. So far, so good, right? This isn't weird to anybody. And then you would go ahead and do this equation, and then you would get the mean arterial pressure, right? But when it comes to the technology that we use every day in our hospitals, it doesn't have ears, okay? That's something I like to tell people who argue with me when they try to calculate the MAP off of the numbers that are on the monitor, and it's completely incorrect. Well, these cuffs that we use that we use in all our ICUs and throughout the whole country and throughout the whole world for that matter, they don't have ears. So they don't actually pick up what the systolic and diastolic blood pressure is. What does it pick up? Well, on the bottom of the screen, you see the oscillations, and the place where it has the largest amplitude of these oscillations, that's the mean arterial pressure. Then what happens is that the device, using some sort of patented protocol, goes ahead and generates a systolic and diastolic blood pressure. That's the reason why if you have at any point tried to actually calculate the map off of the numbers, you'll find that, hey, it's not the same thing as the map on the screen. And it's not that you're smarter than the machine, it's just that, you know, we didn't understand how the machine works. So in those cases, whenever I'm taking care of a critically ill patient, I'm looking at the map on the screen. I'm not looking at the systolic, say, oh, but Eddie, you know, the systolic is 80. I'm like, what's the map? Oh, the systolic is 140 and their diastolic is 40. What's the map? You know, that's what I'm looking at when I take care of these patients. And they've actually done studies looking at this, okay? This is not me making it up and coming here to change your practice. Even though I am trying to change your practice, I'm doing it based on data, of course. So they've tried to look at the differences between the mean arterial pressures, between doing it measured and actually calculated. And what they found is that there is a difference between what's calculated and what's measured with regards to the map. And what they did is that they crunched all these numbers and they found that they cannot use them interchangeably. So please just trust the number that's on your monitor. That's the number that is correct. So again, trust the map. Now, we give patients fluids, but there are issues with giving patients fluids and turning them into the Michelin man and the Michelin woman, which is something that we're not doing as much as we used to, but we still do see it every now and then. To be honest with you, patients do not need 9 liters of fluid. They really don't. There's probably something else going on that we're missing. Okay, because we end up trashing a bunch of organs in the process of resuscitating these patients, and we end up doing more harm than good. So we cause issues to their lungs, their heart, their GI tract, as well as cosmetically with tissue edema, where they end up weeping and all those things. It's kind of disheartening to see that take place these days. With regards to the lungs, we end up causing pulmonary edema, putting a bunch of water in there. We can't oxygenate them, we can't ventilate them. Their chest wall mechanics goes out the door, and you have an increased work of breathing for the patient. So don't trash the lungs. When it comes to the heart, you end up having decreased contractility. You think you're doing a patient a favor by giving them some preload, but at the end of the day, you reach a point where there's too much. They end up having diastolic dysfunction. And then they also have conduction deficits where they go into AFib, have other sorts of blocks, et cetera. Why? Because that myocardial tissue is swollen. Don't do that. With regards to the belly, you know, there's only so much real estate in there. You can give patients AKI, cause their liver to go bad, and you also end up pushing up on the lungs. You have decreased lung volumes for these patients. In the GI tract, this is something that we often ignore because, you know, it's not directly measured, but patients do end up developing ileus. They're not going to absorb as much nutrition, et cetera, or their medications for that matter, because they have all that gut edema. There's translocation of the bacteria, there's congestion in the liver, and if the patient has a belly wound, well, they're not going to heal properly. But all these things look fine and dandy, but you might say, okay, Eddie, but where's the data that we're actually harming these patients? And in this retrospective data shows that we do end up causing an increase in hospital mortality by giving patients too much fluids. Not only that, we put our patients through more procedures by giving them so much fluids. Those procedures include thoracentesis, paracentesis, et cetera. And when it comes to those people calculating metrics in this room, well, we end up having more ventilator-associated events. We have to increase the PEEP, we have to increase the FiO2, we end up doing more cultures, more bronchoscopy. Why? Because we think it's pneumonia when it's really just fluid. So how is it that we decide to actually give fluids to our patients, right? Well, that's kind of like a tricky question because, again, our first reflexive measure is to go ahead and give these folks fluids. But are we actually increasing the preload on these patients? And this is where I'm going to introduce the concepts of dynamic versus static parameters for fluid resuscitation. The way I like to explain it to be a little bit easier is that the static ways of assessing for fluid responsiveness are the things that we used to do several years ago and some things that we end up doing today. Examples of that is checking CVP, central venous pressure. Doesn't work very well. If I could do a whole lecture on that for an hour talking about how CVP sucks. It's okay for cardiac surgery, for my cardiac surgery folks who are hanging out right here and back there. But for resuscitation and fluid responsiveness, even doing delta CVP doesn't work. Other things is urine output. Other things include checking lactates. Those things are static markers for resuscitation, not dynamic. Okay, dynamic stuff is checking for a change in the cardiac output, change in the cardiac index, a change in the stroke volume, pulse pressure variation, stroke volume variation, delta SCVO2, things of that nature that I'm going to be discussing shortly here. But how is it that we know that the old school stuff doesn't work, and instead we should be doing these dynamic parameters? Well, the Surviving Sepsis campaign, which we know is never wrong, right? Just kidding, obviously, you guys picked up the sarcasm. Well, they suggest using dynamic instead of static parameters to actually resuscitate patients. And one of the studies that they used to guide this was a stroke volume-based guideline where they found that if the patient had an increase in their stroke volume by 10% or more, that those of us in Baptist have the ability to do this. We have the technology in-house. We don't have to buy anything new. But if the stroke volume increases by 10% or more, then this patient is fluid responsive and they'll tolerate more fluids. But what happens if the stroke volume does not go up by 10% or more? Stop. You're not changing preload. So doing it again and expecting a different result is insanity. So that's where you kind of stop and you try again later. And what they found by doing these studies and by looking at these patient populations that received either stroke volume-based care or usual care, which is basically flood them with fluids, is that those who got stroke volume-based care had a better fluid balance, 1.7 liters versus 5.6. That's a big difference of almost 3.5 liters. Don't make me do public math because I think I just got that really wrong. In addition, the patients had a shorter length of stay. So if you're counting pennies with how many days people are in the hospital, you save some days here. Fewer patients ended up on the vent. Wonder why? We weren't drowning them. And then they also had less time on vasopressors because this gets a little bit physiological, but we have to remember that IV fluids damage the glycocalyx and the endothelium. We could talk about that at a later time, but it actually causes more vasodilation. It causes a greater decrease in the SVR. So that's a little bit more advanced, but nonetheless, it is something that we have to be aware that takes place. So if you're trying to tighten up those pipes, giving fluids is not necessarily the case. That's why when somebody has an SVR that's extremely low, well, they might not need fluids, they need pressors. Just a management tip. And then in addition to that, fewer patients in the study require dialysis. People will have a tendency to think that more fluids is good for the kidneys, but hey, there is the possibility that we're actually causing harm to these patients by giving them so much fluids. So keep that in mind. Overall, the difference between these patient populations was about 2 liters, and they did better. So if you're still not convinced, there was a systematic review and meta-analysis that looked at comparing static versus dynamic resuscitation. And what they found is that there was a 41% decrease in risk of mortality by using dynamic instead of static. So just something to consider if you're not doing this in your practice to resuscitate hypotensive patients. Other benefits include a decreased length of stay in the ICU, as well as decreased duration of mechanical ventilation. So this is the part where I want you to just wake up for like 2 seconds because it's going to be really boring. Okay, because if we're going to discuss how we figure that these things work, we have to look at the sensitivity and specificity of these tests. And there's a way to simplify. I'm going to possibly butcher this by oversimplifying, but don't get mad. It's just communicating. But we're going to talk about the area under the receiver operating curve, right? You want to figure out, relatively speaking, how sensitive and how specific a test is, basically how good it is at reaching its end goal, excuse me. So if you have an area under the curve of 0.5, it's a coin flip, right? It doesn't really tell you if it works or if it doesn't work. 0.7 to 0.8 is considered to be acceptable, like that test is okay. 0.8 to 0.9 is considered to be excellent, but you really want your tests of any type of test, like these high sensitive troponins and all that have come out. I drill the reps by asking them what's their area under the receiver operating curve compared to like the previous ones, and they get upset at me. But nonetheless, if it's greater than 0.9, it's considered to be outstanding and the gold standard of tests to figure out if something works. So when we actually go ahead and define fluid responsiveness, I already mentioned these, to do a passive leg raise or a fluid challenge, and you want to see the stroke volume increase by 10% or more, cardiac output or cardiac index. And sorry, you guys need something to measure this, right? Because otherwise you're going to be doing it kind of blindly. You want it to go up by 7 to 15%. I usually choose 10% because it's a little bit easier to do math with 10 as opposed to 7 or 15. And then there are also other technologies like stroke volume variation and pulse pressure variation. I'll show you how to do pulse pressure variation at the monitors that we have at Baptist so that, you know, you don't need any fancy device for that. And using these different parameters, we'll be able to determine if somebody's responsive to fluids or not. So where do we start? Well, you can either do a passive leg raise, and every time I say do a passive leg raise, everybody kind of just shudders because that's like a lot of steps and you have to move the patient and all that stuff. So we'll just stick with the fluid challenge, even though I will teach you how to do a passive leg raise in case you're interested in doing something sexy or a fluid challenge. And if you're going to do a fluid challenge, how much fluid should you provide the patient? Should you do 250 cc's, 10 cc's per kilogram, 500 cc's, or a 100 cc mini bolus? And I know you guys are seeing that 100 cc mini bolus and you're like, what? What are you doing here? So they actually looked at this. It's actually pretty interesting. I don't do this in my practice because it's pretty cumbersome, so I'll go through it pretty quickly. But basically, they got 50 cc syringes and just hammered them into the patients while they were doing an echocardiogram and looking at how their stroke volume changed on their heart. And basically, the area under the curve was 0.92, which is considered to be outstanding. But pretty neat. You don't need a whole bunch of fluids to see if somebody's fluid responsive or not, is the bottom line of that. So passive leg raise, and I already see people starting to like, okay, I don't want to do that in my practice. But the thing is that you're giving patients about a 300 cc bolus of IV fluids with no risk whatsoever of overloading them. And it also could be used in patients who are either spontaneously breathing or patients who are on the vent. And you could also use it on patients who have an arrhythmia, because other parameters, you cannot use it on patients with an arrhythmia. So what should the head of bed angle be when you get started? Does anybody know this answer? Well, this cat knows the answer. It's 45 degrees. So cat chilling 45 degrees, that's how you start your passive leg raise. So start at 45 degrees, you have some sort of monitor that's telling you what the stroke volume is, what the cardiac index or cardiac output is. And then you go ahead and you bring the head down, you bring the legs up, and the whole time you're measuring the stroke volume of the cardiac output or cardiac index. And you give it a couple seconds there, you're measuring that in real time. And if there's an increase in the cardiac output, stroke volume, or cardiac index by 10% or more, well then, hey, you have a positive test. That means you can give the patient more fluids and they're going to tolerate it well, they're not going to have any issues, and they're going to benefit from it. You should see that once you put them back up, you're going to see that the cardiac output, cardiac index, or stroke volume falls back down to baseline. Then you give the fluids and you'll see the same response, which is pretty neat. It should take less than 5 minutes to complete. It's a positive test based on those parameters there that I mentioned to you just now. And if you have a negative test, don't give fluids because, you have a negative test. For some tools, like I said, you're going to have something to measure the cardiac output, cardiac index, or stroke volume. If you have somebody who is handy with an echo probe, then they could do it as well. They could do the calculation, and you should go ahead and take these measurements before, during, and after the passive leg raise. Okay, the elephant in the room, of course, is the fact that it's invasive. If you're going to use it doing a PA catheter, it's also labor intensive. And these days where, all our nurses are trying their best with what they have, it probably isn't feasible. It's also operator dependent if you have somebody who knows how to do echocardiograms, but you also might need some sort of technology, whether it be bioreactance or pulse contour analysis, or you could also use end-tidal CO2, but I'm not going to get into that too much here. Other limitations is that you should not hurt the patient while you're doing this process. So for example, in the cardiac ICU, it's CT surgery, moving the chest tubes around, it's not going to be pleasant for the patient. So that's why we don't do it there, because you want to try to not increase the heart rate in the process. And you should also be careful in patients with intra-abdominal hypertension. So does this actually work though, right? Because it seems like a lot of steps. So does it actually affect the cardiac output? And it turns out that the area under the curve is 0.95. This is why this is the gold standard to decide if somebody's fluid responsive or not. Does it change the stroke volume? Well, instead of doing cardiac output, like I said before, you could change it to stroke volume. And in the FRESH trial, they actually showed these data. This came out in COVID time during the summer of 2020. And they actually found that patients received fewer fluids if they did passive leg raise with stroke volume, about 1.4 liters difference. But here are the cool benefits that they found in the study that was published in CHEST. Less fluids, but patients got less dialysis. They also had fewer requirements for mechanical ventilation with a number needed to treat of just 6.1. But the really cool thing that fascinated with me about this study is that more patients were actually discharged home as opposed to getting discharged to a nursing home or an LTAC or like a rehab with a number needed to treat of just 5. So treated 5 patients, one of them ended up going home instead of going somewhere else. So that's a pretty neat finding from these data. Can we look at the blood pressure instead? And I gotta admit that I didn't always know what I was doing when it came to actually resuscitating patients. And I used to think that, hey, let's just look at the blood pressure and see what happens, right? I'm smart, we can do this. Yeah, no, wrong. The area under the curve is 0.65. So it's slightly better than a coin flip. So don't just look at the blood pressure. You actually need to look at the stroke volume, cardiac output, or cardiac index. Cool? Cool. So can we look at the BP instead? No, is the answer to that question. And as a matter of fact, we've been trying and we've been working hard with our cardiac surgery colleagues to actually implement a protocol that uses boluses of LR to resuscitate patients after open heart surgery. And, we're working out the kinks of it and all, but this is the actual protocol that to some extent we're trying to implement in our CVICU in 4200. So that's a little bit of how we're actually tying this into our management in the ICU. And the MSICU also has a sepsis protocol that is quite similar to this, because at the end of the day, hemodynamics is hemodynamics. It all comes down to that equation that I mentioned earlier. Passive leg raise in the neuro ICU. Right? You think this would be kind of counterintuitive because these people have head problems, right? Yeah, head problems. And they actually looked at it in patients with traumatic brain injuries as well as subarachnoid hemorrhage. I got to admit, it was really hard to find data on this. I had to skewer the depths of PubMed. But I did find that when they did passive leg raising on patients, which, by the way, I'm not recommending this. Please speak to Dr. Naval, Chimasani, all these people who know what they're doing with the head. Don't look at me. I didn't tell you this. Okay, but at the end of the day, they found that these folks' ICP did return to baseline. And they also found that the cerebral perfusion pressure after the passive leg raise did return to baseline. What to do with that? No comment, but just know that somebody has tried it before. Now, moving on to some other parameters, which include pulse pressure variation and stroke volume variation. And these all have to do with the whole heart-lung interaction, which if I tried to explain it to you, we'd be here for another 45 minutes. And I see my timer is clicking down there and I don't want to get that far. But nonetheless, it has to do with the pressure between the lungs and the heart, how it's all enacted during inspiration and expiration. And you have a pulse pressure min that takes place in expiration, and you have a pulse pressure max that takes place during inspiration. And there is actually a way to check for pulse pressure variation on our monitors. We do not need any sort of fancy technology on the side. So this is a monitor in one of our ICUs. My reflection is not on there, so you can't verify it was me taking the picture. And you see my finger on the bottom left, right of the screen. Click on main setup. Then you're going to click where it says measurements. You're going to scroll down a little bit. It's going to show pulse pressure variation there. You're going to change your input from the blood pressure cuff to the actual A-line. So again, the patient needs to have an A-line to do this. And then like there, it's going to say ART. And then it's going to start populating on the screen after several cardiac cycles so that it can actually take the measurements and the calculations. And so here, for example, is a pulse pressure variation on a patient of 12. So what should be your go-to number for pulse pressure variation? Well, if the pulse pressure variation is 13 or lower, then your patient does not need fluids, okay? They're not going to be fluid responsive. If it's greater than or equal to 13, you should provide a fluid challenge for the patient. You should give them either do your 250 cc bolus, 500 cc's, whatever you think is going to be beneficial for that patient. And then you assess the pulse pressure variation after that. And so you say, okay, well, this is too good to be true, right? We have this in our monitors. Why don't we do this more often? Well, unfortunately, it has to do with patient selection. Patients need to be on mechanical ventilation. We can't hook ourselves up and try pulse pressure variation, or patients who are spontaneously breathing. Patients need to be either deeply sedated or paralyzed, because you don't want them have them bucking the vent or fighting the vent or pulling more tidal volumes. That will all affect the measurements. One of the things that we've tried to enact in the cardiac ICU, in the cardiothoracic ICU, is that when the patients come out of cardiac surgery immediately, if you populate that number, you don't even need to wait until the swan box and all those things are set up, because you could generate pulse pressure variation immediately upon arrival to the PACU after cardiac surgery. Patients also need to have a tidal volume of 8 cc's per kilogram or greater. They can't have an arrhythmia, and they need an arterial line in order for these numbers to all work. So sure, now you have all these boxes checked off. This better work, right? Like, you have to have a very, very solid patient population for this. And the area under the curve is 0.94. So it's outstanding. It's fantastic. If you have the ability to do this on your patient, you definitely should. Okay. My 2 cents on that. Now, if you try it on spontaneously breathing patients, such as ourselves in this room, well, the area under the curve is 0.29. So it's not good at all. It's basically garbage. So don't try it. I've seen clinicians who try to tell me that they use it as a trend. I'm like, no, sorry, respectfully so, show me why this works, because the data does not support it. What if you use a tidal volume of less than 8 cc's per kilogram? Let's say it's a patient who's an ARDS and you can't push them up that high. Well, then that drops their area under the curve to 0.82, which is not as fantastic as the 0.94 that we saw earlier, but it's still pretty good. So you could potentially consider using it. And again, this is new data that came out just 2 years ago. That shows that you could use this on patients who have lower tidal volumes. Another technology we could use is stroke volume variation. It has to do with the same exact mechanism, the heart-lung interaction that I mentioned earlier for pulse pressure variation. But what happens here is that underneath the arterial pulse curve, you're able to get a cross-section and basically calculate the stroke volume from that. And it is very good at predicting fluid responsiveness with a correlation coefficient of 0.72, which is considered to be highly positive, and an area under the curve of 0.84. So it's still a good test, not as good as pulse pressure variation if we're using actual statistics here, but it's still something we could do. Again, certain criteria, just like pulse pressure variation, need to be met for stroke volume variation. You can't use it in spontaneously breathing patients. The patients cannot have a cardiac arrhythmia. This kind of becomes a maybe, whether you need low tidal volumes, but the truth is these patients do need some sort of device. We can't use it with the monitors that we have at our institutions, without using an adjunct. So looking at stroke volume variation in spontaneously breathing patients, again, people tell me, oh, we use it as a trend. No, you can't use it as a trend. The area under the curve is 0.51, means it's a coin flip. You don't know if it's giving you the right numbers or the wrong numbers. It's just trash, for lack of a better term. But new data has come out looking at using stroke volume variation in patients who have a tidal volume less than 8 cc's per kilogram of ideal body weight. And here the area under the curve actually increased to 0.9. So, these are things that you could use to help determine whether somebody's fluid responsive or not. They have very good sensitivity and specificity. So just things to throw into your arsenal. Any data for neuro ICU for stroke volume variation? Do you guys think there's any? There is. So they actually looked back in 2014, looking at patients with subarachnoid hemorrhage to determine fluid responsiveness. And they actually found that it was a lot better than using CVP. But then again, spoiler alert from earlier, I had already told you the CVP was kind of trash. But nonetheless, the area under the curve here is 0.86 to see if somebody's fluid responsive or not in subarachnoid hemorrhage patient populations. So it's just something to keep in mind. CVP had an area under the curve of just 0.4. So again, not something you should be using in your practice for this purpose. The other thing is that there was improved cerebral oxygenation once the patient was appropriately fluid resuscitated after their subarachnoid hemorrhage. Something else that many of you may not be familiar with is something called end expiratory occlusion test, or EXPO. This is similar in a way, similar way to determine fluid responsiveness in patients. You want to kind of see, you want to hold the patients, you want to do an expiratory hold on their patient, kind of like if you're measuring for intrinsic PEEP. And while you're actually performing this hold for 15 seconds on the ventilator, if you have them on some sort of monitor, you will see an increase in their cardiac output. Again, it has to be held for at least 15 seconds. So again, you have their baseline cardiac output. You're going to do the hold for 15 seconds at least. And you're going to see, as that little box shows kind of in the middle of the screen there, that your cardiac output is going to increase as you're doing the expiratory hold. Then you're going to, if you do see it go up by 10% or more, whether it be cardiac output, stroke volume, or cardiac index, then you know the patient's going to be fluid responsive and you could just hammer them away with fluids. And, you just double check all that stuff works. You can keep on doing the expiratory hold until the patient's no longer fluid responsive. Pretty neat, right? Has anybody ever done this in their, all right, cool. At least it taught you one thing. Good, good, good. So, okay, show me the data. Does this actually work, right? And they found that the area under the curve for using this for fluid responsiveness was 0.95. So again, it's fantastic to determine if somebody's fluid responsive or not. So good stuff. There are limitations, just like everything else. There's no one test that's fantastic for everything because the patient needs to be intubated. The patient also cannot interrupt that 15-second expiratory hold. So if somebody has a metabolic acidosis and they're fighting the ventilator, doing a 15-second expiratory hold is not going to work. They're going to trigger the vent because they're going to want to breathe. So keep that in mind. They also have to be on the 8 cc's per kilogram of ideal body weight. And you can't use it in ARDS patients nor in prone patients because, of course, you're going to be crushing the chest to some degree. So keep that in mind. Now, overall, there isn't much data just looking at neurocritical care patients when it comes to fluid responsiveness. That's why we have to piggyback on the concepts of sepsis, cardiac surgery, cardiogenic shock, et cetera, because at the end of the day, we're all just humans who need fluids to some degree. When I looked up all these data, they were very skittish, so to speak, when it came to making recommendations for neurocritical care. And things that they wanted to recommend, of course, included targeting normal bulimia. Okay, makes sense. Don't drown your patients. Cool, we all agree with that. They also recommend a multimodal approach to make the patients to optimize fluid therapy. So in that case, don't just go by the mean arterial pressure, guys. Don't just go by urine output. Don't just go by lactates, et cetera. You need to be a little bit more, we need to be a little bit more in tune with all the different facets of hemodynamics to properly take care of these folks. They consider using arterial blood pressure and fluid balance as the point of optimization of the patients. I kind of have a hard time with this. And the reason why is because, for example, in the neuro ICU, patients who have strokes, subarachnoids, et cetera, some of these folks have a higher blood pressure at baseline than the buck 20/80 and the map of 60 that we try to target on our patients. So the reality is that some patients might need some augmentation. In our cardiac ICU, as well as in the medical ICU, there's data to support hitting higher map targets than just 65. I know that the surviving sepsis guidelines, for example, say 65 is the way to go for everybody, but we know that this is not accurate because, again, there's data that has been published that shows that augmenting these folks to a map of 75, for example, causes fewer renal outcomes, such as need for renal replacement therapy, dialysis, et cetera. So if we want to save patients' kidneys, some of them may benefit from higher fluid balances. The other thing that they suggest is utilizing cardiac output. Hey, look, we talked about that just now. One of the other things I wanted to mention is using SCVO2, which, SVO2 is obtained via a swan, but you guys don't float swans in the neuro ICU patients. I don't blame you one bit. Probably not the best place for it. But you could also use the SCVO2, basically obtained from the central line, a mixed venous blood gas, for example, from a central line, because you could actually determine if somebody's fluid responsive or not based on this number. And the way that you do it is that you check the mixed venous gas on a patient from their central line. And if you see that the SCVO2 increases by 4% or more, then that patient is fluid responsive. Why is that? Well, we have to remember that SCVO2 has to do with oxygen delivery and oxygen demand, right? And amongst the oxygen delivery component, there's obviously the oxygenation, the cardiac output, and the hemoglobin concentration. So if your oxygenation is constant, let me not pick the wrong finger. If the oxygenation is constant, and the patient's hemoglobin is also constant, then what do you have? Cardiac output. So you could actually assess the cardiac output, again, not by using any fancy machines, but just by checking mixed venous blood gas from the patient's central line. You check it, you obtain a baseline, you give your fluid bolus, you check it again, and if it goes up by 4% or more, then the patient's fluid responsive. So that's a little tidbit as an aside there. You also want to check blood lactates on your patients, but again, just remember that there are a multitude of reasons why lactate goes up. It's not all about tissue hyperperfusion, and maybe I could do lactate next year. Yeah, right. You guys will get bored as hell. And urinary output is obviously very important as well, but I don't think it's the end all be all. One of the things that they do recommend is against using CVP for your patients. So if you're using CVP to resuscitate people, stop. And let's quickly sum everything up. If a patient's spontaneously breathing, you can use a passive leg raise or fluid challenge and look for the change in the stroke volume or cardiac output. Again, for the sake of repetition, 10% or more is good. If the patient's on mechanical ventilation, you could also do the same thing, passive leg raise or fluid challenge with the change in cardiac output or stroke volume, but you could also try the end expiratory occlusion pressure. If you have an arterial line, here's where you can do your stroke volume variation in addition to that, or also do pulse pressure variation in addition to that. And then at this point, I think I'm a little bit early because you guys gave me 45 minutes to welcome any questions, and I'll try to answer them for you. Or if not, I'd like to plug my podcast. If you guys haven't listened to it, Saving Lives Podcast. So that's my nerdy stuff that I do on the side. Anyway. Questions, comments, concerns, complaints? Am I still going to be invited next year? All right. Well. I'm gonna take my not vodka home with me then. Thank you.
Thank you, Dr. Gutierrez. Next up, we're going to have Kiffing Tiger, nurse practitioner from Advocate Health in Chicago. She'll be discussing comprehensive stroke clinic, providing excellent care throughout the continuum.
All right. Hi, everybody. This is a full room. That's cool. I love to see it. Make sure I know where my slides are. Are my slides here? Okay, awesome. Well, while we're waiting for those, I can always chat it up about anything really. What's the room look like? So how many advanced practice providers in the room? All right, how many ICU nurses? ED nurses? Stroke nurses? Stroke unit? EMS in the room? Yeah, awesome. I love it. All right. So we've got a mix, stroke coordinators. Yep. Administrators. All right. So I'm talking a little bit to everybody, but I'm going to say we're switching gears because I was all on critical care management. And while I love that, I'm critical care nurse practitioner by background. I'm acute care. But what I'm going to talk about today is really about transitional care. So if it's okay, I'm going to use the extra time because I built a talk for about 60 minutes and I can always chat, but I swear I won't take up all day. But I'm going to talk about development of a comprehensive stroke clinic and really about other transitional care considerations because honestly, these are my objectives today. I have no disclosures. We really ramp it up on the hyperacute side of things. So we really need to kind of start to scale things back and think about, well, we do really well on the front end and what are we doing on the back end for our patients? And it's just something we don't talk as much about. And sometimes when we're in the hospital, we actually think, oh, I've done my part. I'm done. See a good luck on the post-acute side of things. And there's really a lot we can do on the front end as clinicians, whether we're a nurse at the bedside, whether we're an administrator, stroke coordinator, a provider, whatever that looks like. So some of the things that we know about transitional care, and I could have a laundry list of things here, but what I'll point out is it takes about 35 to 60 hours of informal caregiving by family members. We know families have to be involved when they take their stroke loved ones home. So how are we helping to support them? There's large gaps for critical transitions. And if we have gaps in transitions, we know patients are more prone to readmission, the patient satisfaction, family satisfaction, engagement goes down, and rehospitalization rates go up. Utilization of a transitional coach, such as an advanced practice nurse or a PA, is associated with lower cause of all-cause readmissions. So designating a transitional coach within your organization actually has been shown to reduce hospital readmissions at 90 days. Increase adherence to follow-up post-stroke clinic patients scheduled with appointments at discharge. We're going to talk a little bit about that. For those that have appointment at discharge and have a timely follow-up phone call, are shown to actually have improved outcomes and increased adherence to the plan set out for them. And then patients actually do often consult with their general practitioners in that first year post-stroke. So many of them will go back to their physicians and their internal medicine docs. But what happens is that the GPs are not often up to date with what the most current guidelines are recommending. And so our stroke patients are not meeting their goals. So we're not getting compliance with A1C. We're not getting them to the blood pressure parameters we want. We're not getting their LDLs down. So what we see then is the secondary risk preventative measures are not really being captured. Patients getting readmitted because of lack of compliance with secondary stroke risk. So what this slide really is intended to show you is really we have to take care of the patient from home to home. That's what we're trying to do. They come from the community. We want to get them back out to the community. We really focus in that hyperacute phase. We do it really well. Over the last 10 to 15 years, it's where the sexy side of stroke, we've paid lots of attention to it. We've implemented lots of process and program management interventions.
but transitional care pathways are not as well developed. So we need to start to think about how are we going to develop some of those pathways. And what are we missing? So rehab readiness and ability to be nimble in that environment is something that is poorly understood and we actually don't have tons of resources for. Increased compliance and efficiency for collecting and reporting of 90-day data, because we don't look at that. And I will tell you, I'm deep into data. And when I look at how we can try and track 90-day data, it's not easy. So we don't have a good method for that, but I can track, a lab value in the first 6 hours that a patient arrives really easily and pull that. I can pour my door 2 times. I can run reports on those like Johnny on the spot, but try to go get an MRS at 90 days. It's like pulling teeth. So secondary prevention and stroke rehab also, we're missing the mark on some of our secondary stroke prevention. So in our organization, and I come from a 25 hospital system. Well, we've just enlarged ourselves. I'm from Chicago. I actually should have introduced myself from Chicago. Thank you for the sunshine, Florida. I am loving it because it's been rainy and cold there. But I come from a 25 hospital system in Wisconsin, Illinois. And we just merged with Atrium Health and Wake University. So we are a very large system, but I'm over Wisconsin, Illinois hospitals. So we look at our system. We are a large hub and spoke network. So we get a lot of patients in, they come to, some arrive right at our hubs and our mothership hospitals, others are really being transferred in. So we're looking at these patients in transitional care and saying, what can we do about them? How are we going to treat them here? Do we have methods by which we can get them back to their communities and have resources in place for them? So what we really started to think about was stroke clinics and what is the problem with our stroke clinics? And these were kind of some big low-hanging fruits: compliance, understanding, availability, and these were leading to increased readmissions. So looking at compliance, there was a lack of consistency and poor follow-up in our post-stroke admissions. So patients were not being discharged with appointments. That was a kind of a mark against us. Multiple providers were being scheduled to see these patients post-stroke. It's really difficult for our stroke patients. I can't tell you how many patients I see in clinic that they say to me, oh, I'm seeing you. Do I really need to see this other guy? And I'm like, well, yeah, I'm in neurosurgery and neuroendovascular. You need to go see the vascular neurologist. And they're like, but why? Didn't you just go over everything with me today? Well, no, there's other things we're going to talk about with your vascular neurologist. So it's always that game of, why do I need to see everybody? So that was a problem. Patients they didn't have rides. I don't have a ride. I can't come back. These appointments take so long. So we heard lots of that. Lack of education and understanding of importance of follow-up. So again, people just have a poor understanding that they had a stroke. You have to go back and work on your risk factors. Otherwise, you might re-present with another stroke. So just that lack of understanding was really evident, and risk factor management was poor. And then there were these long wait times to be seen in stroke neurology clinics. So we needed to figure out, how can we get a patient back in to see a neurologist, a vascular neurologist, that's not 3 months down the road. We needed to find some space and time and to free that up and to get away from that concept of a one and done. We would see some of our neurologists saying, oh yeah, we saw them once, you're discharged from our clinic. They still had unmet blood pressure parameters. They hadn't been transitioned to their anticoagulation. We didn't have implantable loops on them. So we really hadn't finished workup. So that one and done concept needs to go away. We need to push back on that and say, no, you need to be following these patients for longer. So what did we do to fix it? Well, we decided that we were going to design and launch a comprehensive stroke clinic. So we reviewed our options, we looked at the literature, we got all of our program leaders together, and we established some goals. And what we said was, we want to make sure that if we're going to design and launch a comprehensive stroke clinic, we're going to have some very structured goals around this. Appointments at discharge has to happen. All of our patients need to leave with an appointment at discharge, needs to be on their AVS, that after visit summary. We want to see increased follow-up compliance. We need to understand, how are we going to track that? We want to have multidisciplinary team approach. Okay. That means not just seeing a neurosurgeon or a neurologist. We're going to see everybody at once. We're not going to silo our departments and our workup. We wanted to decrease wait time. Our stroke patients can't wait 3 months. They need to be seen before that. We want to reduce our readmissions, and we want to have more coordinated diagnostics and follow-up. We would find I might order a CTA head and neck for my patient and then find out that the neurologist ordered a carotid ultrasound. Well, we don't need both. Why are we wasting money, time, diagnostics? We needed to coordinate our efforts on what are the best diagnostics for the patient and what's the appropriate time frame for follow-up. So we created a roadmap. We wanted to identify our key stakeholders and we needed to affirm buy-in, right? If you're going to do anything new in your organizations, you need executive leadership team buy-in. So we needed to meet with them. We needed to define the geographic clinic and space and the clinic logistics, which is kind of the boring part of all this, but really necessary. Okay. I'm actually in the middle of launching for those stroke coordinators that are out there that are advanced practice nurses. I'm in the middle of piloting a launch of stroke coordinator / APN combined role and stroke coordinator run APN clinics. Meeting I have later today is all about Kiffin. Why do you want this space? What are you going to do in it? Who's going to run it? Who's going to answer the phones? Who's going to room your patients? All of those things. How are we going to pay for it? So those conversations need to be had if you're going to do something like this and ask for space. We needed to scope it and market it. So who's going to be seen? What are the type of patients we're going to see, right? We have a large kind of stroke bucket, if you will. So who are we going to include? And we needed to kind of had some inclusion and exclusion around that. Then we need to have a plan on monitoring, evaluation, and a growth plan. So we put our design together and we defined our comprehensive stroke clinic with some of these goals. We did a review of our volumes and financials, and we wanted to know, is it worth it? Do we have enough volume? What might be our financials on this? Identified the key stakeholders, went in, looked at inclusion, exclusion, designed our space. We developed what the transitional care workflow would look like from hospital discharge to rehab or to home to the comp stroke clinic. So we had to define what that workflow would look like, who was going to be responsible for identifying patients, scheduling the patients, following up on the patients. We had to consider what the electronic medical records and the templates were going to look like. We'll talk a little bit about that. We all know anything about Epic or your EMR, kind of pain in the butt. And this was also kind of a pain in our side, but you get through it. But a needed thing, when you spend the time doing it and invest on the front end, it pays off on the back end. Had to figure out how we were going to bill all of our providers in one clinic. Can they all bill? Does there have to be a separate encounter? How was that going to look? Marketing, and then evaluation and growth. So I just want to spend a minute talking comprehensive and multidisciplinary. And I just want to go, and I'm just a dork, so I look things up a lot and I have to explain it in my own head. So comprehensive and multidisciplinary, these are the definitions. People talk about comprehensive stroke clinics all the time. And when I discuss this program that we've laid out now for a couple of our different hub sites, people go, oh yeah, I have a comprehensive program. They see the vascular neurologist, when they come out of clinic. That's not, that might be comprehensive, I guess, if they're making sure they get attached to all of the other components of care and they're not a one and done. But we're really talking about, and maybe we should have named our clinic comprehensive and multidisciplinary. And this is truly a multidisciplinary clinic. And let's see. Why? Because we're combining several academic disciplines and professional specializations. In our comprehensive and multidisciplinary clinic, our appointments take on average about 2.5 hours for that patient. They will be in our clinic space. They see our stroke vascular neurologist. They see the neurosurgery APC, if that's appropriate. They see the neurointerventional APC. Sometimes that is the same person. Typically it is. They see the physiatrist. So they see our PM&R team, and they get education by the stroke nurse at discharge on their stroke risk factors, what the follow-up appointments will be. We all huddle at the end of that patient's visit to say, these are the diagnostics we want. This is the next time frame we want to see them. Are we all coordinated on the same page? We give that to our stroke nurse who goes and gets all that information done, and we schedule all of their appointments. So coming within this comprehensive and multidisciplinary clinic, I'm excited to say, is cardiology. So what we're missing in our clinic right now is our cardiology colleague to help make sure our Holters are on. Are the Holters red? We see a lot of our patients that leave without them. And if they leave without loops, how can we get them in to get loops implanted and get that piece moving too for our cryptogenics? So we're excited that that's starting pretty soon. So this is, oh boy. We're excited that this is comprehensive and multidisciplinary. We also looked at our volumes and financials, some expected outcome measures. So there's definitely a volume need. We have greater than 65% of our patients out of our hubs that are going to home with home health, or to rehab. And these are the patients that we are including in this cohort of those that can return to us in comp stroke clinics. We really needed to define that. And there's a large volume of patients that we can see in this clinic. There's not really any costs involved. We're not asking for additional FTEs. We're working within an already defined geographic and clinic space. It was really about defining and divvying up some of the change in workload. So really no additional cost. So there is going to be a positive return. We were really talking about increasing the number of visits from multiple providers by creating this comprehensive multidisciplinary space. So we really wanted to look at what we did is we looked at our current state, kind of gave an expected future on how many patients we anticipated to see. And then, and I won't focus too much on financials today, but we will talk a little bit about our outcome and measures of success in a bit. These were all the key stakeholders that we identified. The Comprehensive Stroke Center leaders, the champions, our neuroscience and rehab providers, our hospitalist team, because of course they help us to discharge a lot of our patients. We needed service line and medical group leaders involved. Clinic managers within our neuro units were important, so that in the ambulatory space, we had the department managers involved and engaged because they helped to run our reports on our volumes, on our financials, helping to build that EMR template. We created a patient care liaison, and I'll talk a little bit at the end about our PCL. I had actually submitted a grant for a PCL position that started half-time, received a grant for this position, kind of proof of concept of kind of what a patient care liaison and a clinic navigator would look like. What would they bring to a program like a stroke program? Patient family engagement scores went up. Reduced readmissions because patients got contacted back to clinical teams on the ambulatory side. Those were our goals with the PCL, and we found that we've actually now turned her into a full-time position, paid FTE. Clinic staff is important. Obviously, our Epic and informatics, HIT team, marketing, and we work closely with Pop Health and the resource nurses out of there. So what did we do with our clinic providers and managers? Well, we had multiple meetings for brainstorming to design what the clinic would look like. Again, we determined the type of patient. We had to look really closely at provider availability. So I will tell you, if anybody's thinking about designing this, you will get pushback from providers that are going to say, oh, can't do it. I already have clinic on this day and I go from 8 to 4. I have no time. Well, if we're going to be successful, our ask was of providers to say, where might you be able to be flexible? What might you be able to change in your clinic? And when we launched, you'll see, I'll show you, our phase 1 was really starting at a half day. Again, sometimes you need to just proof of concept. You got to kind of get the wheels in motion to get people to understand the impact we can have. And it was exactly that helped us then to expand out to a full day. And now we're looking at going to 2 days per week, 2 days a week. And so it just, don't be too rushed to feel like you've got to shove it down everybody's throats. It takes a minute for everybody to get on board with it, and especially providers, because everybody's so stretched right now. They're like, I don't know when I can fit in any other clinics, but where can we take away and say, hey, we're going to offload some of these stroke patients out of your individual clinic. We're going to put them in this comp stroke clinic. So we're going to help to maximize and offload out of some of your individual clinic. And then people kind of understood that. We designed our workflows, our measures of success, and then what the workflow needed to look like within the clinic visit. What was going to be our length of visit? How are we going to bill and notes? So each of us as a provider, the stroke neurologist, just as an FYI, takes about 45 minutes. So the patients meet with them for about 45 minutes. They meet with the neurosurgery and neuro IR APC for about 30 minutes and PM&R for about 30 minutes. The stroke nurse has about 10 minutes to kind of sum everything up, put it all together. So that's why those patients are with us for, about 2 to 2.5 hours, some a little bit longer if they have a lot of therapy needs. What we've really realized is what we need in our clinic is social work. So that's kind of a next step as well that we're looking at. This is our inclusion and exclusion. So we do include all ischemic strokes, ICHs, and subarachs that are non-trauma. We have 5 level 1 traumas in the state of Illinois in my system. So we don't include any of our trauma patients there. We have TIAs and carotid disease. We try to not see any TIAs unless they have had waxing waning exam and they have something else that's still going on. So we've actually on the back end, and I don't think I'll have time to show it to you guys. Happy to talk about it offline. We have a number of TIA clinics that we've been putting in place. So when we started this, we started with hospital follow-up patients only. So when we had patients calling in for new patient appointments, we kind of held off in the beginning. We had a lot of requests, but we just didn't have the bandwidth. We really wanted to focus our efforts on the hospital follow-up patients only. So we really excluded those new patient consults, and we did exclude our surgical patients on the initial visit. Reason being, our surgeons felt very strongly that those patients needed to see us in the surgical practice very early on. Some of them had staples, sutures, things like that, that we really needed to be addressing. Then those patients go out to the comp stroke clinic. The only exception to that is carotid stents. We see our carotid stents that are symptomatic in that clinic as a first visit. So we have the initial visit, everybody leaves and they are seen within our clinic within 1 to 2 weeks. Then they follow up with us at 30, 90 days, and 6 months. And then at 1 year, if they're doing well, we feel as though they've maximized their risk factor preventative, risk factor prevention, or the risk factors of their chronic disease state, then we DC them from the clinic. So I kind of already outlined who they're seeing in these clinics. The only other caveat is we do require that they have a need to see 2 of the 3 of us in that clinic. So if somebody comes out and at their 12-month visit, they're doing so well that they only need to see neurosurgery and they don't need neurology signed off on them and PM&R, they have no therapy needs, then they just come out to the neurosurgery clinic, because we're really trying to reserve that time for those patients that really need that comprehensive and multidisciplinary approach. So how do we identify our patients? Well, we have a Monday, Wednesday, Friday multidisciplinary clinic and rounds that we do at our hub hospitals, where we have providers, stroke coordinators, PM&R, all of our therapy teams, our case managers, our PCL. Patients get identified in that clinic as being appropriate for comp stroke clinic. And then our patient care liaison tags them and begins to follow them from that point forward. And we'll follow them all the way through discharge to home or discharge out to acute rehab, and then out beyond acute rehab, they'll follow over there. We do look, also ask our acute rehab case managers on those units, and our PMR providers do also help to identify them. And then what happens is our PCL tags those patients and works with our clinic scheduler. So within the clinic, they call out and say, hey, I've got patient X, Y, and Z. They confirm the appointment. The appointment goes into Epic as part of the patient's follow-up at discharge. So when the patient gets discharged, they get that AVS that says you will be following up with these providers on this date. And it's scheduled, so all of us can see it in our clinic schedules. So should that patient not show, we actually can tag them. We see that they've not shown, so we can really follow up on them. They don't get lost in the shuffle of a lot of our other stroke patients who get discharged without appointments, and we have kind of no idea what's happening to them once they go home or out to acute rehab. Well, I don't know what your guys' space is like, but where I'm at, space is like gold. So it's next to impossible to find. So you really have to start to think about this in advance. What department's going to host this clinic? And there can kind of be some tug and pull on that. Who's going to do it? Who's going to be the MA to room? Who's going to be the nurse that's going to come out? You're going to pull a nurse from somebody else. Who's going to be kind of the administrator and manager over this clinic? What day, what time? So these are all really important things that you need to discuss if you're going to launch a clinic like this, just because I just encourage you to not make any assumptions, okay? Because all of those kind of components are really important in this being successful for you. EMR and billing considerations. Well, work with informatics. That's all I have to say. We created tip sheets. So we created tip sheets around scheduling. We really looked at like linear versus staggered scheduling. So do we schedule one provider at 8 a.m. and everybody follows? We did that actually at first. And what we found is we had providers sitting around not doing anything. And that was not good use of our providers. It was people were not satisfied, being like, hey, Kiffin, I'm sitting around twiddling my thumbs, get me busy. Why is the patient not here for me to see? Reason being is that vascular neurologist, as I told you, was seeing that first patient for 45 minutes. So what we decided to do is start to learn to stagger those appointments appropriately. So work with informatics on how that template will look, talk to your team. I encourage more of a staggered visit format in a clinic like this so that your providers stay busy and you maximize everybody's time that's in there and productivity. Note writing is seems like a no-brainer, but there's actually a special way when you work within a multidisciplinary visit that you actually have to close your notes. You have to sign them on encounter. Otherwise, they don't show up as your note. It is signed under a different provider. So really important, again, to work with your informatics team. Billing level of service. Every provider will bill their own level of service. So while you might see one patient, and I'll show you in a minute, we have fewer number of patients and we do provider visits. And that's because one patient might see 3 providers. So everybody's intended to bill, then closing the encounter. You have to kind of designate who's going to close this encounter. If everybody hasn't finished their notes, and so it is important to work as a team. If I finish my notes, but my vascular neurologist hasn't, I can't close the encounter. I need to go to my vascular neurologist and say, hey, can close the encounter because we can't drop any billing charges till you close that. Again, why it's important to have a clinic administrator manager who's really monitoring this space, because if you're an APC and I'm not the administrator manager, but I kind of am because I'm a champion of this, that I kind of got to go give people nudges. Hey, you got to go close your notes. And I'm guilty of it too, but it's something we just need to be on top of. So each patient's built as one visit encounter, examined by 2 to 3 providers per visit. Everybody writes their own note, bills their own bills, and once one person gets selected to close the encounter. I'm not going to go through the tip sheets. I'm happy to share these with anybody who would like them, but just know we created a lot of them and it was really helpful to give to our providers. Told us about how to schedule. We looked at tip sheets on how to write the notes, close the notes, and how to bill within a multidisciplinary visit. How did we market? We created handouts that our patient care liaison actually gave every single stroke patient a handout that said, hey, this is who you're going to see. And people see so many of us in the hospital, they don't know who they're seeing when they come out. So she would circle people's faces, say, you're going to see this person and this person and this person. And patients and families really liked it. They could connect with it. They're like, oh yeah, I remember seeing that guy or that woman. They were in my room a lot, but couldn't remember their name, right? Because just so much going on. So it was really nice for them. And then they get that at the time that they're leaving, along with their AVS, it actually has that discharge appointment. We put this on our website. We talk about it in World Stroke Day. We talk about it in May Stroke Awareness Month. So we really kind of do try to market this. We were a little hesitant at first. Like I said, we weren't promoting new patient consults in the visit until just recently. So we had to be cautious about how much we would market initially because we didn't want to turn people away and have them not want to come back to us. So evaluation and growth. Measures of success were really important. So we wanted to look as much as we could at compliance. And if anybody's ever tried to look at compliance in the ambulatory space, you're like banging your head against the wall. I know, I feel it. So that was really challenging, was kind of a manual process for me initially. So we're getting better at it. Readmissions in 30 days we looked at, modified Rankins in 90. And we are now better able to track patient satisfaction. We had kind of a phased approach of this, as I said. So our phase 1 was really this half day kind of hospital follow-up approach. Phase 2 is full day hospital follow-up. And as we've moved into a full day, and that's where we are at right now, is we're at a full day, mostly hospital follow-ups, and we're really full. So we can only take in so many new consults. And again, they need to be able to have to see 2 of 3 providers to qualify for this clinic. So the scheduler has to do some front end questions. And I will say it was helpful for them because it's a non-clinic person. So we actually created some questions that people to ask. Do you have this? Have you had a stroke? Do you have imaging? Do you have a weakness? Do you have problems swallowing? So we wanted to see if they would actually require PM&R in the clinic by asking some targeted questions. So we designed those for our intake schedulers, and that was really helpful. We actually started to kind of hit the mark a little bit better. And then our phase 3 is rolling out to full day plus a second day. So we're super excited about that. Okay, so looking at our comprehensive, some of our visit volume and some of the data around it. So we actually launched this, and I'm only showing you the last couple of years of data. We launched this in October of 2019, right before COVID. So that was fun, but we had to take a little bit of a hiatus then as we went through COVID. And so some of our data was a little wonky in that first kind of year or so. So what I really have looked at is kind of where are we at in these last couple of years where we've been able to get a little bit more reliable data. So we expanded our day of visits in 2022, like I said, in that phase 2, where we went from half day to full day. You can see that we increased by 100 patients in 2022. Those patients that we were able to get into the clinic by expanding the day. We had over 750 provider visits that were additional to what would have normally been seen for these patients. And then our follow-up and readmission outcomes, if you remember, one of the things that we wanted was to really start to measure how compliant we were with no-shows and readmissions at 30 days. In 2021, we actually only had 8 no-shows. So we did reschedule people because we had people call or fall off that we were able then to get back in. But we truly only had 8 patients that were on the schedule, didn't show, we could never get back in. In 2022, that was up a little bit to 16. We're actually, even though our number uptrended, we're super happy with this because we actually feel like out of all of those patients, we are really hitting the mark. We are seeing a high percentage of these patients back in our clinic because of our discharge process. They are being discharged with an appointment so we can really track them, call them, see what's keeping or preventing them from getting back to us. And we could see that our readmissions at 30 days were really good. So in 2022, we had 12 30-day readmissions. And when we looked at readmissions for patients who specifically after the CSE visit, there was only 2. And what that really is kind of telling us is we're doing a really good job. If we can see the patients in a timely manner, that we're actually probably doing a really good job keeping them out of our ERs and getting readmitted. So this was the kind of data, again, it's not quite as robust as I'd want, but it's getting there. It's kind of showing me the trend that we're on the right track. If we can get patients early with those discharges, we can track them, we can see them, and we're actually keeping them out of the hospital from readmissions. When we looked at our modified Rankin, and what I did is we looked at this at the comprehensive clinic patient group, and then looked at it at our aggregated system across Illinois, so which is 9 hospitals. So our modified Rankin out of our hub site with our patients seen in CSE, we had about a 51% good modified Rankin of 0 to 2. So I think that we're doing pretty good. And again, these are our patients that went to home health and acute rehab. Does not mean that they all received thrombolytic or thrombectomy therapy, but a good majority of them did, to be very honest. So we all know that those patients are going to be the patients that get discharged home and out to acute rehab. So good majority of these are thrombolytic and thrombectomy patients. When we looked at our 90-day modified Rankin at the system level, we're at 45%. So the hub site that's running these comprehensives is right in line and actually above our system modified Rankin score for 0 to 2. So we were at 51% out of the hub comprehensive stroke clinic, 45% across all 9 of our sites. And that really tells me that we're really, again, on target with a good measure of success. Our patients are having good 90-day outcome scores. When we looked at our readmission rates, again, specific to our hub site that our comprehensive stroke clinic is running out of, we had some uptick in our ischemic stroke readmission rates at 30 days at about 8.4 in 2021, 2022, about 6.7. And then our hemorrhagics really took a big uptick, and we have some opportunity there, which is why we're actually about ready to pilot a transitional clinic navigator. We're going to be piloting with a group called Can Do and working in bringing a clinic navigator who will be a social worker and helping us to navigate some of these to make a dent on these readmissions. We looked at the site, comprehensive stroke clinic site compared to system. Again, when we look at the hemorrhagic strokes, we're like double what our system is. I don't know exactly why we're seeing that number right now. I will say it really stood out to me. I don't know if that's because at our hub sites, we're really seeing the sickest of the sick. Everybody's being sent there. So it's just going to be a higher number. And that's just something we need to expect. I think we have to trend that. But the problem with that kind of philosophy is that we didn't see that the year before. So it tells me something kind of changed last year. I don't really know what it is. If we didn't see as many of our hemorrhages for some reason. So we're looking at that data, but we're pretty aligned with our readmission rates otherwise, but we do know we have a big opportunity here, which is why we're kind of looking at, okay, now that we have the comp stroke clinic, what else can we do in transitional care? This is just some physical therapy and rehab outcomes. And this looks at specifically the Comprehensive Stroke Clinic site and how that compares across the nation. So percent of stroke admissions at our site is really a little bit higher than the national standard. We're about almost 38% across the nation. About 23% of patients are having stroke admissions into acute rehab, and percentage community that are have community discharge. Again, we're at about 77% compared to 72%. So we feel like we're really hitting the mark and doing well with getting our patients back out to the community. So what were some of our identified barrier? Well, coordination and availability of our providers' time. It was a slow expansion of going from that half day to full day. The ability to expand to new patients, that's definitely a barrier. Initially, we included our physical therapy team. So for about the first 6 months, we actually had a physical therapist in our clinics with us. And while I loved that and they loved it, it was not, we found the best use of their time. And as you guys probably know, physical therapists require a referral, right? They have to have a good reason to be seeing the patient. We had to create the referrals on the fly within the clinic. So that was a little bit of a challenge for us. So we decided actually to take them out of that clinic space, make sure that we were getting the referrals, setting those appointments up as opposed to bringing them in, which is kind of a bummer because I loved having them there. Change in disposition, so really increased cancellations and rescheduling patients a lot is kind of timely, takes some work of our clinic coordinators. Transportation, so this is a problem when you're a hub. A lot of these patients are coming into you, right, from other communities. So working on how can we get these patients back out to the communities again, and that's why you want comprehensive stroke clinics, but you also, if you're a system, an enterprise of multiple hospitals, then you want to be thinking, well, how can I build other stroke clinics in that community? Do they exist? Can I get them back there? And if not, what can we do to expand out in those communities to get somebody there that those patients can see if there's really limiting factors, transportation, insurance. We had plenty of out-of-network patients. And then the after visit summary is kind of a quirky little thing to highlight, but it's really difficult to create a multidisciplinary destination as a geographic location. So what we have found is it was very difficult to say in our AVS, you're getting discharged to the comprehensive stroke clinic because it's not its own clinic. That clinic lives in the neurosurgery space, meaning physical space. So it's run out of the neurosurgery Brain and Spine Institute clinic space. So we couldn't rename it. So just quirky little things like that were a barrier. And so we really had to work with our hospitalist teams to understand that how patients were getting discharged and helping us to identify the patients to make sure it got correct on their AVS so they knew who they were coming out to see in Comp Stroke Clinic. Opportunities or expansion, full days to 2 days a week, cardiology partnership, as I had highlighted. Inclusion of social work. So a great big need for social work. Again, we're launching a clinical navigator pilot project with Can Do, which is really going to allow us to have a clinical navigator that gets tagged to every patient along with our PCL. And those two will work together to discharge that patient out to the clinic and follow for 90 days while the patient has a mobile app that they can connect to that clinic navigator. So we're really excited for that pilot to start. How do we track data? That's always an opportunity forever and ever. And then I would do about anything to have an Epic EMR navigator in the post-acute setting. Please help Epic. So I know I hear some of you laughing. It doesn't exist. I'd love to work with anybody to create it. So development of an ambulatory navigator for Epic is really we need it. And it's about time that it gets created. So we have no easy way to get reporting out of that. Patient care liaison and our clinic navigators. So I talked a little bit about this already, but synergy between these two roles is really essential and it just makes perfect sense. So I really encourage if you may not call them by PCL or clinic navigator, whatever you want to call them at your site, work with them very directly. And I will say, I tell people all the time, being a patient care liaison is one of the toughest jobs, I swear, that exists because they have to take in all of the heat from patients and families. I don't like this. My provider isn't doing that. My loved one isn't getting out of the chair but once a day. We don't like the food. Nobody's come to talk with us. So they have to take all that. Then they have to be kind of the messenger back to the providers. So I always say to some of the clinicians that come to me and say, Kiffin, the PCL just won't stop talking to me about X, Y, and Z. And I'm like, don't shoot the messenger, right? Come on, guys. Their job is to be the liaison to help patients and families feel heard. But that is a really important piece as patients and families transition and maintaining kind of that relationship. They have to feel like they have a voice in what the next steps are for them. So this is where I have a whole nother 30 minutes of talking, and Abby's already flagged me that I only have like 3 minutes left. So I'm going to just kind of flip through some of this and tell you that TIA clinics and the Clinical Navigator mobile app, happy to talk more to people about this. This is a little bit what it looks like. We're gonna have software and services that are optimized for stroke patients, where we have the hospital team, the Clinical Navigator, and the survivor and patient, and they're gonna have a mobile app. And it takes them through day 0 up to day 90, where we're going to track them through a mobile app that really provides them with weekly check-ins, the tools that they need, their risk factors on a mobile app, addressing readmission, prevention, community support, understanding their discharge needs, and really looking for those opportunities. It addresses things like fatigue. What can they do about fatigue? How can they address it? What are things that the patient and family at home can do? Looking at opportunities, as I said, about a stroke coordinator APN clinic. I have stroke coordinators that are nurse practitioners. They want to work at the scope of license. I heard them. I heard their voice. They've told me this over and over. And I said, if I don't do something about it, they're going to leave the stroke coordinator role. And so what we've done is we are piloting 2 stroke APN led clinics, stroke coordinator APN clinics out of our communities that actually don't have stroke clinics in them, but they have the volume. They're seeing over 200 patients discharged out to home in rehab a year. There's a volume and a need in that community. That's what it tells me. We're going to create the space that these patients can transition back out to. Again, transitional care, thinking about the transitional care pathway. What are the different opportunities that we see in front of us that we're just not capitalizing on, taking advantage of, right? So creating something like this, what's the why behind it? Well, they're capable of doing it. They're an advanced practice provider. They're a billing provider. We want them to work at the scope of our license, especially if there's not an existing clinic in that space. Again, kind of a no-brainer. This was a little bit of our roadmap and workflow and how we created this pilot project, who we talked to, what we've been doing and getting that ready. We've been building TIA clinics. Again, why? And I'm really excited. I will just share with you one of the TIA clinics. We have a few of them that are built out in our system. One is a same-day TIA clinic. They're not seen very much. I've searched the literature for it. So if you guys have them, I'd be happy and would love to talk more about it. Most TIA clinics, you get discharged out and say, get an appointment within 24 to 48 hours. But honestly, if we've got somebody with a symptomatic waxing, waning carotid, I don't know, do we feel comfortable with that? Are they going to include that carotid when we send them home that night to come back for an MRI and a neurology visit the next day? We don't know. Same day TIA clinic, it takes a lot of work, but it's been really exciting to work on this. And I would say we're so far being very successful. This is the pathway, the inclusion, exclusion, how we're looking at these patients. It's actually an APN led clinic. Super excited about that. We're capitalizing on our APNs and their billing opportunities. And again, working at that scope of practice. These are the other TIA clinics we have, why you should consider them. These are our ultimate goals. Okay. Compliance and comprehensive stroke clinics. We want to reduce readmissions, improve our functional outcomes, and reduce the number of strokes in our community. So thank you for your time today, and happy to take any questions. Okay, thanks, guys.
Thanks, Kiffin. That was a great talk. We really appreciate it. It is my pleasure to now introduce Michelle Whaley. Michelle and I met, it's been a couple of years ago at another conference. Michelle comes to us all the way from Colorado, but she's a clinical nurse specialist by training, and she's done a graduate fellowship in neurovascular as a neurovascular clinician. And she's currently the market director for stroke and neurosciences in the Denver market. So she's going to talk to us today about ideal foundational requirements for stroke center growth and development. So for those of you that aren't familiar, this was a guideline that was published by American Heart Association earlier this year during the International Stroke Conference. And it really goes through a lot of really good information about putting together your stroke program. So Michelle, take it away. Upstairs.
All right. Hi, everyone. So I always like to know my audience, and I got in late last night, so I joined a little bit earlier today. How many of you are bedside nurses in the room? Okay. How about stroke coordinators? Okay. Administrators? Rehab therapists? Okay. Physicians, providers? Okay, thank you. It's always helpful for me to have an idea so that I can tailor the talk to the folks that are in the room. So I was asked to join this writing group around this time last year. We had a very tight timeline. The ultimate goal was for us to have this paper ready for the International Stroke Conference, which we were successful in doing. It was published the day of the conference. And our ultimate goal here was to find a way in writing to define what it means to be a stroke center at the varying levels of stroke center, and not every single detail about what it means to be a stroke center, but what are the foundational requirements to move from a primary stroke center to a thrombectomy capable stroke center to a comprehensive stroke center. And as you could see, Kiffin's talk just now, the program in Illinois at Advocate, that is a huge program. They have a lot of resources. So how do you go from a community hospital that's a primary stroke center to a thrombectomy stroke center and then strive to be that comprehensive level center? So that's what the purpose of the paper was. They brought all sorts of providers together. I've been in the field of stroke since 2009, and most of us listed on the author list here have been at comprehensive centers and were among the original centers that were certified back in 2012. So this is a scientific statement. It's not a rule or a law, but these are ideal foundational requirements. So the things that we put in this paper are really to help a stroke program coordinator, an administrator, a leader, determine what things are needed to move to the next level. Because what we were finding was across the country, and as a stroke coordinator back in the day in Denver, I then spent some time doing some public speaking for Genentech. I would find that how stroke programs were run is largely regional. In the Denver market, for example, I may have been the person that trained half the coordinators in the Denver area. So they do things along the same lines that I do, but I was largely self-taught, and I didn't have a guideline to tell me how things should be done in our market. So we wanted to provide some structure, we wanted to provide guidance, and we wanted to encourage other publications. So if Kiffin and her team have not already done so, I would highly recommend that they write up and publish what they have done with their system, especially with their post-stroke discharge clinics, because that's really important and should provide guidance for all of our programs moving forward. And then just a little shout out. We were required to do an infographic, and none of us on the author team were very crafty. I have some Pinterest fails in my life that probably shouldn't be seen, but my daughter actually is graduating on Saturday with her master's degree in graphic design. And so we were sitting, we were up in the mountains in Colorado writing this paper, and I sent my daughter a text and said, "Hey, this is our concept, can you make it?" And within like the same day, she produced this. And so this was her first publication prior to graduating with her master's degree. So again, very proud of that. So let's talk about stroke program leaders. So if you're an administrator in the room, you'll probably find yourself somewhere on this list. The part of the paper that I wrote was this leadership section, and then I was also part of the quality section. So corporations, hospital corporations, largely determine what the growth agenda is for their corporation. So I work for HCA, and HCA has corporate plans for us from a stroke standpoint and from a neurosciences program standpoint, and that flows down to the CEO. And the CEO, the COO, the chief nursing officer, those team members are going to set what the agenda and what the plans are for growth of that individual hospital. Now, the stroke medical director is going to provide direction on the clinical side of patient care. In the paper, we really call out that the stroke medical director should be a vascular neurologist by training. Neuroscience service leaders should have certain qualities. What's interesting and what I've seen across the country is that depending on who the stroke coordinator reports to, depends on what kind of role they have. If the person reports to the quality department, it's going to be largely a data collection job and maybe not more. If the person is reporting to a neuroscience service line or up to the C-suite, there might be more focused on growth and volume and procedures and, attaining a higher level of certification. And of course, all of these leaders really come together, and it's sometimes as stroke coordinators or market directors, we have to kind of help our administrators understand what it is that we're doing and what we should strive to be doing in the future, which is the role that I have currently now. So some of these things will speak to stroke coordinators, and then there is something for nurses in here as well. So we'll get to that. In the stroke program resources section of the paper, we really call out the need for a dedicated stroke coordinator and not a data collector. The data collector is a separate role. Right? So every program needs to have a data collector, but the stroke coordinator is really organizing that program. And there's a lot of ideals about what we think a stroke coordinator should do, and data collection is really not one of them. So I'll call that out here in just a minute. But we really felt like dedicated stroke coordinator at all levels. Now, acute stroke ready hospitals would make sense that they might report up to a quality department or have a quality data person who might manage some of those day-to-day things, because acute stroke ready hospitals are fairly small. The next thing on the list is that comprehensive stroke centers should be providers of telestroke, not utilizers of telestroke. This is a controversial statement. It was for me, actually, because my thrombectomy capable stroke center that has aspirations to be a comprehensive center utilizes telemedicine. Now, it's our in-house telemedicine team. Our people, they will also round on patients. They'll cover telemedicine. They cover a large part of the country with telemedicine, but they're also physically present in our emergency room. So I think me personally, I think there is an opportunity here to utilize both. But the authors of the paper, especially those that wrote that section, really felt strongly that a neurologist should be in-house. And as I step back and think about, okay, how am I going to make this happen in my hospitals? And do I think that having a neurologist at the bedside for an acute stroke or a hyperacute stroke is better than telemedicine? Well, really, if I'm thinking about it, yes, I do. And so having it in this paper allows me to take the paper to my administrators and say, okay, if we want to be a comprehensive center, we need to recruit, we need to have people on site, and they need to be there 24/7, and it's the right thing to do. So having this in paper format has helped even me, somebody who believes in this, articulate what needs to happen for those leaders. Then down at the bottom is the dedicated stroke data collector, which we'll talk more about. So staffing of stroke programs, so this would be the stroke coordinator or the neuroscience team, really depends on volume, level, and complexity. So I have everything in my market from a comprehensive center that has 5 advanced practice nurses running the team to primary stroke centers where that particular coordinator may share a service line like sepsis. And as her volume grows and as her team is going to take that program to thrombectomy capable, she will need to be a full-time FTE for stroke. And I've set that expectation with her C-suite team to ensure that when that complexity reaches a specific level, the program will grow accordingly. And I think it's a really good way to think about stroke coordination as an owner, not a renter, and that they're the CEO of stroke. They really own that program and know the best practices that go along with it and can spend time with their C-suite, helping them understand how best to support the program and how to grow the program. If you're ever working with a CEO, they want to know how you're going to increase productivity, how you're going to increase volume of procedures, and basically how you're going to make them money. So as the CEO of stroke, you should have a strategic growth program. So ideal staffing for stroke programs. So looking at the primary versus thrombectomy capable versus comprehensive. So again, the primary center, depending on size and volume and complexity, should at least have a stroke coordinator and should at least have someone doing data. Now that data can be outsourced to somebody like Hucentrix or Parallon, but that you really don't want the coordinator spending their time collecting data because that can just be an all-day thing. And I have a talk this afternoon about stroke coordination where I'll mention that. Again, low volume centers might combine roles, but there's just a certain sweet spot where they're busy enough and the patients are complex enough that they better be dedicated. Thrombectomy stroke centers should have a minimum of one stroke coordinator and often will require two based on volume, also data collection. And now we're starting to see patients who need an advanced practice provider on site, helping with neuroscience coverage, attending stroke alerts, driving care in that way. And there should be a distinct role called out in the paper based on each member of the team. For comprehensive stroke centers, again, depending on volume, you know, my center in the Denver area that has, they see approximately 1,600 strokes. This would be stroke, hemorrhage, TIA altogether, subarachnoid hemorrhage. They see around 1,600 to 1,800 patients annually. So they have 5 of them because their complexity is very high. They have high volume. Now they've chosen to do all their own data abstraction. So think about that as a stroke APP. They would rather collect data and have more of them than ship it out. I think if I were reorganizing that team, I would absolutely ship the data out because APP should be practicing at the top of their license. Clinical research teams also definitely needed at the comprehensive level, and that's called out in the paper. So for stroke coordinators, these were the roles and responsibilities that we felt were most important. So responding to and ensuring excellent emergent stroke care provided in your ER, in your acute care units, in your ICU, developing and ensuring appropriate use of education materials, providing community education, and on down the list. These are all the things that as a stroke coordinator, you probably have on your list of things to do, but if you're also data collecting greater than 50% of the day, probably aren't actually meeting all of these items here. You're probably pulling your hair out because you're trying to do those things, but the data is wearing you down. So this is where you can take this paper to your leaders and say, look, to meet these standards, we really should have X, Y, and Z in place. And we utilize the trauma charcoal book. Anyone here do anything with trauma? So the charcoal book is like their Bible of standards. Stroke doesn't have one, which was what we were trying to do with this paper. We utilized their requirements, which if you have 500 patients, you should have one dedicated person. APP roles, the common roles would be responders to stroke alerts, stroke medical management during the hospital stay, maybe first assist during a neurointervention, provision of outpatient stroke clinic services. My market in Denver is in the process of rolling out post-stroke follow-up clinics that are going to be APP driven. Evolving roles. Telemedicine for emergency responders. And I've got a couple of colleagues now that are doing daily telemedicine rounds, which is a really interesting role to have. And then of course, being the expert on board a mobile stroke unit. Do you guys have a mobile stroke unit here in Florida? No? Okay. They're expensive. So this is for the nurses in the room. We specifically call out in the paper that we need to have dedicated stroke units at all levels of stroke programs. I think it's pretty common that a hospital will put a sign up that says this is the stroke unit, but then patients go everywhere. And is that good for patient care? Probably not. In my own hospital, when I see that, when nurses are able to be cohorted together with other neuro nurses, with their neuro patients, care is elevated because you've got experts right there to help troubleshoot an EVD or another set of eyes for a really difficult assessment. If that neuro nurse that you're working with is across the unit and down the hall and 2 doors away, they're probably not going to be that expert. So we really want to see dedicated stroke units with dedicated nurses with neurovascular training. We call it out in the paper, and we're hoping that Joint Commission and DNV and any other regulatory agencies out there will pick this paper up and will utilize our recommendations. From a staffing standpoint, we recommend that RNs be to patient ratios be 1 RN to 3 to 4 patients. Is that happening in your acute care units? Probably not. It's not in mine. Ideally, it's 1 to 3 in a progressive care unit setting. What I'm seeing now in my own facility, just from a staffing challenge standpoint post-COVID, we're lucky to get 1 to 5. With 1 to 5, though, the problem is that you're probably now rendering that stroke patient immobile because they can't move themselves and their nurse is too busy to move them. So that's why we call out in the paper 1 to 3. When I'm meeting now with hospitals that want to increase their level of certification, the first thing I'm talking about now is stroke units and staffing. And surprisingly, I'm hearing leaders talk about, okay, how can we make this happen? So again, utilizing the paper for our benefit, taking this to our leaders and really showing what best practice is. And if we want to be this level of hospital, we need to be offering this level of staffing ratios to our patients and really for our nurses. From a quality improvement standpoint, I'm not going to spend too much time on this because there's only a handful of stroke coordinators in the room, but basically what the paper calls out is if you are a comprehensive center, you're going to be collecting through your data collectors a lot of data, and your stroke coordinator should be analyzing that data and looking for opportunities to improve. Things like ventriculitis rates with EVDs, right? That's a major quality indicator. Door to groin puncture, door to recanalization and mechanical endovascular thrombectomy. Door to thrombolytic is super important. Our hospital just switched from TPA, alteplase, to tenecteplase. And surprisingly, our door to needle times didn't go down. Everyone thought it was going to be so amazing and we were going to drop our times. And, we're kind of hovering in the same time frame. But what we found was maybe patients, providers weren't as comfortable with T and K. And so the delay occurred. So as a provider and a stroke leader, I want to know this. And the way you know it is by data and data collection and analysis. So again, on this list, we call out the things that need to be done at the comprehensive level, which is why those programs, because they're more complex, require more people. We also call out peer review. So if you're a primary stroke center, you might have a hospital peer review, but if you're moving from thrombectomy to comprehensive, you should be developing a specialized neuro peer review for your providers. So, and it should be multi-specialty so that team members can come together and analyze what happened with a particular maybe issue that required peer, but as experts in that field, getting together and not only looking at maybe what a provider could have done better, but how do we fix the whole system so that it's better and use it as an opportunity for CME. That's a best practice. Annual PI projects, publicly reported data, these are all things that we called out as best practice. And then same things with how you submit data to registries and how you can compare and benchmark against other like hospitals so that you know as a facility you're on the right track. If you're a neuro ICU, it'd be great to compare your, let's say, dysphagia screening rates or other complications like aspiration pneumonia or UTI, how does your unit compare against other like units within your system or within a regional area of hospitals? That'd be really a great PI project to look at, because again, it's all about quality improvement. Clinical research, this was also a controversial part of the paper. If you're a comprehensive center currently for Joint Commission, the requirement is that you have that you participate in IRB related research. It doesn't really define necessarily what that means. We define it as 3 publications, scholarly publications annually. And so when you, as I think about, if I were running a CSC right now that wasn't publishing, wow, how are we going to get this done? So I actually took that question to a CEO who said, oh, we'll make the residents do it. Or he actually had solutions. So it was like, all right, Michelle, I don't have to write these papers. I can utilize, again, members of my team to assist with that. So I want to call out now, this is just the last couple of slides. When I meet with CEOs of the hospitals within my system, and they want to go from a primary center overnight to a comprehensive center, I try to call out to them what's needed. And if you work in the neuro ICU or you're a stroke coordinator, you understand this overwhelming need from a leader to move the needle very quickly. And these programs actually take a little bit longer to build and to be methodical about how it's going to be done. So when I shared this with the CEOs, I actually got a little bit of traction with it. So I would encourage you to think about this in a similar way. Primary stroke center certification is similar to a level 3 trauma center. It's not that difficult to achieve. These are very important programs and maybe very robust and very busy programs, but they're, from a requirement standpoint for regulatory agencies like Joint Commission and DNV, it's not that difficult to have a CAT scanner or nurses that get education or annual education is provided. So again, these are things that as a leader and as I think about, when they become more complex, like primary to thrombectomy, there are additional things that need to happen, and it's going to be costly. And so it's important for a leader to also understand that now having to have 24/7 on-site critical care coverage might cost them in contracts with providers. They are going to have advanced imaging, and not just during the day, not just on call, but they're going to need to be available on site. The neuro biplane, you can't just buy any biplane. You got to buy a good biplane that your interventionist will want to use. And you need to be strategic about who is providing those thrombectomy cases, because if you're looking for, say, Joint Commission, you need to have 15 cases per provider annually, and being thoughtful about how the schedule works. Not only do nurses need education, but they need 8 hours of education. And in DNV, I think in some cases, there's more education required. So that is costly, and it needs to be written into a budget, and they need to think about that ahead of time. And then your education team should be assisting the stroke coordinator with this. I don't think the stroke coordinator should be doing all of these things. So setting that expectation early on, instead of taking on all those roles, let the facility help you, because again, it takes everyone in a facility truly to become something like a comprehensive center, which requires far more things from a thrombectomy center, and enhancement of data collection and research and all of that. And it's very similar to a level 1 trauma center. So helpful to set those expectations ahead of time. Can be very rewarding to work at a comprehensive center, but it's a lot of work as well. So I'm going to kind of wrap this up here, that it takes a village to create a great stroke program. I'm working currently with a hospital that just achieved what they call Primary Plus, which is a thrombectomy certification through DNV. And she sat down, this is the coordinator now, she's an advanced practice provider. She sat down all of these key leaders and said, okay, we as a team need to make this happen. And we as a team need to collect some things. So physical therapy, we need you to track your door to first assessment. And the lab team, we need you to collect and help us analyze stroke patient data. And that as a team, everyone is going to come together to make this hospital become a very successful comprehensive level stroke center, because it takes everyone to help. You can't just be one lonely stroke coordinator or one lonely medical director. Everyone has to work together. And with that, I'll take any questions if you have any. Yes. Is she grabbing a mic? Well, while they bring that over, when I gave this talk at the International Stroke Conference, I was kind of the last speaker. I was expecting people to be mad. They were going to yell at us. No, people actually clapped. I was surprised. All right.
First off, I want to say thank you. And is there any way you can share the slide?
Yeah, happy to. I'll make sure that Wendy has those and they can get out to you.
Okay. Well, no, really phenomenal. And the struggle is, in a smaller facility, when you don't have a stroke unit that's specific, how do you then, help assure that these patient population is really acquired to seek the right resources? I know we have at least rapid response, which is very helpful for our facility, but to try to really navigate those stroke patients in 3 other units, how did you try to resolve those?
So in the paper, we kind of make it a hard and fast rule. There needs to be a stroke unit. Now, as a facility trying to solve this problem, I would recommend cohorting. And I would recommend every month at a stroke meeting, like if you're a coordinator or a nurse leader, I would take those percentages. So in the month of May, 56% of patients were admitted to the correct unit and had the correct nurse caring for them. And we should strive for it to be 80%. And then we should lean on leaders to make that happen and actually track, having a quality person track where those patients are admitted. And then when they're on off units, analyzing what opportunities may have been missed and highlighting those in every meeting. Because I think leaders, especially if you can give them the paper, which is in writing, you need these things, and look at us, we're not meeting these criteria. And I use this in my own setting. That helps them understand and have a benchmark that they need to work towards. So that's my recommendation. Anything else? Yes.
I'm over here. Yeah, thank you. Awesome talk.
Thank
Thank you. And appreciate all the work that goes into that scientific statement. I can appreciate that very much. So thank you for all that. I would just say I loved this because I've been going through a process and looking at programs that want to go to that next level. And this really worked as a good roadmap. And so I would just offer that as a comment to the group. I use this as a roadmap to take to executive leaders to say, do you have this? Do you have this? Do you have this? Oh, we don't. Let's get these pieces in place before we can launch. I think it is a very nice blueprint to guide administrators and leaders that are looking to expand and grow. So I think it's really phenomenal work on that. My question to you is around some of the quality. So you have a lot of discussion there on quality. What did the group think about really putting in, and was there discussion around saying, hey, every program should have designated X amount of quality individuals assigned to the program? What I'm finding is that there is just a paucity of those resources. Really, as you pointed out multiple times in the talk, is it should not be the job of the stroke coordinator to be pulling data, abstracting data, data dumping. But yet we don't find really that there's any statement or guidelines that really do push Joint Commission or DMV or others to say, you guys should have designated quality groups. So just want to know what you guys discussed in your group.
Well, we were limited in words. So some of our paper got edited out in the editorial process. So we lost some words, but we actually feel like this is a whole paper in and of itself to really define what staffing should look like. Although I do believe there's a sentence in there that calls out the trauma charcoal book that says, if you have 500 patients, you need to have 1 quality abstractor. Or you need to add, if you have 2,000 patients, you need to have 4 people. So that was our intent, was that you would have the ability from a number standpoint to quantify how many people you needed. It's like 1 sentence in the paper, but that was our goal. I'll pull it up and see if I can find it. Thank you. Anybody else? All right, well, thank you very much.
Hello. All right. Well, we are ready for lunch.
Abby, are we back here? Or are we outside? Is there seating outside? Awesome. Okay, thank you. Thank you, Michelle. It was a great talk. Really appreciate it. All right, guys, you're free for lunch, and I think we're back in here at 12:45, so you've got an hour.
John, are you around? I'm looking for a program for this conference, but I can't find it on the internet. Do you have a link?
Yeah, hi, is this Martin? Or you look,
Yeah,
what are you
John.
what are you looking for?
I just look for a program for, what kind of lectures they have. It's gonna be tomorrow as well, and
Yeah,
think-
okay. Well, I gave you what do you need? The Zoom link?
yeah, well, the Zoom link I registered, right? But I can't
Okay.
find anywhere is what the schedules are.
Okay, let me get you the description of the course. Hold on.
How are you doing over there? We've been a little bit busy lately. I'm still sort of talking to people about putting together some other webinar down here in the area, but
Yeah, we need Dubai. We need Dubai to have a presence.
yes, we do.
You know, they have, as you know, they have a good sized neurosurgery community.
And yeah.
Okay, Martin,
What I'm
gonna-
doing right now is I'm collecting all these email addresses from all these, conferences and webinars and stuff.
yeah, you can put
So
it
I'm
in
planning
the,
to send out. I'm planning to send out a group email, and giving some people, maybe not at the highest level, giving them an opportunity to do a lecture and stuff.
okay, I put it in the chat. Did you see the big message I sent you?
Let me see here. Chat, yes.
Yeah, in the Zoom chat.
So that, so it's on a playlist. Okay.
We're actually live on YouTube now.
I think it's streaming on YouTube as well.
Yeah, it's streaming on YouTube as well. Right now, we're on YouTube, right now.
Oh, we are on YouTube.
Because I just left the room open.
All right.
I left the room open. Hold on, there's someone at the venue. Let me see the person. Hello. How you doing? Oh, okay. Hello, how you doing? Can you hear me?
Are you talking to me or?
No, Martin, I'm talking to the person at the conference. Do you see the
All right,
person?
all right.
Yeah, let me just check there. Hello, can you hear me? Baptist Health, Baptist Health? You can't hear at all.
All right.
That's okay. Yeah, they're taking a lunch break now.
Yeah, I think they're taking a lunch break. Well, I'll keep the channel open, and maybe as we go along, it would be helpful to put this into the chat if they have some PDF link or something rather where it states what kind of lectures that we can expect, over the coming days, and even today. How long is it going to last? Do you know?
Yeah, 3 days. Today, I think to 2 o'clock. Another couple
Until
hours.
2 o'clock.
Yeah, or maybe
Okay.
longer. Hold on, let me check the schedule here.
Well, this is what I'm looking for, a schedule. I don't even have a proper schedule because
Okay, if you look on the page, do you take Facebook? Are you my friend on Facebook? That's where most of my stuff is at.
Right.
Yeah, yeah. Let's see, does that have the schedule?
I don't think they have anything. They just have on their advertisement they
Yeah,
have.
there, it's in there. I gave you the schedule. Look into what I sent you. There's a schedule.
All right, let me see.
It's the schedule,
Is-
and there's lots
you
of
put-
information on that
Right
website.
now, or where did you put it?
You don't like
You put it-
Facebook, right?
Yeah, but I hardly ever use it, to be honest with you.
Okay.
I don't even know. And Facebook is, because I don't use it much, then they want to verify me and they want to lock me out. And then they send me emails again. Why don't you use your Facebook account? and
I
stuff
know.
like that.
Well, you know, I have a running battle with Facebook because I basically spread the word, the news of conferences like this, which is
Right.
really their purpose is they build communities. And
Right.
they just shut me down today. They said I'm sending too many emails. I'm sending, you know, you shut me down for another 24 hours.
Well, I don't know. I really, I mean, this is just a technical matter, and then there are some more philosophical, ethical, and political matters with them, which are kind of questionable, actually. But anyhow,
Ethics, I don't know that word.
I don't know that word, right?
I don't know the meaning of that word. I never did.
Well, you know, there's, I don't know, whether it's appropriate to say this over this slide, but when you go into the history of it all, there was another sort of all my life or something rather in 2005 or 2004, and it actually came from DARPA also. And DARPA thought, you know, it might be a good idea. People put all their stuff onto a thing, and then it came out it was through DARPA. So then they found Mark Set, and they gave him a lot of money, and he's been terribly successful ever since.
Okay.
Yeah.
Yeah, I think we're in for some big changes that we can't even tell yet. The thing about it is, because Martin, I hang around the internet all day, all night. I'm always on it.
Right.
I'm not an expert, but you see things happening slowly, fast. I mean, this artificial information, man, oh man, intelligence. The thing is,
that's also.
it's making tools that are going to create changes. Right now, the internet global community, I feel, is making tools right now as we speak that are very powerful to build other tools that are more powerful.
Right.
So I think the tool making part of it's going to be the advantage of AI. It's going to put in our hands the unbelievable ability to access information.
It's advanced database techniques, you know, but the thing is, I have a certain fear that it will lead us back into something like medieval science, because what will happen is, you know, these large computers will correlate all sorts of things, but there's no consistent theory behind it, and hence it's not really, you know, and so we'll get totally confused because it will be taken from some real text, all mixed together, a big plagiarized soup of half-baked stuff, you know, floating around. Some of it, which is quite true and reasonable, and a lot of it being utter garbage, and it will send us back right into the Middle Ages, where people had no clear theory what science should do and should not do.
Well, you know, Martin, I think that people should get to know AI, a little bit about it, before they start really getting into philosophy and what's the dangers. I think that people really have to get to know it a little bit. But I will tell you, people that know what's going on have said to respect it and beware, which we will. But first, I want to learn it before I, you know, cast opinions like this is the end of the world. But even Elon Musk says it's got to be controlled, which is good.
Yeah, I mean, computers, you know, it's if you look at it as being sort of a a very sophisticated autocomplete or something of that order, well, fine, so if you look at it, as a human being, using your judgment, and then you say, okay, well, that piece of text here is, we can, we can go with it. But the big danger is that, a lot of humans are too lazy, and so we'll get into we're already in it anyway.
Yeah,
we'll
but so many people giving opinions, they don't know anything about it. They haven't used it yet.
Yes, there you go.
Get to use it, see it, feel it. But I respect what other people say, like Elon Musk and people like that say, be careful. It's scary and powerful. Be careful. And he's one of the leaders. He's one of the leaders that says it should be controlled.
It will lead to confusion. That's what will happen. I'm afraid of that.
Yeah.
But anyhow.
Okay, they're fooling around here with the conference. Is anybody presenting something, or we're actually getting recorded, Martin, but this is going to all be erased.
Right. No, I'm looking forward, for computing to do real stuff, but we need to have a theory of what's going on. I actually recommend, the old linguist guy, what's his name again, from MIT, what's his name? He had all these language models, and if you have time, you can find him on YouTube.
Send me the name.
Chomsky, I believe.
When you get the name, when it comes to your mind, just
yeah.
Let me give you my email just in case.
And he's really, anyway, it will be an interesting tool for certain things. And I don't think we will want to develop the next program to go to Mars using AI as it stands.
Yeah. Keep your seatbelt strapped, but get prepared. I'm studying. I'm trying to get to know stuff. Chomsky. Oh yeah, Noam Chomsky.
Yeah.
He's very, very. He's been around for a long time.
Some interesting things to say about it. From the theoretical.
Yeah, a lot of people. Hey, listen, I gotta go, Martin. I gotta do some things. Okay, I'll be back.
Sure. All right. Bye for now.
Yep.
our eyes, our surgeons did the procedure, but it's really on you guys to do those neuro checks in the first 24 to 48 hours. Because if a patient's fluctuating or they're deteriorating, they might have to go back for another angioplasty stent or another procedure. SOS. Huh? Was it really that bad? Oh, wait. That's. Can we go back to the first PowerPoint? The slide. I think we're on slide 13. Yes, perfect. Thank you. Okay, post-op complications, my favorite. So the first one we'll talk about is retroperitoneal bleeds. Retroperitoneal bleed is a hemorrhage in the retroperitoneal space. So risk factors for this type of bleed is trauma with a catheter, sheath insertion, too high of the access puncture, anticoagulation therapy, thrombolytics, right? So clinical manifestation, your patient comes out and pack you. You don't know that they have a punctured, you don't know where they puncture, but you do know that they're nauseous and they're complaining of back pain, and then they start becoming diaphoretic and tachycardic. You're like, oh goodness, what's going on? So first thought could be a retroperitoneal bleed. Later signs, you'll see like bruising of the flank. So your typical Gray Turner sign, abdominal distension with peri-umbilical ecchymosis, a colon sign. And then some will have pressure-induced femoral neuropathy, and that's caused by compression of the nerve in the psoas sheath. So those are some signs to look for. First thing you want to do is page neurosurgery, page neuro ICU. Go ahead and draw a hemoglobin hematocrit, especially if you are unsure if they're hemodynamically unstable. Type in screen or type in cross. We're going to get an ultrasound, make sure there's no dissection or pseudoaneurysm. And then I'm not going to say gold standard because I don't even, it's not like it when I say gold standard, but it is the test that we want. We want a CT abdomen pelvis. We're looking for a contrast, extravasation, any active bleeding, because at that point, we would have to call either IR vascular, and they would have to come in and potentially embolize if it's an ongoing issue. These patients will need neuro ICU care. They'll need neuro checks, hemodynamic fluid resuscitation, blood transfusions, close monitoring. So these can be bad if not caught quickly. Okay. So post-op complications, groin hematoma. I think we see that not so much anymore, thankfully, but access site hematomas, injury to the common femoral artery resulting in leakage of blood in the surrounding tissues. So this can occur due to a number of reasons. You can have trauma to the vessel wall during catheter insertion. You can have incomplete hemostasis, removal of the closure device too early, so like TR band, or if you're using manual pressure too early, and closure device failure. So failure of the deployment that can cause you to have increased risk of hematoma post-op. Underlying coagulopathy or use of anticoagulation medicine. The incidence of hematoma, so this study looks at 472 patients who underwent mechanical thrombectomy between 2005, 2014 with a sheath and a balloon-guided catheter 8 French or larger. So out of the 470 patients, 260 had TPA administered pre-op as part of their stroke treatment. And all of them, almost all of them had device closure. So 462 out of the 72, so about 97.9% had device closures. The incidence of a groin hematoma, even getting TPA before, even with device closures, was very low. Incidence is very low, regardless of the sheath or the catheter size. Part 2 for groin hematoma. So clinically, your patient is going to be complaining of pain in their area, their puncture site area, tenderness, swelling, firmness. Their leg, their proximal thigh will feel like a rock, like it's very hard around it. Ecchymosis at the puncture site. Some might have weakness, numbness, tingling in the affected limb. So if your patient says, I have no numbness, tingling, that might be a problem. So again, call neuro ICU, call one of us so we can come check it out. They can cause compression of the femoral nerve or other structures if the hematoma expands and starts pressing on the nerves. Presentation immediately post-op up to several days. This is something I'm super passionate about because these complications don't just happen like immediately post-op. We have patients that are downgraded to PCU and they start mobilizing more with PT, and maybe their closure device pops off. Maybe, it wasn't on there tightly to begin with, but now that they're up and mobilizing, they have a hematoma. So like a nurse in PCU, we always tell them, can you please just like put your hand on their groin once a day, make sure it's okay. Because a lot of patients, especially stroke patients that are now nonverbal and they can't communicate with you, like, ow, my groin hurts or something doesn't feel right. Like, it is our job to take care of our post-op patients when they're on the floor and make sure, be on the lookout for these. Diagnosis, clinical, firm tenderness of the area. We'll get a Doppler ultrasound to rule out an underlying dissection or a pseudoaneurysm. And then management, first line is going to be, doesn't matter if it's post-op, a week op, it doesn't matter. Manual pressure. So with two fingers, not your fist, you want to place it on the arteriotomy site, which will be proximal to the skin puncture. So if you think about it this way, you see a puncture in the skin right here, the needle, because it goes in a 45-degree angle, the arteriotomy site will be down here, about 2 to 3 centimeters above. That's where you want to hold pressure. You want to hold just enough pressure, subocclusive, but just firm enough to where platelets can aggregate, blood can run, and you still want to be able to feel the pulses. That's a myth. Like, you do want enough pressure to keep it down, but not enough to occlude the pulses. And then we have safeguards. That's just basically for someone to not have to sit there and hold pressure. It does the same thing. Inflate it kind of like a TR band and let it do its thing. And then second cases might need to consult our colleagues, IR vascular, to intervene. But that has not happened while I've been here. So good job, everyone. We're doing great. Secondly, pseudoaneurysm. So a pseudoaneurysm is a collection of blood that forms outside the arterial wall, and it creates a sac-like structure that communicates with the arterial lumen through a small defect or hole in the wall. The cause is typically a partial injury to the arterial wall, so like the needle poke. The incidence is low, but it can be high. So it's 0.5% to 8.7%. So a lot higher incidence than a hematoma. Signs and symptoms. So unlike a hematoma, what you're going to feel is, if you're checking the groin, you're going to feel a pulsatile mass, and that is that pseudoaneurysm. And it will be pulsatile because it has that arterial pressure. So it'll pulse, it'll be big, it'll be tender, and sometimes they won't complain of pain until they're up and walking, and now they have leg pain, but no obvious swelling or bruising. But we know now, because we are listening to this talk, that it could be a pseudoaneurysm. And also, like thinner patients, if you're putting your hand on their groin, you can feel sometimes that closure device because they're thin and a little pulse from the femoral artery. If you don't know if it's the closure device or a pseudoaneurysm, just give us a call and we'll likely order a Doppler and that will evaluate the size of the neck based off of that. If you have a pseudoaneurysm that's partially thrombosed already or completely thrombosed, usually we don't do any intervention on those. Those will take care of itself. However, if the ultrasound reveals, a wide neck or something like that, IR will then have to take care of it and then vascular surgery if it's pretty severe. And then all they do is this little picture is demonstrating the injection. So it's a coagulant agent that is directly put into the pseudoaneurysm cavity to promote thrombosis. And usually they can leave the next day with no problems. Thank you. Oh, surprise. Plot twist. I have a case study. Yes. And I had to scribble it out because I gave away what it was on the first slide. I was like, crap. All right. So that's my little doodle. You can scroll. Thank you. So a 63-year-old with hypertension presents with aphasia and right-sided weakness. NIH of 6. Last known well was the night before, so it was a wake-up stroke. Wasn't a candidate for thrombolytics. His head CT showed no acute findings. CTA revealed a left M1 MCA occlusion. You can see right there, the beautiful arrow pointing to it. So he underwent recanalization, thrombectomy, beautiful Tiki 3, and you could see full reperfusion. Great job. So post-op, he went to neuro ICU. He had some improvement of the speech. However, 2 hours later, his speech worsened. He had increased expressive aphasia and now right-sided weakness, which was worse than. Okay. So what in the crowd, what do you think could be a reason for his worsening exam? Reocclusion? Did you see it through my scribble? Yeah. Oh yeah, good. I know. That was a joke.
Bleed.
Good. You're
Everybody
listening.
said bleed.
Bleed.
Yeah.
Seizure, sometimes seizure, bleed. So what would you do if you expect any of those? What would be your first line of management? Oh crap, patient's now NIH is back. He just got recanalized, but now he's worsening. What do you do? That is a good, yes. So if they're in ICU, you can take them to CT scan. CT scan's good, negative. Then what do you do? CTA? I think we can scroll. I think these are on the next. Yeah. So, yeah, those were the differentials that everyone gave me because I have the smartest crowd in the audience. Okay. Post-op, CT, no hemorrhage, CTA, reocclusion, management. We're taken back to the angio suite. So let's go. Fast. All right. So because we suspect that he had intrinsic disease, which we would have seen on initial angio, we had to go back in. His vessel did shut down, so it reoccluded. And we had to fix this by angioplasty, opening up the vessel and putting in a stent. And you can see laser. There. The beautiful stent. And then this was his second PA for his run in angio, and then beautiful. Okay. And then the patient did well. He went home on aspirin and Brilinta, went home 3 days later, and Dr. Nema ran to him in the cafeteria, and it was just very cute and just very heartwarming. So the nurses, one of the nurses in ICU, they caught it with the beautiful neuro checks. They alerted us. the surgeon went right back down, fixed the problem, and he's out eating cafeteria food in 3 days. So that's why we do what we do. We can't do it alone, right? And we can go back to the next slide. I think it's just saying thank you and any questions for me.
Is there any recommendation regarding when you can re-access a vessel following angio with the
Kelts,
closure device?
yeah, I think it's pretty, I know Kelts say that you can like after it's already deployed, you can immediately go back in with Kelt device as far as.
As far as any recommendation, I'm not 100% sure every access has certain recommendation. Angels, for example, if it's used, they recommend 3 months, don't puncture that side. However, in reality, we typically, at least I typically re-access the same area unless there has been a complication. I'm gonna see what Dr. Hannah.
Just for the record, all the complications shown in this conference belong to Dr. Nima. We run a complication conference every year in Jackson Hole, and this is not a complication, it's a great save. So hats off to Dr. Nima and the team, right? Because it took recognition of the patient getting worse again. Unfortunately, sometimes it's missed. We really, this is the first time I hear about the angio suit 3 months. We don't pay attention to that, Diane. If we need to go back in, you just go above and below of the previous puncture. The Kelt is kind of cute because you have the little ring that is metal, so you can see exactly where you puncture. So actually use that for your guidance. What Ellery was sharing of the X-ray on the head of the femur. Now with the Kelt, you have a little piece of metal there. They can go and say, okay, that's the artery. So you can guide, that's on the vessel wall. So you can use that to guide your next puncture and re-access above or below. But with all these closure devices, Star Close, Minx, Vascade, you just go above and below and just, it's not a problem in general. Thank you, Eller. Great talk.
Thank you. Any more questions?
Yes, great talk, great job. So one other thing, you mentioned it briefly, but post-op patients, why is it important for everyone to know why blood pressure control is also very important?
Oh yeah, like immediately post-op. You're at higher risk for reperfusion injury immediately post-op. So whether that's thrombectomy, you're pulling out a clot, or carotid revascularization, you have to bring down the blood pressure to prevent hyperperfusion injury, which could then lead to like a hemorrhagic transformation or other issues. In the back.
So in terms of like training like nurses that aren't necessarily well-versed in procedures like this and like a newer program, in terms of like these delayed complications you see like a hematoma, pseudoaneurysm, whatnot, are there certain ones that are more common than others in order to like kind of teach them to look out for? And then like what is the time window, like, how far out can you expect to see something like that?
That's a good question. So typically if there's been, like, let's say a few times there's been device deployment failure, and then they hold manual pressure, NIR, main hemostasis, they come out, our PACU nurses, they're on alert that this might be a high risk. Let's keep them bedbound a little longer. Those typically will bloom, I feel like, faster. I don't know if it's because we have our eyes on them and we're aware, so we monitor them closer. But the ones that I feel like go miss when they go to the floor is the pseudoaneurysms. I mean, yes, some will spontaneously resolve and thrombose on their own, but sometimes they don't. And it's because you have to physically, a patient doesn't know, they don't see that thickness swelling on their proximal thigh like you can with a hematoma, but instead they don't feel their groin to the point where there's a pulsatile mass. They might complain of like leg numbness, tingling, because you might have some peripheral nerves being compressed, But otherwise, I would say the first few days we'll do hematoma. We'll see more hematomas and then later pseudoaneurysms. That's just my untrained experience, what I've seen. I don't think there's any references.
I think from everybody in the crowd, you gotta listen to the patient, right? Because it's not uncommon. This lady, second day, she's on the floor. I went to the restroom, I heard a pop on my groin. If the patient had an angioceal, you guys know the angioceal is a foot plate that goes inside the vessel, little suture that holds a gel foam plug that goes on top of the vessel. If this person heard a pop, go check the groin because there's a good chance that little suture broke. And that's a hematoma waiting to happen. And it's not uncommon to see that. Oh yeah, I went to sit down on my bed, I heard a pop, and nobody checked, and then an hour later have a massive hematoma. And as Ellery said, all these studies, these two guys here, as good as any closure device. Naturally, for the team, is a pain in the neck to be. We talk about 3 minutes or 5 minutes per French. So if it's a 6 French sheet, is 6 times 5 is 30 minutes of manual pressure there, no picking. Oh, let me see if it stopped bleeding. No, 30 minutes. It's time consuming for the team, but it works. So if you're at bedside, I'll never forget a lady. She had a massive pelvic hemorrhage. I was out of town. Critical care physician called me and said, Mrs. X is having a groin hematoma. I said, who's holding pressure on the groin? He could not answer that question. So the first thing that you have to put 2 fingers there and hold, and then get help. That you gotta listen to the patient because it can happen at any type of the episode of care. And manual pressure is a big time saver here, because if you can stop the hematoma from forming, sometimes it doesn't, right? But it helps a lot. So you gotta listen because the patients will give you sudden hint. We had one in the on PAC the other day. This lady was complaining of groin pain. I happened to be coming to talk to her and her family. She said, oh, my groin hurts. I went to check, and she looked at me and said, oh, you check really fast. I said, no, your groin nice and soft. There's nothing there. 3 minutes later, she's going to the restroom. Big hematoma. I said, ma'am, you jinxed me. So so it can happen at any point, and all of us have to listen to the patient because they can sense their body better.
Yes, that's a good point, Dr. Handel. Even like before we discharge a patient, me and Dr. Nima will ask the nurse to just mobilize with them around the department, because even simply mobilizing, they'll know, if they hear a pop, if things get bigger, if things get more painful, then we're not going to discharge them that minute, but that's something to be aware of. So can happen at any minute, any day. Always be on the lookout. And any more questions? All right. Thank you, everyone.
Okay. Valerie? Yeah, there's stairs. Don't fall. Our next speaker comes to us all the way from New Mexico. I have the pleasure of hearing Sam speak last year at the AAN conference. We keep forgetting, I think. Indianapolis. Okay. And he gives a really great talk on aphasia. I think you guys are really going to enjoy this talk. So I'll let him finish his introduction, but take the stage.
My controller. Hi, everybody. My name's Sam Mulata. I don't normally sign my name with all that shenanigans after it, but that's like hospital required that, bully everybody into the fact that you have a BSN, which I don't think makes you a better bedside nurse than an ADN. I'm just going to put that out there. And you're the only audience I've spoken to since August that knows what those last sets of letters stand for, so I won't go over that. Though some people think the MA stands for medical assistant, that's not what it stands for. I have a master's degree in linguistics, and I'm currently in a PhD program in linguistics. I actually have to write a paper while I'm here in Florida. But we'll get to that. What I want to talk about today is basically giving you a fundamental understanding of, and I'm probably going to go over 30 a little bit, probably closer to 40, but I'll do my best. Do I just click this to advance? Oh, look at that. I don't have any relevant relationships. We're going to talk about the general differences among aphasia, apraxia, dysarthria, right? The only people who really get these terms correct are the speech language pathologists, right? Because they actually go get a graduate degree and become speech language pathologists. And without stealing any thunder from the presentation I'm looking forward to later related to going through the NIH, we will actually relate this back to the sections of the NIH, because I realized, just like with cardiac competency, that my instructors in nursing school didn't necessarily know what they were teaching me. They were just like, just memorize your PR and your QRS and your QT. That's what you need to know. Same thing with doing the stroke scale, right? Did anybody go through the stroke scale? How many people, anybody, your preceptor, go through the stroke scale with you and really explain what each thing was? Or was it like, here, do this, ask the patient, ask the patient these questions, right? Lots of more nods on option number 2 there. Why are these topics important? All of these things occur in isolation or co-occur frequently with patients, right? It's hard to get them in isolation, but my goal is not to turn you into SLPs, but to at least get you a sense of what these words mean and get you to stop using the phrase word finding difficulty, because that doesn't mean anything. Just like confusion is my other soapbox. I was talking to some folks last night, right? Confusion doesn't mean anything. Oh, he's a little confused. Well, is he? Or is it a perceptual thing, right? So it is confusing for everybody. So apraxia is any type of motor planning disorder. We have gait apraxia, we have dressing apraxia. I'm going to skip over the video of dressing apraxia in the interest of time. Basically, breaking down the Greek, we have a meaning without, and praxia is action, same place we get praxis or practicum or practice from. The functional definition is the inability to carry out on request a motor act in the absence of any weakness, sensory loss, or other deficit involving the affected part. So this is a planning problem. Like, I've got to put stuff together in my mind to make words come out of my face, right? And this is separate from aphasia. Let me click through this. Okay, and I'm not going to play that one. Actually, there we go. So this is an impairment, specifically when we're talking about apraxia of speech. We're talking about an impairment in motor programming and sequencing of movements of the articulators for intentional or volitional speech, right? Your articulators being, you've got cranial nerve 5 and 7 and 10, and you got a bunch of 5 different cranial nerves controlling your ability. But you also have this area in your prefrontal cortex that is able to put stuff together. The main thing that you'll notice when people have verbal apraxia is they will say things differently. You say baby, and they say baby, boo, bo, bay, bay, bo. They can't quite get the things in the correct sequence. So this is a clip. Am I able to play it from here? Can I hit play on it? Will it work? This is Gina. I'm just going to play a little section. I want you to think about what her speech is like.
My name is Gina. I am 43-year-old. I am apraxia speech. I have stroke.
Okay, so I'll stop there. What do you notice about, I didn't define my term, prosody. The paper that I have to turn in later today is just on prosody. I took a whole class just on. What is prosody? Prosody is the pitch contours of how we speak. So when you know that I'm asking a question, or when I'm angry, right? Or when I'm being sarcastic, right? Those are aspects of prosody that carry meaning. In her case, I'm just talking about the pitch contour. What does anybody, you can shout out freely, what does anybody notice about her pitch of her voice? Unsure, it's all over the place. Yeah, there's a lot of rising and falling. You can see her struggling, almost looking up to find the words. This is different from expressive aphasia, as I'll show you. And her articulation is kind of halted, right? Almost more like a stutter. So that's what apraxia, that's where somebody's unable to put the pieces together to make the speech come out in a fluid stream, but she's not having trouble finding the words. You can tell what word she's aiming for, and you're like, oh, you almost got it. Because she's like, apraxia, right? Different from expressive aphasia. So, oops. This is, again, I could talk about this for hours, but 45 minutes is my limit. So with dysarthria, we're talking about the innervation, right? We're talking about muscles. We're talking about all the things that cranial nerve 7 is responsible for, all that stuff with facial articulation, but also 9, 10, and 12, your ability to form the sounds, your ability of your vagus nerve to innervate your voice box, right? Your ability to actually phonate. In addition to your ability to move your tongue in a symmetrical manner, cranial nerve 12, just your ability to open and close your mouth effectively, to be able to get sounds out correctly, the different phonetic parts of English. And muscles can either be spastic or they can be flaccid. In the interest of time, I'm not going to go through those spastic or flaccid examples, except to say that with something like ALS, that's where you have flaccid dysarthria. So when you ask the patient with ALS to say, my baby ate a cupcake on the train, they can't get those what we call stops in phonetics. They can't get the cupcake. They get right? On train. They can't get the full stop the way that somebody with spastic dysarthria has. They get the stops, but they can't quite get the other sounds, you know, rhythmically together. Does that make sense? Okay. So just to do a little test of your own dysarthria. And I discovered in a psychology of language class, I can't say this stuff out loud, or it triggers your brain in a different way. If I say it out loud and you hear it, you're going to be able to do it better. So I'm not going to say it. So everybody say this out loud. Right? Tom threw Tim 3 thumbtacks. I do a pretty good job with it because I've been doing this, you know, practicing. How about this one? This is interesting. Since you're all doing it in unison, I think you're doing a better job of it. Somebody outside is going to be like, what is happening in there? These are a little bit easier to say. Okay. I'm going to report back to the chair of the linguistics department that not only do I improve your performance by saying it out loud before you say it, but you all sort of collectively seem to help each other. It's sort of like everybody eventually settles on a key of happy birthday. When you're all singing happy birthday, everybody, we kind of start off all over the place and then we all simmer into, you know, down to a nice space. So quick, what's my pointer? So there was a little confusion when I did this presentation before that I was mapping the brain. I'm not mapping the brain here. This nice colorful arc over the top of this head is front to back articulation. And this is the International Phonetic Alphabet. This is not to be confused with India Pale Ale. These are a different kind of IPA. This is the letters that we use in phonetics when I'm transcribing the way that somebody actually talks, right? The sounds that we actually make. So you can see those bilabial stops at the front of p and b, right? That's a bilabial stop, meaning I have to be able to get both my lips to close the airflow so I can get a p or a b. Then we get a little fluid with a m and a w, right? That's a little bit softer. Then f and v, where I actually get my lower lip and my, this is a labiodental. So you get your lower lip and your teeth to make the sound, right? Then you have th and the alternate being, you know, one is voiced, one is voiceless. T and d, obviously in Spanish, this is different. te and the in for native Spanish speakers, right? But for English, it's a t and a duh. S, z as in zebra, butter. Nobody says butter, right? You don't pronounce the T. We call that a flap. Ladder, right? If you're English, maybe you say properly, butter. But nobody says that. It's a flap. So we identify it differently than ladder, butter, burrito, right? Where I come from, we say burrito, right? My friend from Tennessee came and ordered the burrito. And I was like, I've never heard anybody say it like that before. But then we get to these hard letters like r and sh and j. It's a little bit harder. Native speakers of Japanese don't differentiate between la and r. It's pronounced depending on where it is. So, when people do the sort of stereotypical Japanese accent, there's a reason for that. It's because phonologically, that's the same letter or same sound, the same phonetic sound in Japanese. And then ka, ga, it's kind of nice. They make the N part J, part N when they spell it, right? But that's an And then we go all the way back to ha and uh-oh, right? Different cranial nerve controlling this back here. The fact that, native Arabic speakers, much more important sound in Arabic than it is in English. The only example I can usually think of in English is uh-oh, right? That we actually make the stop in the airflow back here. So why do I go through this? Well, then it starts to make sense when I'm going to skip over this stuff in the interest of time. We're going to come back to that and think about that articulation when it comes to the stroke scale. Because did anybody ever explain to you why it says Mama Tip Top Thanks Huckleberry Baseball Player? Because it sounds like who wrote this? How down to earth? I heard him speak on the radio last night. And then why is the lady who looks like she's on too much Valium washing dishes? She's like the 1950s mom who gets amphetamines in the morning and Valium in the afternoon, and she's washing dishes while the kids are like knocking stuff over and about to wipe out, and she's just like, there's a reason for these pictures to be, there's a reason, there's a method behind it. So the main thing that I want to talk about is aphasia differentiated from these two things, right? It's really important to think about, there's 4 defining characteristics of aphasia. It's acquired, okay? It has a neurological cause. It affects reception and or production, and that's across modalities. I used to have a woman that I would co-present with who was born deaf, and the same genetic condition that caused her to be born deaf. She had some sort of PFO or some other sort of anomaly. I don't know what it was. She didn't know what it was. But when she was 25, she had a stroke, and she had expressive aphasia in sign language. So it affects it can affect all modalities. And it's not a sensory deficit. It's not a motor deficit. It's not psychiatric, and it's not an intellectual disorder, right? We can certainly have people who have aphasia who have cognitive deficits. But when we're really purely defining aphasia, it is not a cognitive deficit or intellectual or psychiatric, sensory or motor, right? So read this aloud. I don't know if anybody's a Lewis Carroll fan. Okay. So I can tell who's read Lewis Carroll and who hasn't. This is from Jabberwocky, and I like to include this one because it's got some English in it, right? You're like, well, okay, it was the night before Christmas, and all through the slithy toves. So there's some aspect that you're able to comprehend what Lewis Carroll was writing here, right? And you manage to stumble your way through it because you're actually reading. So now, Kanye West has narcissistic personality disorder. All right. That was super quick, right? You're able to read that, even though it's busted up English, and, make your way through it, because all of the parts are functioning of your ability to do this, right? You're able to hear me. I'm also referring to Kanye West and not Lewis Carroll or, somebody else that's, something that's like already kind of simmering in your consciousness a little bit. I try not to think about him, but I just, it's impossible not to have some incarnation of Kanye appear in your life in 2023. So You've used a lot of different parts of your brain. Traditionally, we look here at, area 11, we talk about Wernicke's area, we talk about Broca's area. That still holds true, but it's a little more complicated than that. I'm not going to go into the detail from Greg Hickok there in 2009, but turns out that our processing of language is a little more complicated and a little more bilateral than we previously thought. It's not just straight up Broca is the little factory where the little the little words get put out and then they come out your face, right? It's a little more complicated than that. But there is something to the lateralization of language. And so we still think about those Brodmann areas that correspond to Broca's and Wernicke's area. For the purposes of our purposes, anybody a fan of the Joanne Hickey Neuroscience Nursing book out there? A couple of hands go up. That was like my intro to neuroscience nursing 17 years ago. This is a very simple explanation, but accurate enough for our purposes today. Reading out loud, you're reading Lewis Carroll. It goes into your eye sends the message back to the visual cortex that's like, hey, I sort of recognize, well, I don't know, is that English? Well, that is, but that's not, but I can sort of choke through and I can sound it out because I recognize that alphabet and some of those words I recognize. Right. And that goes to Broca's area that sends signals for you to, formulate that speech. And then same thing with listening and repeating. Right. Goes into the auditory cortex bilaterally, gets sorted out and gets processed predominantly on the left side in an area roughly corresponding to Wernicke's area. But again, there's this dual stream model. Things are a little different. The form and meaning thing, there's actually two simultaneous streams happening in the brain. But for today, we'll just talk about Broca and Wernicke. Don't forget the homunculus. Think about, if you actually mapped our human body according to the amount of real estate that the brain takes up, this is what our bodies would look like, right? Hand and facial movement is of top priority for the brain. Now that we walk around upright, it's pretty important that we can do all kinds of cool things with these, especially because we got opposable thumbs, But this also corresponds to the areas that are most often hit, roughly a little under 7 out of 10 cardiogenic embolic strokes hitting this area. So I know that, who are my bedside nurses? Okay. Fair number of bedside nurses. Everybody's got some bedside experience though, correct? Obviously you don't go in and do a full language assessment. You order a speech consult, right? But for the sake of categorizing this information in your brain and thinking about what you observe in your patients as you see them, right? The 6 categories for nursing assessment of language: fluency, comprehension, repetition, naming, reading comprehension, and writing. These are different ways that language is understood, and then, and how it's processed and encoded. And, there's a decoding process for language and there's an encoding process for language. And there's different factors where things can go wrong at different parts in that chain, right? Fluency, asking the patient to describe his or her work or house. Don't ask yes or no questions. We all know that because somebody, can you tell me your name? Yeah. What's your name? Yeah. Right? You want to ask, what did you do before you retired? Something that's spontaneous. And fluency is one of those things that is, is there a clinical significance between 99 heart rate, sinus rhythm 99 and sinus rhythm 100? No, but we got to draw a line somewhere with what we call tachycardia, right? So fluency is one of those things. How many words does somebody get out? People are faster talkers than others. I just learned this semester that the average speech rate, not for me speaking up here now where I'm going a little faster, but we speak at about 4 to 5 syllables a second, roughly. And you can see when people are talking, that fluctuates when you actually measure that. But so fluency. So now maybe this makes a little more sense. You're asking your patient to describe what's going on in this picture. And you can get some sense of fluency here. Now, you might have a right hemisphere damage patient who does not see the kid with the cookie jar, right? This picture is called the cookie thief. For those of you that don't know, it actually has a name. It's not the over-medicated mom from the 50s, which is what I usually describe it as. This is, so you may find other things incidentally with this, showing this to a patient, right? If they're not describing the kid who's about to wipe out, they only see the right side of the picture. Maybe they've got a right hemisphere issue going on there, but the purpose of this is to see how can somebody spontaneously interpret and speak what's happening in this, right? So word comprehension, what are the ways that how do you all test word comprehension? What's one of our number one ways of testing comprehension? Following commands, yeah. Show me two fingers, right? And we still accept it when, depending on what fingers they show, and if you don't specify, TBI patient might give you, I still give full credit, right? I give a lot of partial and full credit in neuro assessments. So point to your nose, point to the thermos, knock on the door. You can do a little memory testing in here too. Are they able to remember 3 commands, right? Repetition. Are they able to repeat back when you say dog, dog, right? Chocolate chip cookie. I had to change it for this audience. I say biscochito at home, but nobody probably knows what a biscochito is here. So Christmas cookie in New Mexico. Naming, right? Naming is really important. Can you name familiar objects? Right? This makes a little more sense. When I auditioned for my current job as nurse educator 6 years ago, I've been a nurse since 2007, and then I've been working in clinical education. We have a huge education department, and I'm really spoiled because I get to run my own show as far as all the stuff I get to teach, all the different levels from ICU to outpatient, and I get to customize it all, right? But a nurse that I worked with for, I don't know, 7 or 8 years, when a staffing nurse said, "Hey, what's the deal with this glove and stuff?" And the nurse said, "Oh, we're testing visual acuity." I was like, "No, we're not testing visual acuity. You already did that. If you did this thing, we've already tested visual acuity." This is the language section of the NIH stroke scale, right? So we're testing, can they name? It's worth noting that I think it was in the Philippines, they had to change this around a little bit. They found that it was not appropriate because these things were not easily identifiable. I don't know how much cactus you have in Florida, but you've all seen Wile E. Coyote, right? So you at least know what a cactus and a ham, and if somebody says swing instead of ham, I give them, all right, you're in the ballpark. How often do people say the word hammock, right? But can they at least identify it? Or hand instead of glove, right? So checking for anomic aphasia. I'm going to do a big old reveal at the end where I'm going to show you location of lesions associated with types of aphasia. Right. So reading comprehension, having somebody read from the newspaper, asking, giving them a command written down. I don't know how many, has anybody ever had a patient that doesn't understand you giving a command, but if you write, close your eyes on a piece of paper and you hold it up to him, then he can close his eyes, right? Not uncommon. So now you know how down to earth I got home from work near the table in the dining room. These all seemed random to me. The glove, the key, I was like, what is, not to mention, thanks Mama Tip Top, thanks Huckleberry baseball player. Writing, again, you're probably not realistically going to do this, but sometimes it's the only way you can communicate with your patient. I had a guy with Wernicke's aphasia that was a little bit better, but not much better, a little bit better with written communication. Right. So the thing that stands out here is what out of these 4 things, what's the one that stands out that's different from the other 3? And the other 3 are the same as far as what they're assessing. Yeah, Mama Tip Top 50-50, right? Because what we're doing there is we're actually going back to this, right? Everybody say mama and think about what part of your face you're using to make that sound come out. Mama, that's very simple. Can you get your lips to close together? Right? Then we get progressively more complicated. Everybody say tip top. So you got to get a t and a p with the nice vowel shape of ah in between, which is very simple. Tip top, right? 50-50. You got to can you get your lip against your teeth enough to create a fricative? F is a type of fricative, voiceless fricative. V would be the voiced fricative, right? Thanks. Everybody say thanks. Pay attention to what your tongue does. Thanks, right? Huckleberry. Baseball player. right? It gets more complicated. If you weren't clear on why those words, neither was Genentech. Genentech originally just translated the words into Spanish. Mama, lo mejor, mitad de mitad, gracias, arándano, jugador de béisbol, right? That's not the point. The point is mama, tetati, mitad, gracias, árbol, futbolista, right? To actually get those sounds that move all the different articulators, because maybe your stroke's not that severe, but you got a little bit of dysarthria, right? And it's especially tricky because you might have somebody, those folks with lower medullary strokes, they might not even aspirate, right? I mean, they don't show signs of aspiration. I'm sorry, let me correct. They could totally be aspirating, but they're not showing signs of aspiration. Those lower medullary strokes where you've got, 12, they may sound pretty good and they don't immediately, cause a concern. So how do we put all this stuff together? We usually put it together in a big old map like this. Nobody uses these terms. I don't expect you to use these terms. SLPs don't use these terms except in research, not so much in the clinical setting, okay? So I already said about fluency is relative. Here's an example. I just want you to, I'm going to play you 2 short clips. Expressive aphasia here. Is it going to do it? Oh, do I play? Oh, there it is. Sorry. This is Sarah. She had a stroke at 19.
So what's your name? Scott. Oh, no. Sarah Scott, that's right. And how old are you? I can't. Try. I can't.
Mom with the video camera.
And what happened to you? Stroke. You had a stroke last year. Yeah. What happened? Can you remember what happened? School and English class. Okay. And I book and I read it around. But I can't because stroke.
Okay, so what do you notice about, does she have any dysarthria? Good, proper received pronunciation, we call it that accent, that British, proper British accent, right? Nice received pronunciation accent. She's getting the nouns down. She's kind of missing some stuff, but she's putting it all in order. Like his school and book and English class, and I read aloud, but I can't because stroke. So you can piece that together, right? It's your ones with really heavy duty, very dense expressive aphasia that you're like, come on, give me something, right? But in her case, there's no dysarthria and there's no apraxia of speech, right? She's just having a hard time getting those words, finding the word and saying it and getting it out, right? So much, much less fluency. We don't like to use the term Broca's aphasia for this. This is expressive aphasia. This is non-fluent aphasia, totally neurologically intact. She's made a great recovery. This video is from quite some time ago. She still has problems with the cookie thief picture though. When her mom shows her the cookie thief picture, she still has trouble spontaneously talking about it. So hold that thought on expressive aphasia. Now here's a little guy Here's a little guy that we've all taken care of, somebody like this. And you can imagine people might think there's a cognitive deficit here when there's not. This is a guy named Byron, right? I want you to think about what you notice about his speech, what's missing, what is there. Does he understand what's going on? Does he understand what's going on, like the setting, right? He's so cute. You've seen Byron before, yeah.
Hi, Byron, how are you? I'm happy and you're pretty. You look good. What are you doing today? We stayed with the water over here at the moment, talk with the people, with them over there. They're guiding for them at the moment. But they'll stay in the moment. You have water for him. With luck for him. So we're on a cruise and we're not. We will store it right here and they'll stay right there with them. And what were we just doing with the iPad? Right at the moment, they don't show darn thing. This is the iPad that we were doing. Right here. I've got my change for me and change hands for me. With him, I would talk with Donna sometimes. We're all with them. Other people are working with them. I'm very happy with them. This girl was fairly good and happy. You know, I play golf and hit other trees. We play out with the hands. We save a lot of hands on home for people for us, other hands, of what you get, but I talk with a lot of hands. Sometimes I talk of any more to say. All right, thank you very much. Thank you very much. I appreciate it. I hope the world lasts for you. Thank you. It's been a pleasure. Bye-bye. Have a good day.
Sounds kind of ominous, right? I hope the world lasts for you. As he looks behind you, up at, but that's how you know that he's in there, right? He knows he's having a conversation. From a psycholinguistic standpoint, he's making eye contact. He's acknowledging turn taking, but he doesn't quite understand. What were we doing with the iPad? Right now, don't show a darn thing. Hang out with Donna sometimes and play golf. I have a lot of hands on hold for him, So it's fluent, but you can imagine the, now the obvious difference here is post-stroke depression occurrence, is greater in which population, right? He's in pretty good shape. He's, emotionally, he's in pretty good shape. Sarah, maybe not so much, right? But it's all in there. He does all of the right things. We have this thing called phatic speech, PHATIC. It's the thing that you do where if I run into any of you, because I only know Wendy, really. If I run into any of you and you say, hi, how are you today? And I say, great, thanks, right? Even if I'm stressed out and my life is going, I'm going to be like, how are you today? Fine, how are you, right? It's this ritual. So he says, I'm happy, are you pretty? So it's functioning, the psychosocial aspect of speech is functioning, but the words he's just grabbing whatever's in there. He's just like jumbling around with it, right? So this is a really nice picture by one of the professors in the speech and hearing sciences department at UNMH that I like that kind of sums it up. The thing that has been updated is instead of a yes, no up here, where we have the green circle and the red hexagon, is functional and poor, not yes or no. Is there fluency? Is it functional or is it kind of crummy? Because it's not an either or, right? So you can see with the wrap up here, you can see like if you've got no fluency, no comprehension, no repetition, then you've got global, you've got like a big, dense, large, elvo that just took out the left hemisphere. As opposed to these areas, and it's interesting, transcortical motor. Anybody have any idea? Bonus question. Anybody have any idea what the transcortical motor, what kind of stroke might cause that? What kind of infarct might cause that? A watershed infarct between the ACA and the MCA. That's where we get very particular presentation with watershed infarcts of language deficits. But otherwise, hopefully, does this give you a nice, I'm assuming you guys are going to send out slides. If you want these, I can send them to you, or I don't know if Wendy's got them. Boop, boop. So basically, these symptoms tell us you have a certain expectation of where an infarct is, what the deficits are, whether it's expressive aphasia, whether it's receptive aphasia, fluent, non-fluent, what apraxia looks like, right? The reason why it's good, I think, just to have a baseline better handle on these terms is that you can monitor a little bit better as your patient gets better, right? Or if they don't improve. But of course, it takes a village, and speech pathology is going to be the ones who are really on top of it. But I think it's good for us to know what they're looking at and what these terms mean, so that when you get report from the critical care person or the person that's not a neuro person, that's like, oh, he's got altered level of consciousness and he's mute. Well, how long did you wait for him to answer your question when you said, what is your name? Before you went on to the next question, right? That true story during COVID had a guy with a stroke that they were like, he's got altered level of consciousness and he's mute. And I was like, I don't know, let's try this again. Let's go in, hey, where do you live? Because he had a gown on from a rural area in the Navajo reservation, said Shiprock, New Mexico. Where do you live? Waited 10 seconds, Shiprock. Ah, see, he's in there. He's not cognitively impaired. He has expressive aphasia. And his stroke was so far forward that he didn't have upper extremity weakness, so it was extra confusing for the non-neuro folks. So that's pretty much all I want to say about all of this stuff. I wanted to stay within, we've got 8 subtypes, and like I said, this co-occurs with other deficits, and most of those subtypes really only matter in the setting of research. SLPs don't really use all the transcortical stuff. We really talk about expressive or receptive when we're talking about aphasia, as you know, when SLPs are talking about it. I'm not an SLP, I just said we. I don't mean we, I mean they. Okay, and I'm happy to take questions. Yeah. Oh, yes. And I can repeat your question back for the. Mhm.
How long do you think is an appropriate time to give somebody else to answer this question? Once again, I'm familiar with this patient, and I know that you have a little bit of a delayed response as for baseline, so everybody's trying to check off, oh, that's the name of response. Different than our long, we ask the question of what is an appropriate amount.
That is a great, so the question is, what do you think is an appropriate amount of time to wait for somebody to respond? I will tell you, when I hired on as an educator, I was told to wait 7 seconds when asking a group of people to answer a question. COVID online turned that into like 20 seconds, turned it into a showdown. Like, I will wait here in utter silence until somebody answers my question. But I think like a 7 to 10 second rule, if you can start to see them trying to articulate, if they're not in there and they're just kind of like, you know, somebody with Wernicke's is going to just start saying they have a lot of hands on hold for ham or whatever. But somebody with expressive aphasia, that's a really good question. You know, this guy, it took him a while to get it out. And it's also really important to ask simple questions. In the case of this guy, the critical care 3rd-year resident came and said, you know, Mr. So-and-so, would you like to be on your left side or do you want to be on your right side? Which way would you like to turn? I was like, hold up. Sir, would you like to turn that way or this way? And he goes, and we turned him, right? So a lot of it is processing, minimizing, because keep in mind, the brain is also, you know, at a deficit. Just processing is down, right? It's running on Windows 97 sometimes. And so I would say at least 10 seconds, but that's totally anecdotal. Any other questions? Yeah. Oh, absolutely. The other, if you think of apraxia, the video that I was going to show, but in the interest of time, ooh, I'm out of time. In the interest of time, I didn't show it, but if you think about what it takes, you know, for a jacket is thrown, for people watching at home, I'm throwing a jacket on the podium. You have to be able to look at it. I know it's a jacket, and I have to be able to be like, all right, my arm's got to go on the opposite side, and then I got to flip it around like this, and you don't even really think about it. Or getting in your car and starting it is a whole sequence of that's not, you're not even conscious of. But with apraxia, you know, being able to sign, being able to finger spell, that can totally, those can co-occur for sure. Are we good? Okay. All right. Thank you very much.
Thanks, Sam. That was great. You guys, we can do more questions later. Obviously, we do have the reception afterwards, so feel free if you do have questions, just save them for then. I hate to cut you off, Sam. It was a really awesome presentation. But next, I'm going to introduce Diane McLaughlin, who is a nurse practitioner in our neuro ICU. She is the only nurse practitioner that has been named a fellow of the Critical Care Society, Neurocritical Care Society, sorry, and a fellow of Critical Care Medicine. And she's one of our Gators 40 under 40. So go Gators, and congratulations, Diane. And thanks so much for talking with us today.
All right. So I see some familiar faces from yesterday. We're going to talk about cerebral edema today, which is a little bit different than elevated ICP, and we'll talk about those differences soon. I have no disclosures, but again, I'm open to any if somebody wants to offer me something to disclose. Objectives, we're going to talk about the different types of edema, what as nurses you can do without anybody telling you to do it, how we manage with medications, and then why we employ surgeons. All right, so this is cerebral edema. It's easy enough, right? So the simplest definition of this is that there's extra water in the brain. The question is going to be whether it's intracellular or whether it's extracellular. There are different types, and we'll go into this, but pretty obviously this is a swollen brain, right? Well, how can you tell when you have a whole head of hair and a skull? So how do you guys tell? Do we just, everybody that comes in, assume that they have cerebral edema? What kind of aphasia is this, 7 seconds? All right. All right, so first place is a physical exam, and we're going to rely on you for that. So what are physical exam findings that you might find in somebody that has cerebral edema? Headache. What was that over here? Lethargy, like, what else? Say that again, worsening symptoms? Good. I mean, usually the ICU table says fixed dilated pupils and coma, which is pretty much screwed, but so really it could be super subtle. Any change in how that person is can be a sign that the patient has cerebral edema. And it could be really cool little findings. Maybe it's something linguistic. Maybe it's that the patient all of a sudden is staring off. They could be seizing. It could be anything. So they have kind of a tough job when you're going in there every 5 minutes and doing your neuro exams. What about vital signs? Are there any vital sign changes that might occur? Have you guys heard of Cushing? Yeah, too late. That's good. All right, what is Cushing's triad? You get a reception if you get this right. Okay, so close. It's actually hypertension, bradycardia, and then respiratory changes or bradypnea usually. And then you also have subtle things sometimes like some ST changes. You can have T-wave inversion. If you come to me with a 12 lead with T-wave inversion, my first thought's probably not going to be, oh my God, this patient has cerebral edema. But it can happen. And sometimes people aren't aware that those changes have nothing to do with the heart and all have to do with the brain. All right, so how do we measure cerebral edema? We know, we basically said there are a bunch of subtle signs that can mean anything, but could be. So how do we actually tell? In the world we live in today, these patients are going to get imaging, right? Usually a CT, and you might have subtle findings on the CT. It could be anything from seeing effacement of the sulci. It could be, you can measure optic nerve sheath on the CAT scan. You can see the brain is shifted from one compartment to the next, which again is pretty late. And then ICP is a surrogate for cerebral edema. So you see the treatments that we utilize are going to be a little bit different to treat the edema than we would to treat elevated ICP. And then we have to throw, you know, some of you guys at night have seen me walk around with the ultrasound where you put it on the eyeball to look at optic nerve sheath because cerebral spinal fluid displaces when the brain's under pressure. So you can see that that actually dilates. And then MRI is a great tool because it actually tells us if the blood-brain barrier is intact, and it'll tell us whether we're seeing cytotoxic edema or vasogenic edema, which are the two main types we're going to talk about. There are other types. If there's interstitial, there's osmotic, but these really are the two mainstay types of edema you should be aware of. All right, so cytotoxic. So cytotoxic edema, and this is a diffusion weighted image on MRI, and usually associated with ischemic stroke. This is where the blood-brain barrier is actually intact. And what happens is there's disruption of the sodium-potassium pump. And so all that sodium sits within the cell and it draws fluid in. And so our treatments are going to be based upon swollen cells. And so when we look at DWI, what we're looking for is to see, does fluid diffuse into that cell? And you can see when on this particular sequence, when it shines bright, that it's saying that there's no diffusion in. Most commonly, we associate this with infarct or ischemic stroke, but there are other things that can also cause this. I mean, usually if you have something sitting there, you're not going to have a lot of water diffusing into that. But when you see us looking, this is going to tell us that there's an acute infarct there. So vasogenic edema is a little bit different. This, we have disruption of the blood-brain barrier. And so I think I talked a little bit yesterday about how when the body's under stress, and this is true in the brain as well, that the capillaries, the membranes become leaky essentially. And all of that fluid shifts out. And so the brain itself becomes heavy. So it's not intracellular. Now this is extracellular. And again, the treatments are a little bit different how to treat this. And here, when we're looking at MRI sequencing, you might look at flare. And this is something sometimes you can see even on CT, if there's a lot of edema, you see that all of differences in the white matter on CT, you're going to see changes. So gray white matter for cytotoxic, whereas vasogenic is white matter. All right, so what causes cerebral edema? Seems like a pretty exhaustive list, doesn't it? So essentially everything can cause cerebral edema. The ones that you're going to think of are going to be stroke, whether it's ischemic, hemorrhagic, subarachnoid hemorrhage. If somebody has elevated ammonia levels or portosystemic encephalopathy, somebody has high blood pressure and ends up with PRES, if somebody's hypotensive or if they've had a cardiac arrest, somebody's had trauma, if somebody has a brain mass. We can keep going with this. We could probably fill the next 30 minutes with different reasons that somebody might have cerebral edema. Oh, that's cute. All right. So what are your goals here of care? So because we utilize ICP as a surrogate, we're going to try to reduce it. Keeping in mind that wherever you're measuring that, if you're measuring it, might not actually be the best surrogate. So if you have a patient that has a mass in the posterior fossa and you have an EVD in, and that's supratentorial, is that going to give you a good measure of what the ICP is where there's something, a space occupying lesion? No, and actually that could be dangerous because it could cause the brain to shift up. So you have to look at markers that make sense with where your injury is. Next, we want to try to maintain perfusion. So sometimes there are these patients that we can't do a great job controlling ICP. And you'll see all of a sudden our focus changes. Before we wanted ICPs less than 20, and now all of a sudden we just kind of want the CPP greater than 60. That's not best practice, even a little bit, but you see that it happens on a regular basis in these patients that are difficult. We're going to watch these patients. These are the patients that you're going to be in the room much more than you probably want to be. And then preventing secondary complications. And so brain injury is a very dynamic process. How they present is not necessarily how they're going to present later. And as you've probably learned, the different peaks for edema occur at different times dependent upon the disease or the underlying pathology. So a patient that has an ischemic stroke might be a couple days in before you start to see it. And then in hemorrhagic stroke, depending upon your source there, it's actually believed to be two different peaks that happen, an earlier and then a late peak. And actually the type of edema switches from cytotoxic to vasogenic. So the treatment strategies change a little bit. The brain is also super, super sensitive to any other changes that might happen. So we know the brain needs two things in order to thrive. So glucose and oxygen, so pretty simple. And so if we do a bad job managing those things, then it's going to have complications later on with how the patient does. Does this look familiar to everybody in the room? 7, 6, 5. All right. All right, so this is Monroe Kelly. So this is going to be review. But I'm going to talk about this because I'm going to give you the analogy that I like to give families when I'm trying to explain this. So you'll get the detailed explanation. And I'm going to give you the very simplified version, which is that there's only so much space in the skull. You have about 80% brain tissue, 10% spinal fluid, 10% blood, which are your vessels, right? And automatically your brain is going to try to compensate for any changes that might occur. So all of a sudden you have a new mass there, you have a new bleed there, a hematoma that's formed, you have a new infarct there. Then your brain's going to try to increase venous outflow. It's going to actually stop producing as much spinal fluid. And that works for a very short period of time. And that's when we come in and our therapies try to help adjust the contents of the skull as well. So when I'm talking to families about this, I say, if I hit my hand as hard as possible, I don't know why I would do this willingly, what's going to happen? Yeah, so it's going to swell. And it probably is a form of vasogenic edema, but now if I take that same hand and do that, but I have a really, really tight glove on, what happens? Yeah, it swells worse. And I'm cutting off circulation now, where before I could double the size of my hand and probably carry on about my day. The second, I have compartment syndrome, essentially, right? And that's what happens with the brain too. If you keep the brain, everything swells up. It's in this tight box. It's essentially like you're getting compartment syndrome of the brain. And so there are only a couple things that you can do to help that, but you're also causing a completely different set of injuries. So your brain is shifting into what would have been healthy tissue, and now you have damage there as well. And so that's what we're trying to mitigate. So what's the simplest thing that you can do? Sit up. And why does that work? So venous outflow. So you sit up, you keep your neck. You'd be shocked how often we hear about patients in ICP crisis and they're what we say is the taco position, where their legs are way up in the air and then they're folded kind of like that. And they are at the top of the bed, which is probably why they're in that position, but they're folded like this. And all you do is move the head a little bit and all of a sudden the ICP starts to come down. It's really simple, right? But we forget it because we start to worry about the numbers more than worrying about the patient. And that's something you can do very easily without anybody else. Kind of something that's changed over the last 10 years is this idea of hyperventilation. It used to be kind of a mainstay, and we still utilize it in short periods of time. And the reason it works is it causes vasoconstriction. The reason that it's bad is because it causes vasoconstriction. So it's a very temporary fix to a problem. And now we're only driving that CO2 down to 30 to 35 because you can actually cause cerebral ischemia as well as lowering pressure. All right. So in order to keep the surgeons employed, what can they do to help us? Easiest thing is they open the box. They open the skull. They take a piece of the skull off. Problem solved, right? And then we actually have an external herniation that occurs, which is a good thing because it means it's not going to press on the good side of the brain. And actually, even in trauma, sometimes you'll see they have like a basket handle that they have removed both sides. There are a lot of nursing considerations when you take somebody's skull off because you have a very sensitive area that's unprotected. But it works. It's a really simple solution. So maybe less simple, but it still works. If you look at that glass, if we want to reduce the overall contents there, what are some things we can do? Well, we can take out the mass. So you take that ice cube, lift it out, whether it's actually a tumor, whether it's a hematoma, you evacuate that, and all of a sudden the entire contents of that skull go down. It's the same principle when we're removing spinal fluid. We want to remove the overall contents, and you can see which is going to be more effective, removing the ice or removing the liquid. Yeah, so you get a little more bang for your buck that way, but you still can reduce the overall contents and then theoretically pressure by removing fluid. All right, so what can we do on the medical side? Essentially, most of our treatments involve dehydrating the brain. What are some other things before I move on? This is where the difference between ICP management and cerebral edema management comes into play. I know as a nurse, my favorite thing was sedating the patient. So that doesn't actually do anything for edema, but it does for cerebral metabolism. It quiets everything down. You're lowering pressure in general. Something that we saw in trauma, but I don't really see in most neuro ICUs is giving a neuromuscular blockade. And actually, there are no randomized controlled trials that show that that does anything to improve elevated ICPs, but it's still something that you see fairly often in somebody that has refractory ICP issues in a trauma unit. You want to go big, pentabarb. It's like the neuro equivalent of unplugging something and plugging it back in to see if it helps. Sometimes it does, which is probably also the equivalent when we try that. So back to our mainstays. I will tell you, I spent about a year working on the guidelines for cerebral edema, which means we screened probably 1,000 studies looking at hypertonic saline versus mannitol. And I will tell you, there is a slight edge to hypertonic saline. And even since that's come out, there's been some changes about how we can administer that. And you can see hospital policies are starting to shift this direction. It used to be that you could only give hypertonic saline through a central line. That has been debunked. And it was kind of extrapolated from TPN data anyway, so it wasn't necessarily good data to support that it had to be given through a central line. There are a couple different formulations that we can give this in. 2% used to be thought to be a little more friendly to peripheral veins, but now we know that's not true. So we can give 3%. We can give it as a continuous infusion. We can give it as a bolus. We can actually give 23% as a bolus, because think about it, it's essentially like a brain code. Would you give an epinephrine drip through a peripheral? Nobody would be super excited about it, I bet, but would you push epi in a code? Yeah, so it's the same principle. I'll just make sure you have good working IVs. You can also give it IO. There's published data on that as well. And then you see I kind of threw sodium bicarb in there. So my guess is everyone here works in a hospital system that has some type of hypertonic saline readily available. Is that true? 7, 6. Okay, I'm seeing nods. If you don't, and because it's readily available in a code cart, you can use sodium bicarb in order to drive your serum sodium up. You would give, usually it's about 2 amps, but you give 1 mil per kg, and it would be like giving a hypertonic bolus. So there are little things that you can do in the field, in the emergency room, that if you just need something right now and you can't wait, in order to drive that sodium up. So mannitol, I mentioned that mannitol is kind of falling out of favor because it doesn't work as effectively as hypertonic does. It's associated with renal failure and hypotension when you're administering it. And then it can also cause cerebral vasoconstriction, which we want to avoid in these patients. So there are a lot of reasons it's not that great. The reason we used to say give mannitol is 1, it was readily available, and 2, you could give it through a peripheral line. But now we just talked about hypertonic saline. That's not really true anymore. When you're giving mannitol, you're looking also at the osmolar gap, because the compensatory mechanisms in the brain are essentially that the arterial pressure is more than the venous pressure, which is more than the spinal fluid pressure, which is more than ICP. So you're trying to change that, the osmolarity to cause these shifts that occur. And so I forget where I was going. Oh, so it used to be that you just look at the serum osmo and say, okay, well, if it's over this, we're not going to give it. Well, now you want to look at the gap and see if it actually is going to have an effect, because you can actually have an elevated serum osmolarity, but still get an effect from mannitol. But as I said, it's starting to fall out of favor. In patients that are super refractory, you might see that they might schedule this and give hypertonic too. And this works in both cytotoxic and vasogenic types of cerebral edema, as does hypertonic. So these are our mainstays. See, I was so excited about hypertonic, I put it twice. All right, when do we use steroids? So steroids actually don't do anything for cytotoxic edema. And so this we're going to reserve for vasogenic when the blood-brain barrier is disrupted. And it's one of those things that people don't completely understand the mechanism of action, but the best hypothesis is because it's that leakage from the capillaries that it helps firm up that cellular matrix and prevent those shifts from happening, which is the same way it kind of works in all your other organ systems. So it makes sense that that is probably the mechanism of action. And so in addition to seeing this with something like intracranial masses, we also see it sometimes with meningitis as well. But this is not, other than tumors, associated with improved outcomes. And even with tumors, this is not alone going to be what's going to help that patient. There are a lot of terrible side effects to steroids as well. You can have infection, you have increased wound healing, you have patients that go a little bit crazy, and you don't see that with hypertonic saline. All right, so what does the future hold for cerebral edema? We're constantly looking at ways to improve our practice. And you've seen over the last 10 years how we went from mannitol to hypertonic IV push, and now what might be coming. So glyburide, we'll call it the Ozempic of the brain, maybe, is that, no? So this is another diabetic medication. And this is interesting because it doesn't cross the blood-brain barrier, but once the blood-brain barrier is broken, it crosses readily. And the reason it doesn't completely make sense is where they found the most use for this is in patients with ischemic stroke, which tells you maybe there's a change in mechanism along the line, the longer this is, as the stroke is evolving and the infarct is evolving. And they found that it saved some patients from requiring decompression. So there's some promise here, but there aren't any great trials. And what is out there isn't high quality of evidence, but it's pretty well tolerated and it's in small doses, like 2.5 mg twice a day, 5 milligrams twice a day. And if it's not going to hurt somebody and it might help them, then maybe there's a place for it. Similar with minocycline, it has, so this is an antibiotic that we could utilize. And in the like 2008, 2009, there were some animal studies that looked at TBI and showed a decrease in cerebral edema following administration. And this actually super readily crosses the blood-brain barrier. Good side effect profile, well tolerated, might be a place for therapy. And then melatonin, which anybody that knows me knows is my favorite medication of all time, has an, other than Precedex, has an antioxidant property and has been found to decrease cerebral edema almost immediately. The question is it enough of an effect that if your patient's in ICP crisis, are going to be, I need some melatonin? Probably not. But if you put something like all three of these together that are well tolerated, have shown some efficacy in decreasing edema, would there be a role in maybe preventing somebody having to have their skull taken off? Maybe. And there's at least one or two organizations that are starting to look at this, so I think there's more to come. All right, I highly recommend this article because I'm on it and it took a lot of time. But it does give general guidelines for broken down by what the pathology is and what's recommended. But the synopsis is hypertonic now is a little bit preferred to mannitol. If you don't have hypertonic, then by all means give mannitol. And then give some pediatric concerns too. And then I actually used references, so that was good. All right. Does anybody have any questions? Yes, sir.
I was curious, the difference in management with pediatric patients. because I still cannot, I avoid pediatric patients at all costs. I've always, but I know that their cerebral perfusion pressure and all the mechanisms through which the way the little ped's brain works is not like our grown-up brain. So I was wondering what the difference was in treatment protocol.
So it largely depends on the age because, you know, so pediatric neurology is completely different. A lot of times we don't even scan these patients depending upon their age. You can actually identify hemorrhage just with ultrasound. And so they have the added benefit of having open suture lines up until a certain age so that you don't need to decompress. But then they're actually more sensitive to cerebral edema than the adult population because their brains are still forming. And so they're at that formative stage. Those patients are more likely to be decompressed surgically prior to when we would give up medication management in adults. Hypertonic saline is still a mainstay. Mannitol is still a mainstay of therapy. And then if you're talking about just ICP, then they go benzo a little quicker to decrease cerebral metabolism faster than we would in adults if you're talking about sedation preferences.
What about melatonin dosing? Just because I know if I asked a neurosurgery resident for melatonin in ICP crisis, I'd have 6 heads. So just curious about the dosing with that.
So 5 milligrams is usually what's been utilized in the studies that have been done. I can tell you, I do a whole nother talk about sleep in the ICU, and I can tell you at doses of 10 milligrams that it actually lingers in the system and you'll have daytime drowsiness the next day. And if you talk to an actual sleep scientist, he says that the doses that we just take over the encounter are similar to doses that you would give an autistic child. So there's a lot to be learned, but we found there is, they found this in COVID too, using melatonin and its antioxidant and anti-inflammatory effects. So 5 milligrams is a safe dose when you're using it for this indication, but more is not better. Madam? So we think it's preventative. Early evidence is showing that there's a positive signal with prevention, with particularly those 3 medications used in combination. And so especially resource limited, these are cheap meds, they're well tolerated, and that could be something big in the future to prevent need for surgery or emergency treatments.
So does that mean that you would probably treat someone who has had a trauma accident, such as, an adult having a really bad fall? Would your hypothesis to that, you would do that? If they're not exhibiting a lot of, signs and symptoms, but yet there is a suspect for that?
Oh, that's a good question. So when would I employ it? So it would depend on the degree of edema. If they're like right on that borderline of somebody that I thought would need decompression and they have a serum glucose level that would tolerate, and then minocycline and melatonin, I would throw on just about anybody without much hesitation. And they're time limited duration. So they're not just on it indefinitely. I think in the studies, the melatonin can stay on indefinitely. And then it's like 3 days of the minocycline and then 5 of the glyburide. And actually, if it helps their blood glucose, we leave it on. So if they're at that borderline mark that we're like, oh my gosh, is this person going to need a 3 a.m. decompression? I might throw it on them and see if I was able to do whatever I want, which is not the case. All right, thank you.
Thanks, Diane. That was awesome. So we're going to switch gears a little bit, and Michelle Whaley is going to come talk to us again. So she was introduced earlier, so I won't go through the introduction process again. But this talk is geared more towards stroke coordinators and stroke coordinator work. So hopefully this will pique some interest in those of you who are not yet stroke coordinators, but might be considering it in the future. So Michelle, take it away.
Thank you.
Yeah, so this talk actually works pretty well for anyone who's going into any kind of program management, whether it's stroke, sepsis, trauma. You know, each group or each job class has different nuances, but basically the details stay the same. So it's been 10 years now since I first started giving this talk, and it stays relevant because turnover of stroke coordinators is so high. How many of you that are stroke coordinators have been in the field more than 2 years? 1, 2, 3, 4. So 4. When we started surveying stroke coordinators, what we were finding was that at each conference that we did, around 70 to 77% of attendees had been in the role less than a year. And then a regulatory agency might show up. And when that happened, people would say, I'm out of here. I do not want to be here when the Joint Commission or the DNV comes back again. So we wanted to find a way to how we could keep people in the profession, how we could make the profession something that would be desirable to stay. I've been in this field now for 14 years. I've moved up. I have had different jobs along the way, but I still stay kind of in this current moment. On Mondays, I cover the stroke program. It helps me understand what's happening in my hospital. It helps me see where the gaps are, things that I might miss. And I just think it's important to be with patients as well, even if you're an administrator. So no disclosures for this talk. So there's a lot of competing priorities when it comes to being a stroke coordinator or a coordinator of any kind. And, what you've got to balance is, if you've got 10 things to do and they're all at the highest priority, well, how are you really going to prioritize what your day looks like? And I've found that with new nurses, new to stroke coordination, it's really hard for them to figure out how to get things done. I have a fairly new stroke coordinator that works in my facility, and I walk into her office and it's like a bomb went off every day. There's stacks of papers and there's data, and it's really unorganized. And I'm trying to gently nudge her into organize your day, organize your week, your month, and your year, and you will always stay on track. Keep yourself constantly ready for survey. That will help you enjoy the time when the regulatory surveyor is on site because you're ready and you're not panicked and you're not trying to do things at the last minute. So I think when it comes to program coordination, and tell me if I'm wrong, you really need to know what kind of a person, what is your personality? Are you an extrovert or an introvert? We're all one or the other in this room, right? I'm an outgoing introvert. I actually might spend too much time in the office, right? And I need to find ways to get out and meet people. I need to get out and run with families. Whenever I do that, I'm always like, it fills my cup. I feel like, okay, I'm really back into the people that our programs help and help people, get back to their lives. But it's hard for me to get out of the office because I'm going to focus on the things I need to get done. And if it's in a nice, quiet environment, I get it done. Now, on the flip side, I've had stroke coordinators that are extroverts, and being stuck in the office, doing any kind of office work really is like dying a slow death. I've had a couple of people say to me, I just can't do it. I just can't be in the office anymore. So you've got to find a nice balance. I think introverts, take your laptop out to the emergency department and sit down and do some work in there, be with the staff, be able to help them with emergencies. It could work the same way if you were a sepsis coordinator or you worked in the trauma world. APPs who are hired in to work as stroke coordinators, if you really love doing consult notes and HMPs, this job is not for you because that's not what the role is. And I've seen some APPs get hired into jobs like this, and then they just really miss that type of work and they leave. And every time a coordinator or a bedside nurse or someone who works in this field leaves, it takes a long time to catch back up. So intentional hiring, when you're looking at who might be hired into work in your program, if you're a leader, be really thoughtful about who that person is and their skill set and their abilities to work in this role.
I think clinical nurse specialist, that's my job title, is actually a perfect fit for stroke coordination because we have this, whole graduate program that's designed to think about patients, think about nurses, and thinking about hospital systems. And that helps. That's a pretty well-rounded educational background for someone in this type of world. And then the last thing is, if you're coming from the bedside, you really need to have Microsoft Office skills, because if you can't make a spreadsheet or a PowerPoint presentation, it's going to be very challenging in the role. So you might need to take courses on your own to build proficiency. The types of programs, again, will depend on the type of team that's needed. So acute stroke ready, often led by someone in quality. I mentioned this earlier. Primary stroke centers often have an RN working in that, and they may or may not be full-time. And then CSC and TSCs may actually have very large programs. I like using the AACN synergy model when I'm thinking about how a program should look or how my day might look. Who is the sickest patient on my unit? And who is the most inexperienced nurse caring for caring for patients? I'm going to go see the vulnerable patient and the vulnerable nurse actually pretty soon, first thing in the morning, because I want to make sure that that patient that is being cared for by a brand new nurse is stable and is safe, and that the care provided is appropriate. Just as if the patient who is the sickest, maybe it's your patient with cerebral edema on hemicranie watch. That's a very vulnerable patient. You want to see them, help the family understand what's happening next. So this is a really good way to think about your programs. I also look at it from the system standpoint. So thinking about, all right, if the hospital X across town needs to grow, do we have the right people? Do we have the right synergy? And those people that have been hired in, is it going to make sense for that program? So organizing the day at a primary stroke center isn't as detailed as maybe a comprehensive center, but usually people need to know who's in the house. What kind of patients do you have in the house? I've seen some programs do things all retrospectively. They wait for their abstraction list to come. And that is actually way too late. That could be 10 or 15 days later, and then you have no idea who's in your hospital and whether the care that was provided was appropriate. If it happened in the past, you can't make changes right on the spot. So my recommendation is to really be looking at patients every single day, looking for adherence to standards, attending multidisciplinary rounds, updating a stroke log, and focusing on abstraction if your role is data, and then attending scheduled meetings. So this is what I think a good sample day could look like. I think it's really important if you're in a new role, like a new stroke coordinator role, it's really easy to spend too much time at work. And it's really easy to run your list in the morning on your day off. And I'll admit, I ran the list this morning because my stroke coordinator is on vacation and Joint Commission is coming. So you've got to find a good way to balance it, or find others in your system that can help you on these days, maybe when you're not in the house. I think it's also important to add, additional work to your schedule and allowing yourself to have time to work on projects. This is really important, especially if you're trying to improve your program. You've got to schedule the time to work on performance improvement, and you really should schedule the time to work on regulatory agency readiness. And I try to schedule EMS and community outreach at specific times of the year and provide education at specific times of the year. There was a really great hospital that I had an opportunity to work with in Wisconsin, and they used seasons of learning. And I also kind of think about, okay, you could use seasons of performance improvement too, or seasons of education. In Q2, I always do physician education. That just always pings me that I need to get that ready, and I'm going to have it sent out, and I'm going to do it in a way that makes it easier for them to return it back to me. I always have education due at the end of May for nursing staff. So they have an entire year. Regulatory agency comes in the summer. I've got it ready where it's due by the end of May. And then I usually do Q3 and Q4 for outreach and community education, because I can never teach a nurse anything in the hospital because we're on budget constraints and you can't do any kind of teaching in third or fourth quarter. So I try to strategically align this so that I can maximize opportunities within the budget, and then downtime when we can't do regular teaching for staff to focus on EMS and other outreach. Organizing the month, I would recommend highly prepare for your meetings a week in advance. There's nothing worse than getting a slide deck ready Thursday night when your meeting is at 7 a.m. on Friday. And if a busy week is coming up, the third week of the month is always the busiest for me. I try to have everything kind of cleared off that schedule and making sure that I'm ready to go when those meetings occur. And then, of course, organizing the year, it's very much in that seasons of learning or by quarter. So first quarter, updating policies. Second quarter, nursing education, physician education. Third quarter, EMS community. Fourth quarter, physician review of policies. Now, for a comprehensive center, and I think several of you in the room here maybe work at a comprehensive center, I'm going to use Swedish Medical Center in Denver as the example. When I last was the stroke coordinator there, we had 5 of us, and on any given day, 3 of us were working. And we had to divide up the work, and we couldn't all work on the same thing. And we also didn't want to ignore other aspects of the job, like some data collection or other details, preparation for meetings. So we always divvied it up kind of in this way. APP1 went to stroke alerts, followed the neurocritical care unit. APP2 went to neurology floor rounds, saw all of the patients on that floor. And then the third person managed the office work for the day. And then they also went to meetings, and they also worked on outreach. And if we followed this kind of format strategically, all the work that needed to be done was done. And everyone had an opportunity to rotate in that office work day. But, you know, as stroke coordinators, we probably might enjoy being out with patients more than we would be in the working in the office, especially depending on your personality type. So we want to make sure that everyone has an opportunity to get the things done that need to be done. I love this idea of how do I prioritize things? And I take this from Dorothy Del Bueno. She created a curriculum for assessing nurses' ability to critical think. And I just like it for this perspective when I'm training someone new. What must you do today? What should you do today? And what could you do today? You're not going to get everything done in a day, but you really should think about what my must-dos are. I need to see vulnerable patients. I need to see inexperienced nurses. I need to attend stroke emergencies. I need to make sure that new admissions are handled appropriately. I should go see new, patients who were recently admitted. I should go see high need families, and I should help get patients ready for discharge. And then there are some other patients that might be on the could-do list, somebody who's waiting for placement and they've been in the hospital 30 days. I might only need to see them once a week as opposed to seeing them every day. So thinking about this from a prioritization standpoint can help what could be an overwhelming list of 30 or 40 patients be a little more manageable each day. Same thing goes for office work. So prioritize that workload based on what must I do today, what should I do, and what could I do? And then work on processes so that if I'm not, if it's Monday and I have a meeting with the CEO and there's a stroke alert, I need to trust that the ER team can handle a stroke alert, right? They should have a process that's well honed so that it happens whether I'm there or not. That's kind of what this is. Create processes within your institution that allow you to step back and watch them do their work and follow the things that you've taught them. And the Joint Commission, and I would imagine DNV would be the same, but what we're hearing of late with Joint Commission is that they really don't want stroke coordinators cleaning everything up. They don't want you sweeping the streets and making the core measures better. They want it to just happen organically within your units. That's, again, working on the process and making sure that that's right. The other thing I would say is stay current on data collection. And I talk about this. If you have to do data or you're the data collector in your facility, you will thank yourself if you stay on track. Letting data get behind can be really difficult to get caught back up. And so I can't say that enough. Keep yourself current and organized. On Fridays, I tend to make sure that everything is done for the week if I'm in this role. And then evaluate what's being collected. If it's something that you've been collecting forever, just because you always collect it doesn't mean you have to keep collecting it. So stop collecting it if there's no benefit to doing so. Get rid of paper where you can. Use logical names for when you save things. Use logical names in the subject line of the emails you send. I used to work with an educator who always put in the title of or subject line of his email, stuff. Well, how am I going to find that later? Like everything is stuff. Like, so I usually am very strategic on what my subject line is, how I save things on my share drive. I give dates, I give very detailed titles because I want to find things easily. I don't want to have to dig through a lot of saved files. So being logical makes a lot of sense. And I use Outlook to my advantage. I use tasks. I might drag an important email that I maybe don't need to do anything with today, but I don't want to lose into my task folder. And you can just take it right from your Outlook and drop it right in. To me, this has been really helpful because then I can go back through and I can find the things that I need to easily and quickly. So if I'm managing stroke, which is my typical Monday, I'm going to be very focused on patients in the morning. I want to make sure that I've reviewed their records. I know who is the sickest, who is the one that might discharge. I'm going to go to alerts. I might attend meetings midday. We have a moratorium on meetings in the morning, so leaders can round on their staff and patients. So that gives me an opportunity to focus on my review and rounding on patients. And then in the afternoon, I'm going to kind of clean up the day, make sure I have things collected, but I'm going to try to leave on time because no one's going to burn out faster than someone who is constantly working late. I interact with the system in many different ways. I attend physician meetings. There was one stroke coordinator role I had at a comprehensive center where we could never get information to providers. And the hospital I'm at now actually has an inpatient physician directed meeting. They lead it. I can bring to them, here's the order sets, the percentage of order sets that were missed last month, and they strategize on ways to improve their own practice. That's been quite refreshing. See if you can get on a meeting like that, because that would be really helpful for some of the things that you're trying to do and collect. I attend the critical care meetings, I attend performance improvement, I attend division meetings, and all of those I strategically share data I have analyzed in hopes to improve the program or improve the division of hospitals that I work with. Excuse me. I also, from a neurosciences perspective, interact with different ways, again, to drive my program forward. So I'm going to end this with, how do I maintain constant readiness for survey? I try to update my slide decks all the time. I use my monthly meetings to then become my data tracer for Joint Commission. And I update those monthly, quarterly, and annually. And if I were here today, if this were my program, I'd be taking pictures of what was happening here. This is education. And I would throw those in a slide deck because then I've got an opportunity to share, oh yeah, we had a great educational offering and look at all the people that were here. Same thing with updates on the calendar, putting something on my calendar specifically to update a policy to make sure that that's done. Those are all ways that I stay on track. Also staying current, knowing what's happening in the world of Joint Commission, DNV, HFAB. I think you guys have the Florida Health Department that will also come in and do some surveys for you. Knowing what their requirements are and knowing when an update has happened, that's really helpful. I remember one year we had a survey, we didn't have the current manual and we got some RFIs because of it. So staying current, I will never not stay current again because of that experience. I also spend a lot of time networking with other people, like-minded people. I'm now in a leadership role, but I still interact with stroke coordinators and get really great information on how I can help the people that work at my facilities. So in conclusion, it's really important to stay on task, get out and meet people, get out and see patients, see family, see nurses, round, get back to the office, get your work done, really love the work you do. I've tried to leave stroke probably twice in my career, and I just miss it too much. I really like helping these patients, helping improve their lives, reversing stroke when I can, with tenecteplase or with mechanical endovascular thrombectomy and getting those patients rapidly. I love doing that. And I love it enough that even if a stroke alert comes in when I'm supposed to leave, I'm going to go because I want to make sure the patient gets the highest quality of care. And it's that passion. I'm the CEO of Stroke. I really believe in the care that we provide, and it helps me keep staying fresh and engaged in this role. And with that, I will end and take any questions. Thank you. I know I got the coveted end of the day slot. All right, guys, thank you.
Okay, is that a wrap?
Okay, sorry, the mic is not cooperative. So we have one more session. It's the hands-on NIH, but before we get started with that, I do have a couple of announcements. So number one, if you are claiming nursing continuing education credits, you need to fill out the form. Abby has copies of those. We will use your sign-in sheet to make sure that you get the credits, but Abby has the correct form. So make sure you see Abby, because there's two different forms. One's for CME and one is for continuing education for nurses. Number two, we're going to have a couple of announcements. So first will be the drawing for the stroke for the raffle. And that will be a nice little gift basket. So we'll do that. You guys have it? Oh, we got a couple. And Cheryl, are you here? Where's Cheryl? Okay, yeah, the form that you got when you signed in this morning at registration is the correct form. So we'll do the raffle in a second. They're gonna set up for the NIH stroke scale. So if you guys want to take you want to step out for a second or take a quick break, you can do that. It's gonna take us 5 or 10 minutes to set up, and then we'll get started again. But we do want to do these drawings first. Abby, do you have you got them all? And then when I'm done with this, Cheryl's going to announce the winner of the stroke board contest that we had for Stroke Awareness Month. Oh, okay. All right. Well, we'll do it during the presentation then. All righty. Too bad we don't have a drum roll. All right, guys, this is totally random. Last time I did this, I couldn't read the person's name on the card. So hopefully your handwriting is legible. All right. It's Marjorie Donnelly. Come get your award. Yeah, and we have one of these gift baskets every day. So, make sure you come back and try again tomorrow. I don't think you can win twice, Margie, sorry. All right, guys, so a few minutes, like I said, give us a few minutes. They've got to set up for the NIH. It's a hands-on NIH stroke scale tutorial. They'll go through a couple of cases, so you don't want to miss it. But if you need to take a break for a few minutes, that's fine. We'll be back here at 3 o'clock sharp.
Oh, I need one. No, but one more.
Oh, that, yeah.
Might need to swoop down. Well. Come in. Come in. But see, I'm short enough, you can see it all.
Light that's shining right
Everybody else. Is that better? Yeah.
Yeah, I know. Yeah, that's, you're gonna fall down if you try to. Okay, guys, we're gonna go ahead and get started. I'm gonna introduce our team of stroke coordinators from Baptist Jacksonville and the other Baptist campuses. So come on. Dorothy, you here? All right, come on, guys. All right, we've got Cheryl Lewis. She's our stroke coordinator for Baptist Nassau, Beaches, and all of our satellite emergency departments. We've got Kristen Davies, who's our stroke coordinator at Baptist South. Grace Benetti is our stroke coordinator at Baptist Jacksonville. She's minus a partner right now, so we are hiring if anybody's interested in a stroke coordinator job. Resumes are welcome. Kirsten is our stroke educator. She's the first person we've had in that role. She's leaving us very soon. We're very sad. But this is actually her last week with Baptist, so we're also hiring a stroke educator. So we're really sad that Kirsten's leaving. She's done an amazing job, and we're very fortunate to have had her for the last year or so. And then Dorothy Adair is our stroke coordinator, formerly at the downtown campus, but she's helping us head up our transitions of care program. So they're going to do a hands-on NIH stroke scale, what do you call it? Demonstration. So I'll let them explain it. Cheryl, I think first is going to announce the winner of the stroke board contest. So I'll let them get started. Thanks, ladies.
Okay.
I'm gonna sit over here.
Can we have our slides, gentlemen? Do we have, oh, here's the clicker. You can, which is the clicker? Oh, there we go. All right, I know we've got some out of towners here. As Wendy said, I'm Cheryl Lewis. I'm the stroke coordinator for just about everybody you can think of except for South and Jax. So I take in a lot of territory, and I know I've seen some of my folks here. Our stroke board contest this year, we actually get to show it at this seminar, and we're very happy about that. It's usually, we don't usually do our seminar during stroke month, but it's kind of aligned this year. So we sent out emails and to all our stroke units, our ERs, our ICU, they were all eligible. And I do have an honorable mention this year. I want to name the units though, and if you are from that unit or hospital, please stand so we can acknowledge everyone that participated. Oakleaf ER, and I know I just saw a bunch of my people leave. Clay PCU. Oh, there you go. Thank you, honey. Weaver 10. Oh, there you go. All right, yeah. Town Center ER. Anyway, I saw Amanda leave, unfortunately. And then Baptist Nassau ICU. Anybody? Okay. Well, the winner is Weaver 10. Congratulations. The unit, we change up the prizes every year. The unit will receive a pizza party for both day shift and night shift. Anna will be in touch with Grace and myself, and we'll arrange that for your unit. We appreciate all your hard work. This is a wonderful board, wonderful creativity, and we're glad we could showcase it here today. The honorable mention that I wanted to talk about was our beaches and med-surg unit, and they did a wonderful board. They weren't in the stroke unit per se, it's PCU at beaches, but we wanted to give them an honorable mention for showing showing their creativity and being enthusiastic about our stroke patients. So thank you. Weaver 10, I'm going to give you a certificate. You can give it to Anna. I think she already left. Oh, is she here? Oh, okay, I'll find her. All right, thank you. And I'm going to introduce my partner, Kristen Davies, and we'll do some NIH stuff. Isn't that exciting? Yeah.
So is this Cheryl? Which one do I?
Oh, keep going.
All right, guys. So my name is Kristen. I'm one of those weird ones that kind of goes between being a stroke coordinator and a nurse practitioner. So downtown, I work with the vascular neurology team, and at South, I'm a stroke coordinator. So depending on which setting I'm in, I might tell you, you need to do your NIH right now because I need it for a joint commission measure. And if I'm downtown and we're in the middle of a code stroke, I'm like, just tell me what the deficits are. I don't need the number right now. So it's going to go back and forth, but we are going to go over the NIH stroke scale. I'm assuming most of you guys are familiar with it. I mean, it's a neuro conference. Most of us work in the stroke world. But I'm going to go through some of the kind of the pitfalls of the NIH and things that we need to focus on. So I have no disclosures. So our objectives are up here, understand how to do the NIH, verbalize when to assess the patient, and understand how the outcome of the NIH stroke scale predicts patient outcomes. So, okay, in the interest of time, we're not actually going to do the whole poll everywhere, just because I know it takes people a while to get the app going. But what is the NIH? Just by your hands, is the answer A, B, C, D? Yes, D is the winner there. The NIH stroke scale was actually created from a compilation of different stroke scales in the late 80s. And then the NIH stroke scale that we use today was finalized around 1995, 1996. It was used for a lot of TPA testing studies. So that is what we're currently using as our NIH. So you guys will be all familiar with this in some way, shape, or form, whether you're used to seeing it in Epic. You guys should have received one of our little NIH books that you can put in your pocket. These can be cleaned off. I really like them if they can get all types of things and just wipe them down. But you can see by just looking at the length of the scale, and some of the other speakers have spoken about parts of the NIH, it can be a very time-consuming, kind of cumbersome exam to do if you're not familiar with it, because there are a few little goofy things to go along with how it's done. So some things to know about the NIH. It goes from a 0 to a 42. I have never seen a patient alive with a 42. But a 0 does not mean that they haven't had a stroke. So they could have had a stroke and their deficits have resolved, but you look at the MRI and they still have a stroke there, or they may have a deficit that is not picked up on the NIH. The NIH, we ask a patient to grasp their hand. We're not testing their ability, like how tightly they can grasp their hand. We're just checking to see if they can follow the command, make a fist, open it back up. So what if somebody is a piano player? They can maybe move their hand a little bit, but if they can't move their fingers really proficiently, that's not going to show anywhere on the NIH. A score of greater than 21 is often considered a severe stroke. But I want you guys to keep in mind whenever you're doing the NIH that the severity of a stroke can be very patient specific. If somebody is a truck driver and they can't see out of the right side of either eye, that's pretty severe for them, even though that's only going to give them an NIH of 2. 2 doesn't sound so bad in the greater scheme of things, but that would be severe for that patient, because honestly, I don't want to drive around on the road with a truck driver who can't see out of the right side of either eye. Left MCA strokes will score a higher NIH as compared to right MCA strokes, even if the ischemic burden is the same. Anybody want to hazard a guess as to why? Speech. Most of us are going to have our speech language center on the left side of our brain. I remember looking at MRI a couple of years ago of somebody who had a right MCA stroke. It looked like he'd taken out most of the right MCA territory. He was acting a little goofy, but he was able to walk into the ED. And I looked at him and I looked at the MRI. I'm like, looked at the name, like this can't be the same person, but it was because it was his non-dominance side of his brain. Anterior circulation strokes account for more points on the NIH as compared to posterior circulation strokes. So all of those brainstem strokes, even the occipital strokes, the number of points that can be accounted directly towards posterior circulation is significantly lower as compared to anterior. Gait is not tested. How many of you, I don't think we have many ED people left, but in the ED, when we have a patient who comes in and they're like, I'm kind of falling, I'm not really sure if I can walk, we sometimes really do need to test their gait. It's not going to show up anywhere on the NIH, but if somebody can't walk and maybe they just have a little bit of ataxia with finger nose, that is still going to be a severe disability to them, but gait is not tested on the NIH. And then as I already said before, NIH of 0 doesn't mean a patient didn't have a stroke. It just means a deficit wasn't picked up. So some tips when you're doing the NIH: score what you see or hear. Take the first answer that you're given. They can't phone a friend. If the patient doesn't remember their age, they can't look at their family member and say, how old am I? You take the first answer that you get, and you have to account for all deficits you see. Even if they are old deficits from a prior stroke or injury, count those as deficits. Definitely put a note in saying, hey, these are chronic deficits that they have. But if you don't count those deficits and a nurse 2 or 3 days later does count those deficits, your NIH could jump up by 4 or 5. And within the Baptist system, you're supposed to call neurology if the NIH goes up by more than 2. So count all the deficits you see or hear. If a patient needs glasses or hearing aids, make sure they are used during testing whenever possible. If you're having the patient read sentences, you don't want to count them off as having like they can't speak or they can't see just because they don't have their glasses. And this is one of those areas where my stroke coordinator brain says, make sure you take the time to find the glasses, put the hearing aids in. And the vascular neurology side of the brain says, just go. Just go. Time is brain. Let's move. But definitely, whenever possible, try to limit anything that is going to make the patient's disability appear worse. Know what your patient's primary language is. A lot of people in Florida speak Spanish. I don't speak Spanish. I might be able to say a few words, but I am definitely not fluent. So if you're talking to them in English and their primary language is Spanish, you might count them off for a lot of things on the NIH because you're just speaking a different language. They don't understand what you're asking of them. The NIH can be very time consuming, especially if you're not used to doing it very frequently. If you're in the ED, I really tried to say group the NIH together. If you can be with the ED physician, the nurse, and the neurologist at the same time doing NIH, that would be the best, just because every single time you take more time to do the NIH, it's more time added on to everything. The same deficits don't necessarily correlate with the same disability from one patient to another. And I had to I rewrote that several times just to make sure it sounds right. And it still may not make a whole lot of sense, but just with the truck driver, somebody who drives around for a living, they can't see out of the right side of either eye, and they can no longer go back to their regular job. That is going to be a much more severe disability as compared to maybe the 80-year-old who has dementia and lives in a nursing home. It's the same deficit, but the disability that patient is going to have from that deficit is going to be judged a little bit differently. So when you're doing the NIH, just don't assume, yeah, it's only a 1 or 2, the patient's going to be fine. Yes, they can maybe still walk and talk, but maybe that deficit is going to be a disability for them in the long run. So I'm going to go over the NIH. I'm going to try to go quickly because I know we have the whole banquet out there. But with 1A, level of consciousness, you walk into the room and the patient automatically says, hi, or I want to leave, or when can I get out of here, whatever. But they respond to you the minute you walk in. You don't have to say anything, shake them. You don't have to do anything like that. They just respond immediately. That's going to be a 0. You have to say their name. Hey, Miss Smith, and you're a 1, and then just go down like that. Level of consciousness questions. Ask the patient the current month and their age. Don't ask who the president is. You don't want to get the answer sometimes to that one, and it's really going to just distract from the whole thing. So just ask them what their month and what their age is. Again, if they have dementia at baseline, they may never know that, which is fine. Just make sure you document that when you're documenting your NIH. Still count them off for it, but say, hey, this is chronic. They never know this. Level of consciousness commands. Ask them to close their eyes and open their eyes and make a fist and open their fist. Don't just take your finger and put the finger right in yours. They're some of them, if they have a severe stroke or really encephalopathic for whatever reason, they may clamp down. That's reflexive. They're not necessarily going to open and back up. So if you have to put your fingers in theirs to get them to follow the commands, put them in there, squeeze my fingers, now open your finger back up. And if they can do that, then they're following the command. All right, best gaze. We are only checking horizontal gaze right now. We're not doing left, right, up and down. That is part of a normal neuro exam to do left, right, up and down, but the NIH is not a full neuro exam. So we're only checking horizontal gaze. Can they go over to the left and then they can get to midline, but not over to the right, or do their eyes stay somewhere up here on the left side? So that's what we're looking for. If the eyes just stay up here on the left and you can't get them to move over, they have a forced deviation, and that's 2. Vision. I hate vision. I'm sorry, I don't know any other way to put it, but vision is very, very difficult to test. What I will caution you on is check each eye individually, whether you have to cover the patient's eye for them or they close their eye, whatever it may be, and you're checking all 4 quadrants on each eye. This is, no, you can't see behind their head, but try to be about 45-degree angle out this direction and down here. And then when you are testing them, if you probably by this point will have picked up, maybe they're having some language difficulties. Don't say, how many fingers am I holding up? And you don't get anything. Oh, well, she can't see. No, they have a language problem. They may not be able to speak to tell you what it is. And that time, okay, point to where my fingers are wiggling. And if push comes to shove, by threat and see if they blink. But check each eye individually. Facial palsy. So just drooping a little bit. Is there slight nasolabial fold flattening right here? Is it completely drooped? 3 is complete paralysis of the side of the face. Most of you will know that that's not usually associated with a stroke. I've learned to never say never, but not usually stroke. It's usually more Bell's palsy, but we work Bell's palsy patients up as stroke all the time. So just look at that nasolabial fold flattening, see if it's flattened, if it's completely drooping, if everything's drooping. With arms, remember 5 has a 5A and a 5B. You're doing your arms individually. Yes, in clinical practice, I know we're all like, okay, put your arms up. We do them at the same time. I do the same thing, but if you're trying to teach somebody else how to do it, I would encourage you to do one arm at a time. And the one thing that we do differently than the way the instructions are usually given is have them hold their palm up and close their eyes. So if they have their arm like this, palm down, you're not necessarily going to pick up on a very subtle weakness. So you have palm up, you might see the slow, low pronator drift that they're not aware of. And if you have them close their eyes, you're taking away that sensory input to say where their arm is in space. So they can't correct it if they start to see that their arm is drifting. So arm up, watch to make sure it's stable, count to 10, go to the next arm. For the legs, same thing, close the eyes one at a time. Watch out for the little like 85-year-old, 90-year-old ladies. They can sometimes lift both legs up at the same time. You will get kicked in the face once and learn never to be standing over the patient when you ask them to lift their leg. But when you're doing the legs, you're still looking for drift. With arms and legs, 0, there's no drift. 1, they start to drift down a little bit, but they don't hit the bed before you can count to either 10 for the arms or 5 for the legs. A 2 is going to be, they can hold it up, but they drift and they hit the surface before you can finish counting. 3, they may not be able to lift it up and down, but they can maybe move left and right. They just can't move against gravity, so that they can kind of move side to side. 4 is no movement. Ataxia is the weird one. Ataxia can only be scored if it can be tested. So the patient who can't even lift their left arm up in the air because it's so weak, if you say, lift your arm up, touch your nose, and then touch my finger, it's the weakness that is causing them not to be able to do that. Maybe they do have some ataxia at baseline, but it's the weakness that is the overwhelming issue at that point in time. So you cannot count it if you cannot test it. Comatose patients, you can't test it, you can't score it, they get a 0. We don't do a UN unless there's a joint effusion, or maybe they have an amputation, something like that. But a comatose patient, you are not going to put a UN or a 2 on it or something like that if you can't test it. Sensory. So sensory, people get confused between number 8 and number 11. 8 is, can they feel that you're touching on the both sides, and does it feel equal? Does this feel the same as this? You can have them keep their eyes opened. I try not to go for the feet a whole lot, just because a lot of our patients have peripheral neuropathy at baseline. I try to go more mid shin and up and try to touch the skin directly, not go over jeans or something like that. But just, does it feel the same on both sides? If it doesn't, can they still feel it on the left side, just not quite as much as the right, or they can't feel anything on that side? 9, this is, I don't think I can do this part justice, but best language. So this is where we're trying to figure out if they have any type of aphasia. Ask them to describe the cookie thief picture. You might pick up on other things that maybe you missed in the beginning of the exam. So they're looking at the cookie thief picture and they're saying, okay, yeah, mom's washing dishes, the sink is overflowing. What else? Do you see any other problems? I can see outside, I can see like the yard. Anything else? No, they're not seeing anything on the left side of the picture because maybe they have a hemianopsia that just wasn't picked up when you were doing this, the vision part. Same thing when they're reading sentences. If I think that there's any visual impairment, I sometimes have them start with, they heard him speak on the radio last night and see if they miss some of the sentence at the one of the sides. But what you're looking for here is, can they produce the words without you having to tell them what it is? Can they name the glove or the hand? I do take hand as an answer a lot of the time. The key, can they come up with those words on their own, whether it's describing the picture, reading the story, or looking at the different objects? Can they produce the word without you having to tell them what it is? And I know that the pictures do sometimes throw people off. I can't remember what language it is, but there's one language where there's no real word for hammock. So if they say swing, I think swing. But the general idea of what it is. 10 is dysarthria. This is, I don't show them these cards. I say, repeat after me, say mama, say tip top, say 50-50. Make sure when you're doing that, that your pronunciation of the word is very crisp. When I say the word thanks, it comes out thinks a lot of the time to patients. So I have to really say, repeat after me, say thanks, because otherwise they repeat back, they say thanks. Well, that's kind of the way it sounded like when I said, so they were doing exactly what I told them to. Something else to be aware of, though, is we live in the South, or most of us live in the South. We have a few people from out of town, but we get some really thick Southern accents around here. And sometimes it can sound a little dysarthric. Maybe they don't have their teeth in. I mean, you don't know what it could be, but it sounds slurred. So you have to score what you see. If it sounds dysarthric to you, you got to count them off as being dysarthric, even if the family is sitting there saying, she always sounds like that. But if it sounds dysarthric, you score what you see. All right, and extinction and inattention. This is one that throws everybody off. So what you're testing here is pretty much, is the patient aware that they have two sides of their body? So if I'm trying to rush through an exam, number 8, which is sensory, I'll sometimes have them close their eyes and say, tell me if I'm touching on the left side or right side, and then do this, and then to do both at the same time. And if you're like, oh yeah, I can feel this, and oh, it's the right side, even though I'm touching both at the same time, they're extinguishing to that left side. Same thing with vision. If they could see over here, they can see over here, but if you do them both at the same time and they can't see over here, they have some type of inattention. That's more prominent in right MCA strokes, but it can be, you can find it elsewhere. All right, so we're going to go through a few case studies we're going to try to make this work. We're going to have the camera come up onto the screen, and we're going to try to have you guys score it. So when you came in today, you should have gotten one of our downtime forms for the NIH. You can just label at top patient 1, 2, 3, and 4, and just go through it, and you score it as we're doing it. Remember, my wonderful coworkers who were voluntold to do this, they have not had strokes, so it's sometimes hard to pretend that you have some deficits, but they're going to do the best that they can, and hopefully you guys can see pretty well on the camera, and then we'll just run through what the score is afterwards. All right, first up, Dorothy. There's stairs over here. Oh. My notes, sorry. Yeah, can you guys, I don't know, does that work? No? There's a light on. Oh, that works. All right, so we have a 62-year-old female with a past medical history of hypertension and diabetes. She presents to the ED via EMS for evaluation of confusion and right-sided weakness. I think they're working on getting the camera switched over so you guys can see exactly what's going on here. And I am going to use my little book here just because I have a tendency to jump around, because that's what I do during a code stroke, is jump from point A to point B. But so I'm going to use the book. Okay. Hopefully you guys can see pretty well. All right.
Oh, fell off the PowerPoint.
Knock, knock, knock. I'm walking into the room. Hello. Hey, Miss Dorothy. So it took me just a little bit to get her to pay attention to me. So, hey there, can you tell me how old you are? And count to 7, give them time. What month is it currently? So she's trying, but she can't quite get it out. All right, close your eyes for me and open them back up. Good. Make a fist with your hands. Okay. And I forgot when I was going through this, you don't have to have them do a fist with both hands. It's left or right, whichever one they want to show you is. All right. So we're going to check horizontal gaze now. My hand I may be like that NIH stroke skill video where that guy is putting his hand right in front of the camera so you can't actually see, but we're going to try. Look at my thumb, follow just with your eyes. Keep your head still. All right. Could you guys see that on the camera? Yeah. Okay.
Yes.
It's hard to hold the microphone, so I'm going to put this down for just 1 second. I'll just try to speak up really loudly. Because I need 2 hands for this right now. All right. Look right here at my nose. Point to where my fingers are wiggling. All right, I'm going to cover one eye. If you're covering their eye, just make sure that your hand might be blocking their actual view. So if you have the hand up like this and you're way over here, maybe your hand is blocking what they're able to see, not that they can't see. All right, smile big for me. Thank you. She practices that in the mirror for us. All right. Can you take your left arm and hold it up like this? Okay, I'm going to help you here. Let's take your left arm and hold it up like this. Close your eyes and keep it up for a count of 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good. Go ahead and put it down. You do the same thing on the right side. I'm going to help you here. All right, let's get your palm up. Close your eyes. Keep your arm up for a count of 10, 9, 8, 7, 6. All right. All right. I'm going to have you lift your left leg up in the air. Close your eyes and keep it up for 5, 4, 3, 2, 1, and down. Let's do the same thing on the right side. 5, 4, 3, 2, 1. All right. Okay. All right. I want you to take this finger and touch your nose and touch my finger. Back to your nose and over to my finger. Good. You can do the same thing on the other side. All right. All right. I want you to bend this knee. Take your heel and draw a line down your left shin. Good. And do the same thing. Bend this knee. Yeah, don't fall off the chair. All right. So does this feel the same as this? Can you feel this? What about this? Which one feels more, this one or this one? Okay. All right, I'm not gonna roll her pant legs up, but does this feel the same as this? No. Which one feels more, this or this? Okay, we're gonna move on to our language section here. She does have her glasses on. All right, tell me what's going on in this picture.
This, this,
Tell me what objects you see here.
yeah. Chair, some,
Yeah. Okay, point to the key. Point to the feather. All right, so she understands what I'm saying to her. She's just having a hard time getting the words out. All right, and read these sentences to me.
sure. Sun, earth,
All right, repeat after me. Say mama. Say tip top. Say 50-50. Say huckleberry. Say thanks.
say.
She had decreased sensation on the right side, severe expressive aphasia. I had one listed for dysarthria, but I don't think we got enough language example to really say whether she was dysarthric or not. But so that was what I was trying to get on the numbers. All right. Our next, oh, whoa. Yeah. No, let's actually skip to, you're leaving us. So this is what happens. All right. All right. So we have a 38-year-old female who has a past medical. 1 a.m. is when I came up with these. I wasn't really paying attention to who was going to be being the patient. A 38-year female who has a past medical history of migraines, presented to the ED via EMS for evaluation of feeling off balance, and her speech is altered. So, yeah, maybe I just keep being told that people online can't hear us if we're not on the mic. Hi there, how are you?
Good, how are you?
Good, thank you. All right, tell me how old you are
38,
and what month is it currently?
May.
All right, make a fist for me and open it back up. Close your eyes and open them back up. Good.
Yeah, the camera's.
They can't, oh, sorry. Oh, sorry. I didn't realize it hadn't flipped over. All right. Look right here at my thumb and follow it just with your eyes. It's, can you see it?
There it goes.
Oh.
Okay, so
Oh, I saw it down there. Okay, let me try again. There you go. All right, again, in the interest of time, I'm gonna do visual fields, both eyes at once instead of individually. But look right here. Tell me how many fingers you see.
1, 5, 2, 1.
Okay, I said to ask her to tell me the numbers because she can clearly speak. She's been talking to me, so she doesn't have any difficulty with language. Smile big for me. Good. All right, and I want you to put both arms up, palms to the ceiling, close your eyes and keep your arms up for a count of 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Go ahead and put them both down. All right, close your eyes and lift your left leg up and hold it for 5, 4, 3, 2, 1 and down. Right leg up and hold it for 5, 4, 3, 2, 1. Good. You take your left index finger and touch your nose and then touch my finger and back to your nose and open my finger. And then same thing on the left side, finger to your nose. Try one more time. Good. You bend your right knee and take your right heel and draw a line down your left shin. Good. And bend the left knee and draw a line down the right shin. Okay, good. Does this feel the same as this?
Yes.
What about this to this?
Yes.
All right. Read these sentences to me, please.
You know how, down to earth, I got home from work near the table in the dining room. I heard him speak on the radio last night.
All right, and tell me what's happening in this picture.
The mom, it looks like she's washing plate. The sink is overflowing. It looks like her kids are behind her trying to steal a cookie from the cookie jar, and he looks like he's going to fall off a stool.
All right, and what objects do you see on this page?
Glove, cactus, key, chair, hammock, feather.
All right, and repeat after me. Say mama.
Mama.
Tip top.
Tip top.
50-50.
50-50.
Huckleberry.
Huckleberry.
Thanks.
Thanks.
Baseball player.
Baseball player.
All right, and close your eyes for me. Tell me if I'm touching you on the left, right, or both.
Left. Right. Both. Both.
All right, so NIH, 0, 1, 2, 3. Okay, 3 wins. All right. That's about all that we have for you guys. I just want to make sure that everybody went through the night. All right. All right. Wendy, do you have anything? Any questions from anybody? No? I think I'm waiting to hear if it's set up out there or not. She's looking to see if the reception is set up for you guys or not.
Yes, we are. Can you guys hear me? We are set up and we're ready to go. So thank you to everybody. This is a really great crowd. We've had a great day. Make sure to turn in your evaluations, leave us any feedback that you have, and hopefully we'll see you guys tomorrow. So enjoy. Thank you to also briefly, thank you to our speakers. You guys did a great job. We're thrilled to have you all. So.